Good morning, everyone. Good morning. Good morning. Good morning. Good morning. Hello, hello. Check, check, check. Audio full shot like. Check, 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 check.
A very good morning to you. Welcome all the delegates, faculties, chairpersons, and all. So let's start today's session. Yesterday, everything was discussed about the male partners, erectile dysfunction, premature ejaculations, and other related problems. So today, we'll start the session with something related to the female sexual disorders. So let's start our session with female orgasmic problems. So I welcome Dr. Neeraj Jadhav. I request Dr. Tia Jadhav to chair the session. Sir, kindly come on the dais. I request Dr. Sushma Bhairavkar ma'am to please come on the dais to chair the session. Dr. Tia Jadhav is an intensivist and also an anesthetist. He is currently working as the director and ICU in charge in the Shivam Hospital, Loni Kalpo. He is also working in Ruby Hall Clinic, Pune. Dr. Sushma Bhairavkar is senior gynecologist. She is practicing in the theory area near VishwaRaj Hospital. She is practicing obstetric and gynecology since 1980. I request chairperson to introduce the speaker, Dr. Neeraj Jadhav. Over to you, sir.
Good morning, everyone. Today's faculty for the lecture Recent Advances in Sexual Medicine is Dr. Neeraj Jadhav. He is consultant obstetrician gynecologist from Rajkot. Chairperson, Sexual Medicine Committee, HOD GSI 2022-2023. Winner Best Committee of HOD GSI Award 2023. Past President Rajkot Menopause Society 2022. West Zone Coordinator HOD GSI Adolescent Committee 2016-2019. Joint Secretary Rajkot Obstetrician Gynec Society 2011-2013.
It's fine, sir. No need to read.
Okay.
Yeah, it's okay, sir.
Okay.
So, thank you, sir, for your kind introduction. And at the outset, I would like to thank VishwaRaj Hospitals and the whole organizing team for inviting me. It's great pleasure as a gynecologist to be among so many stalwart of the sexual medicine committee and to talk about the sexual medicine. In Foxy, we as a sexual medicine committee has a trying to motivate and encourage our gynecologists to take up the sexual medicine as a to take more interest in the sexual medicine, because we as a gynecologist can contribute significantly in improving the sexual health of our women. So on that note, I will start my talk. So I am going to talk about the female orgasmic disorder or female orgasmic dysfunction. So what is orgasm? Orgasm is from the Greek word that is a excitement or swelling, or it's also known as a sexual climax. In Malayalam, there is a very much beautiful word for the orgasm, that is madhumurcha, that is for the orgasm. It is a sudden discharge of accumulated sexual excitement during the sexual response cycle, resulting in the rhythmic muscular contraction in the pelvic region, characterized by the immense sexual pleasure. A picking of the sexual pleasure with release of the sexual tension and the rhythmic contraction of the perineal muscles and the reproductive organ. In the female, there are contractions not always subjectively experienced by as such on the wall of the outer third of the vagina, but in both genders, the anal sphincter rhythmically contract. Orgasm is a highly subjective phenomena experienced in a very different way in both the across the individual as well as on different occasions by the same individuals. Various descriptions of the orgasm, like altered consciousness, multiple physical changing, highly focused on the genital sensation are there. And there are striking similarity also between both the gender. There is now good evidence that many women require clitoral stimulation to reach their orgasm. When we have seen that or what happens during the female orgasm, so I'm skipping that. According to Master and Johnson, there are 4 phases in the sexual response cycle. That is excitement, plateau, orgasm, and the resolution. While Kaplan divided into 3 phases, that is desire, excitement, and the orgasm. Excitement: when woman is stimulated physically or psychologically, the blood vessels within her genitalia dilate. Increased blood supply causes the vulva to swell and fluid to pass through the vaginal wall, making the vulva hyperemic, swollen, and wet. Internally, the vault of the vagina also expands. Heart rate and the breathing quickens and the blood pressure increases. Blood vessels dilatation can lead to women appearing flushed, particularly on the neck and the chest. During the plateau phase, as the blood flow to the intrauterus reaches its limit, it's become firm. Breast can increase in size by as much as 25%. The clitoral pulls back against the pubic bones and it seemingly disappears. While during orgasmic phase, the genital muscles, including the uterus and the introitus, experience rhythmic contractions around 0.8 seconds apart. The female orgasm typically lasts longer than the male at an average around of 15 to 31 seconds. Unlike men, most women do not have a refractory period and so can have a further orgasm if they are stimulated again. And in the end, there is a plateau phase. But nowadays there is a this model is basically more popular or more convincing about the female sexual response cycle. That is the basin model, where it is a circular model because woman can be enter into the sexual activity from any phase. It's not necessary that they start from the phase 1 and end in the phase last phase. The high importance that the science society places on the sex, combined with our incomplete knowledge of the orgasm, has led to a number of common misconceptions. Sexual culture has placed the orgasm on a pedestal, often prizing it as an on and only goal for the sexual encounter. However, orgasms are not as simple and not as common as many people would suggest. It is estimated that around 10 to 15% of women never had an orgasm. Research has shown that orgasms are not widely considered to be most important aspect of the sexual experience. One study reported that many women find their most satisfying sexual experience involves a feeling of being connected to someone else rather than the being their only goal about the orgasm. Orgasm have multiple potential benefits due to hormones and other chemicals that are released by the body during orgasm. Orgasm do not only occur during the sexual stimulation. And there is another word, that is a fake orgasm. A fake orgasm occurs when a person pretends to have an orgasm without actually experiencing one. It usually involves simulating or acting out behavior typically associated with the orgasm. It's like one type of relationship maintenance strategy. Then there is another word, that is the orgasmic gap. Not to achieve orgasm simultaneously, most commonly due to unawareness about the sexuality of the female. Why does the orgasm gap exist? Well, there are many reasons. A major one has been cultural ignorance about the anatomy of the female. Many people with vaginas don't have orgasm by vaginal penetration, but they can achieve orgasm by the clitoral stimulation. And foreplay also matters. In the partner relationship, it is also important for partner to understand that taking their time to explore their partner's bodies and wants and needs can also be significantly help to closing this orgasm gap. Now coming to the physiology of orgasm, orgasm is more than a simple reflex. Orgasm can be induced by stimulating in a variety of genital as well as non-genital sites. We have seen this physical changes what happens, and now let's see if lack of orgasm is something to concern about. A lack of orgasm is not a problem in and of itself. If one can enjoy sexual experience and is not bothered by the frequency or intensity of your orgasm, there is no cause for the concern. On the other hand, if lack of orgasm or decline in the orgasm intensity or frequency is causing distress, it may be a good idea to bring up the matter with the health provider. Unfortunately, there is a documented disparity in the frequency of orgasm between the heterosexual men and the heterosexual women, with men achieving orgasm more frequently during the partner sexual activity. This is we have seen that it is called as an orgasm gap. Now coming to the female orgasmic dysfunction, what's the definition says? It is characterized by persistent or recurrent distressing compromise of the orgasm frequency, intensity, timing, and or pleasure associated with the sexual activity. It should be present for more than 6 months. Frequency, orgasm occur with a decreased frequency or it is absent. When intensity, orgasm occur with the less intensity. Timing, orgasm occur too late or too soon. And pleasure, orgasm occur with the absent or decreased pleasure. So coming to the prevalence part, reportedly prevalence rate of the female orgasmic problem in women varies widely. It's around 10 to 42% depending upon the multiple factors like age, culture, duration, severity of the symptoms. However, this estimate do not take into account the presence of the distress. Only a proportion of women experiencing orgasm difficulty also report the associated distress. Variation in how symptoms are assessed also influence the prevalence rate. So approximately around 10% of the women do not experience orgasm throughout their lifetime. And dysfunction, it can be either lifelong or acquired, or it can be generalized or situational. Risk factor, it can be either organic, psychological, or other causes. Organic causes, it can be either neurological disorder, endocrine or metabolic disorder, or it can be due to drugs. Then neurological disorder affecting the spinal cord also can lead to orgasmic disorder. Then neurological disorder that causes injuries to the peripheral nerve. So many causes are there. It can also lead to the orgasmic disorder. And surgical injuries to the spinal cord and the peripheral nerves can lead to it. And traumatic injury to the spinal cord and peripheral nerves can be responsible factor. Then there are several endocrine and metabolic disorder like testosterone deficiency, thyroid deficiency, adrenal disease. All can have a effect on the orgasm. Then there are certain drugs which can affect the orgasm. Then there are personal and psychological factors like past sexual or emotional abuse, lack of knowledge about the sexual stimulation or interaction, poor body image, guilt or embarrassment about the sex, cultural or religious belief about sex, stress such as financial problems, mental health condition, all can lead to the orgasmic problem. Then there are relationship factors like lack of emotional intimacy, unresolved conflict, poor communication about the sexual needs and preferences, infidelity or breach of trust, intimate partner violence, partner sexual dysfunction can also lead to orgasmic problem. Then most important is the common sense. Sometimes orgasmic disorder can be a result of the insufficient stimulation or lack of communication between partners about what feels good during sex. In these cases, exploring the sexual interest and then discussing your preference with the partner could be beneficial. Coming to the evaluation part, detailed sexual history from both the partner, physical examination of both the partner, and laboratory investigation, and in the end, psychiatric evaluation. The sexual history, following questions should be asked during the sexual history initiation. Who initiate? Is this her preferences? Frequency of the coitus? Is the type and amount of the genital stimulation adequate for her? Is lubrication is adequate and satisfactory for the intercourse? Length and time of the intercourse? Ability to achieve orgasm? Difficulty? Is he distressed by not having orgasm? Does she experience any pain or any other distraction in her mind? We have to inquire about all these factors. Then there are various scores available, but in our day-to-day practice, they are not that much useful. For research purpose, definitely we can have that questionnaire. Then investigation, CBC, thyroid and prolactin, blood sugar, testosterone level and estrogen level. Then we have to assess as a couple, both the male and female, about the various sexual aspect, and we have to make that chart. And during physical examination, general physical examination of the overall appearance, systemic examination, then in breast, check for the lumps, retraction of the nipple or axillary lymph node, check local about labia, perineum, introitus. And there are some special indications like buccal smear, now conduction studies, but they are not for daily use. In some special cases, you can go for that investigation. Coming to the therapeutic option, we have this all can be part of our management strategy: sex counseling, supportive psychotherapy, sex therapy, marital therapy, behavioral modification therapy. There are clitoral devices, vibrators and dildos, and certain drugs, and in the end, phytochemicals. First off, we have to do the counseling with the implicit model or any other model which you are comfortable with. The implicit model, it is permission, limited information, and specific suggestion, and in the end, intensive therapy. I'm not going to in detail because we have so many other lined up. So, coming to the management strategies, lifestyle changes and therapy. Education is the most important about the female sexual anatomy and how different parts of the anatomy respond to the simulation. We have to teach to the female as well as to the couple about this anatomical aspect. Then directed masturbation is the most important part in the management of the orgasmic disorder. Directed masturbation training is largely behavioral training, usually conducted for 4 to 16 weeks therapy session. It involves graded exposure to genital stimulation, may include role playing, orgasm response, use of the sexual fantasy or vibrator to facilitate the heightened arousal and orgasm. It has shown well-established efficacy when administered in a variety of modalities like group, individual, couple therapy, or bibliotherapy. The success rate of the DM training in women with the primary anorgasmia are generally high. It is around 60 to 90% of in women become orgasmic with the masturbation alone, or in 30 to 85% cases, it will become she will become orgasmic with the partner sexual activity. Then comes the sunset focus therapy. The first comprehensive treatment program for the sexual dysfunction was developed by Master and Johnson, we all know. It consists of the graded exposure to non-sexual to sexual touching, to acquaint sexual pleasure with trust and effective communication between the couple. It reduces distractions and spectating by increasing attention to the pleasurable sexual and sensual sensation during the partner sexual activity. The same treatment strategy we are used for the all-female sexual dysfunction. Principle of the technique are non-goal-oriented physical intimacy, take the pressure of the performance and achieving orgasm. It focuses on the sensation of touching your partner, exploring the sensual touching beyond the genitalia, and discovering whether aspect of intimacy bring up any feeling of discomfort. Then there are change in the sexual position. Some changes in the sexual position may increase stimulation of the clitoris during the vaginal penetration and may have a better orgasm. Sexual enhancement devices are available. Devices that enhance the sexual stimulation may assist you in having an orgasm. These include vibrators and air pulsating device that stimulate the clitoris. Another devices that is held over the clitoris create a mild suction to increase the blood flow, and use them alone to understand what works for self, and then trying this device with the partner. Then cognitive behavioral therapy, individual or couple therapy may help. Therapy can help with the behavior that may promote the good sexual relationship or communicate our needs during the sex with the partner. Then there are medical treatment, testosterone therapy for some postmenopausal women who have testosterone level lower than what is considered typical for women. Testosterone replacement may improve the arousal and orgasm. But we all know side effects like acne, excess body hair, decline in the HDL or good cholesterol, and risk similar to the estrogen replacement therapy. Then there is the estrogen. Estrogen is systemic estrogen is taken as a pill, skin patches, gel, or spray. because it affects the whole body. It has some health risks, we all know. Then there are typical topical estrogen available, which usually we use doses 0.5 to 2 gram per day, and minimum dose for the shortest interval we have to use, and it can be given for 21 days followed by 7 days free interval. Then there is another molecule, that is tibolin, is also useful in this age group, that is postmenopausal age group. Beneficial effect on the climateric symptoms and the sexual function of the postmenopausal woman. Advantage over conventional HRT because there is a less risk of the side effect, and but there is a one risk of the stroke. Then there is a DHEA, is a hormone produced naturally by the adrenal gland, because it is converted into testosterone. It may be useful in this age group which having orgasmic problem. Then there are medical devices where we seen there is a vibrator and the clitoral device. This is the picture of the clitoral devices. Then sex therapy. Strategy is to have an orgasm alone, that is by masturbation, then orgasm with the partner by the clitoral stimulation, and ultimately orgasm with the intercourse. This is the basic strategy of the therapy. Then there are treatment approach with the aesthetic gynecology is coming up nowadays, and there are so many advances in the management like PRP, fillers, laser therapy is there. PRP improves the vulval appearance, improves the sexual life. It is a PRP, we all know it is a platelet-rich plasma. It is injected in from the patient's own blood. It releases growth factor which stimulate skin cell to produce more collagen and elastin. We all know about the O-sort and the G-sort. I'm few lines about the O-sort. O-sort is a controversial rejuvenation procedure in which PRP is injected into clitoris and in the upper vaginal wall. PRP is usually derived from the fresh blood of the patient, a minimally invasive means of improving sexual gratification and urinary incontinence. Also, participants' purpose is that using patient's PRP stimulates stem cell to grow the healthy vaginal tissue. There are some studies also showing it's very effective when it comes to the orgasmic difficulty or oral female sexual problem. Then there is a one more, only a few slides. Gore mycomesh, it was used in 2015 by Park. They inserted under local anesthesia a 2.4 centimeter mesh under the posterior vaginal submucosa. Results showed that the substantial improvement in the sexual function. Then there are silicone threads is also available. Now it is been tried. They made incision at 3 and 9 o'clock positions and found that the FSFI significantly improved after the using this. Then there is a laser available which rejuvenates the vagina and improves the orgasm. So, education and insurance that the ability to orgasm during intercourse is not abnormal may be the key issue that may help women find their sexual pleasure and satisfaction. Only women who are distressed by the problem and acknowledge that they are in charge of their own orgasm and thus responsible for their pleasure and satisfaction need help and direction. Every woman is unique, has different sexual experience and expectations, and respond differently to different stimuli. When addressing the issue with the patient, often simple permission to address the issue and education of the topic is enough to direct the patient. Only few patients need professional sexual counseling or sex therapy. So this is one, if I can, so only 2-minute video is there. It's on funny note, I will like to end my talk. It's not trying, no problem. So thank you for your patient hearing. चलेगा हो सके थोड़ा कर दो
Thank you, Dr. Neeraj Jadhav, for such an excellent lecture on recent advances in sexual medicine. Now, I want to ask delegate if you have any questions, you can ask Dr. Neeraj Jadhav.
Sir,
Yes.
how many times male partner comes with you with the same problem of the female?
For which problem? Orgasmic problem?
For orgasmic female problem, how many times
No,
male
no.
partner
Usually,
comes to report you?
yeah. Usually, husband comes with the only problem that they having low desire. They never come with the complaint that they are not having achieving orgasm. And in particularly in our cultural thing that women also are not that much bothered about their orgasm. Yes. Sir.
Yes. What about DHEA? Can
Yes.
is it approved drug or off label?
No, it is off-label drug. Yes.
Did you given any patient DHEA for?
Yeah, we many times we give and it somehow helps, but it is not FDA approved drug. And in Western countries there are DHEA gel available, but we are not having that gel. Think it is a better option if we use the DHEA gel, but it is not available here.
But in my practice, DHEA is better
Yes.
for orgasm as
Yes,
well
yes.
as this.
Yes, because it converted basically into testosterone. So yeah.
I don't use testosterone because of it can.
Yes, yes.
DHEA
Yeah.
is not having more adverse effects.
Yes, yes.
If there are no queries, then we can conclude the session.
Thank you, Jadhav sir. It was an awesome lecture, right from the basics to all the fundamentals. I would now like to call upon Dr. Namdev Jagtap, consultant physician at VishwaRaj Hospital, to felicitate our speaker and the chairpersons. I request Dr. Namdev Jagtap to felicitate our chairperson. Ma'am, please come on the dais. Dr. Sushma Varaukar, ma'am, please come on the dais.
वो वहाँ से कर रहा है.
Suppose you are out on a trip.
I would like to introduce Mr. Dr. Pramod Kumar Surve for the lecture for his recent advances in sexual medicine, and everything is displayed on the screen, I think. Yes. Sorry, by mistake.
Suppose you are on a trip alone, or sometimes you are a couple. And if you get a chance to meet someone else, a male partner with a female or a female partner with a male, something surprising, something like that, what will you do? Have you thought of? Our next topic is that surprising. The topic is sex in a surprising place. So chairpersons are there. I request the chairperson to introduce the speaker.
I would like to introduce Dr. Shirish Malade, consultant in sexual medicine and male infertility. Everything is displayed on the screen, so please continue, sir.
Good morning, all. So, Dhangar sir has given me a little challenging job today, and he has asked me to put a tadka in our regular and routine rasoi. And he has requested me to take this topic describing a specific event where you don't expect two persons to indulge into intimacy, and to all your surprise, they were into a deep intimacy. So this is the seed which came into his mind, and today I am here to just water it to some extent so that this idea can go further and we will have some meaningful take-home message. Sex in surprising places. What thoughts came into your mind looking at the title of the topic? Neeraj sir? Okay. So MIT campus and Raj Kapoor का बगल में जो म्यूजियम है, with Jinnat Aman and Mandakini के पोज के साथ, that can tempt you. Yes. Anything else? We all are by default polygamous, but our culture, our law is restricting us to be a monogamous. Very candid confession, Varghese sir, and I am sure such confession can come only from a Keralite. Still you dare to comment. Correct. So the couple of pictures on the slide itself is telling you that these are unusual places. First you see the dancing car, and second you see hiking tent, in which a couple is engaged into it. So today's jest is, it's not moving for me. It's not only surprising places, but I have added, Sanjay sir, Dhangar sir, I have added surprising partners, surprising orientations. You may not think of something कि ये ऐसा भी हो सकता है. Surprising arousal pattern. Each and every individual, if you sometimes go into detail of their history, you will see that a person gets sexual arousal by a particular thing only. No matter all other stimulations may be there, but unless he sees a nice buttocks of a woman, the person cannot get aroused. There are men who are, what sometimes we label them as a fetish objects. The fetish object. The ponytail can be arousal object for so many people. And finally, surprising practices. What kind of, imagination, the sky is the limit. Whatever practices that you can indulge it in. Yes. So the big question comes, monogamous, polygamous, if given opportunity, in the childhood we have heard something like virginity. People is creating a lot of hue and hype about virginity. So we used to tell that virginity in a person is due to lack of opportunity. Given a choice, no one will remain virgin if he has enough courage to break the law, and if he finds a suitable person where he or she thinks that it is worth to break the law with this person. जॉन अब्राहम मिल जाए मुझे तो मैं कुछ भी करने को तैयार हूँ. You hear so many fans of the celebrities. Justin Bieber के celebrities, they get orgasm just by hearing in concert. Both sexes. So sex itself is not a moral category. What is right or wrong? If you see scientifically, sex is just a biological act. Although it places us in relations in which moral conditions do apply. Of late, if you have seen on Facebook and so many other, there was one channel, Ullu. Ullu app is also there, where you see this Ekta Kapoor ka production house is making the Indian soft porn, where they depict a story. And Dhangar sir, you will be surprised, वो स्टोरी में पार्टनर्स कौन होते हैं? बेटा लॉन्ग डिस्टेंस जॉब पे गया है, घर में ससुर और बहू अकेले हैं, उनका स्टोरी बनाते हैं. टीचर एंड स्टूडेंट का स्टोरी बनाते हैं. घर पे सेल्समैन आया, कुरियर बॉय आया, और वो लड़की कपड़े चेंज करती रहती है, कुरियर बॉय उसको देखता है. दिस थिंग्स they are coming up with. So all these things, if you see, the moral consideration do apply, and in view of the social norms and legal norms, this you will be labeled कि ये गंदा है, ये सही नहीं है, ये अच्छा नहीं है, और ये इलीगल है, और ये सोसाइटी का टेक्सचर को गंदा करता है, खराब करता है. These all things come because of its moral consideration. But biologically speaking, we recognize sex as only it's a biological act. In which cases these things will apply? Pre-marriage sex. Nowadays people say कि it's very common. No one waits till marriage and intimacy. And you will be surprised that on an average, the average Indian young person's age to enter into sexual relationship, what do you think? Kitna hoga for boys or girls? At what time they enter into the average? You know, the national surveys, the figures are out. You may be thinking 20 years, 21 years, 18 years. It's somewhere close to 15 and 16 years for both male and women. Extra-marriage sex, temptations. Then sexual activities of single persons. You know, they are by norms or by society, they are sexually starved group, you can say, because the partner is either not available in case of unmarried persons, divorcee, they are single, widower, both male and female, their partner have passed away. People in long distance relationship, husband has gone to US, 8 months कंपनी ने भेजा है उसको H1 वीज़ा पे, H1 डिपेंडेंट वीज़ा नहीं मिला, so wife is compelled to stay back here. Partner having chronic diseases, paraplegia हो गया husband को, what wife is supposed to do? Chronic conditions, chronic tuberculosis, or any conditions which is compelling bedridden, एक partner bedridden है and the other person is absolutely fit and healthy. Partners having unstable mental health. Now you are too much troubled by the spouse who is not having a very stable mind, and whenever you approach her or she approaches husband, they deny, नहीं आज नहीं, आज मूड नहीं, आज सर दुख रहा है, आज अष्टमी है, आज पूर्णिमा है, आज मेरा व्रत है. हाँ, एक सोशल मीडिया पे अच्छा जोक बनता है कि हस्बैंड लोग बैंकॉक क्यों जाते हैं, साल में 365 डेज, उसमें 12 पूर्णिमा, 12 अमावस्या, ये सब कैलकुलेट करते 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 लास्ट में 30 डेज ही बचते हैं जहाँ हस्बैंड को कंसेंट मिलता है सेक्स करने के. व्हाट हस्बैंड इज सपोज टू डू? Loss of sexual desire in one partner. I am no longer interested. You know, after 1 or 2 child, many women in their 30s or 40s, they lose total interest. They get so much engrossed in child rearing, child को बड़ा करने में, घर संभालने में, and they are totally, they lose interest in sexual activity. And finally, incompatible couple, झगड़ते हैं, लड़ते हैं, झगड़ते हैं, हर चीज़ पे they have differences. So the moment they enter into the bedroom, कुछ ना कुछ बात याद आती है, झगड़ा शुरू हो जाता है और सेक्स एक कोने में चला जाता है. एंड फाइनली वन नाइट स्टैंड वर्सेस रेगुलर रिलेशनशिप. धनगर सर ने जो सीट दिया था, सेम थिंग कि अचानक आप सफ़र में हैं एंड यू फाइंड समथिंग सो अट्रैक्टिव, सो नाइस पर्सन, एंड यू फॉल इनटू वन नाइट स्टैंड. देयर इज़ नो कमिटमेंट, देयर इज़ नो एक्सचेंज ऑफ मे बी इवन कॉन्टैक्ट डिटेल्स ऑल्सो. दिस इज हैपनिंग वेरी वेरी कॉमनली. हमें दिखता नहीं है, इसका मतलब ये नहीं कि ये नहीं हो रहा. Between legitimate couple also, between the married couple or the couple whom we consider as legitimate, why surprise sex gives more pleasure than the routine sex? Because breaking law gives you a small thrill. There are many people वो हेलमेट नहीं पहनना है था मेरे को टू व्हीलर पे. ऐसा नहीं है कि उनके पास हेलमेट नहीं है, ऐसा नहीं है कि उनको तकलीफ़ होती है, लेकिन लॉ है ना तो उसको तोड़ने में मुझे मज़ा आता है. अगर ट्रैफिक हवालदार नहीं है तो मैं तो हेलमेट नीचे ही एक्टिवा पे रख के चलता हूँ. ओनली इफ आई सी और इफ आई स्पॉट ट्रैफिक हवालदार मैं उठा के सर पे डालता हूँ. वाई पीपल हैव दिस टेंडेंसी टू ब्रेक लॉ. विदाउट टिकट एक बार ट्रेन में जाने में बहुत मज़ा आता है. टीसी एकदम यहाँ खड़ा था और मैं पास से निकल गया, उसने मेरे को टिकट के बारे में पूछा भी नहीं. एंड दिस फेलो फाइंड समटाइम्स थ्रिल, यार विदाउट टिकट मैंने ट्रैवल कर लिया. सो इंडल्जिंग इनटू अल्कोहल, फॉर मैनी ऑफ अस स्टिल इन द सोसाइटी, अल्कोहल नहीं लेना चाहिए, खास करके फीमेल्स को. मेल लेता है तो एक बार चलता है, लेकिन फीमेल्स अगर अल्कोहल लेते हैं तो फीमेल्स themselves feel so happy and elated. Not that alcohol gives them pleasure. It is that breaking the stereotype gives them the pleasure. You see the kitty parties of most urban places nowadays. You know, they take a huge pleasure and fun by breaking these minor laws. indulging into drugs and narcotics, same way, or indulging into anal and oral sex. एक कपल तो ये करता ही नहीं है. Anal और oral sex exists only in pornography. Anal and oral sex is existing only in a very forward, जो हमारे मुंबई में सोवो कल्चर कहते हैं, साउथ बॉम्बे कल्चर. हाँ, मतलब जो कोलाबा, नरीमान पॉइंट, वो एरिया में रहने वाले सोवो कल्चर में ये होता है, हर जगह नहीं होता है. सो इफ दे इंडल्ज इनटू ओरल सेक्स समटाइम्स, इट्स अ ग्रेट अचीवमेंट बाय देम, ग्रेट प्लेजर. अरे हमने ये कर लिया. एक्चुअली ये करना नहीं चाहिए, गंदा होता है, बट हमने कर लिया. पब्लिक प्लेसेस may not be actual sexual intercourse, but just kissing, goodbye kiss अगर कर लिया. यंग कपल करता है in 20s, hugging and kissing and saying goodbye is now common. कोई भी रेलवे स्टेशन पे देखो, एयरपोर्ट पे देखो, common. But have you ever spotted a 55-60-year-old couple indulging into goodbye kiss or some very passionate hug? Never. But if someone does, gives them a thrill. Sexual performance enhancers use करके, you know, on very, you will get a request in your clinic. डॉक्टर अभी कल हमारा 7th एनिवर्सरी है, हम लोग ना वो रिसोर्ट एक बुक किए हैं, 2 दिन के लिए वहाँ जाने वाले हैं. तो कुछ ऐसा सजेस्ट करो, कुछ ऐसा मेडिसिन दो कि वो 2 दिन बहुत अच्छा हमारा निकलेगा. सो दे वांट टू एनहांस देयर परफॉर्मेंस ओनली फॉर दिस 2 days. Use of sexual aids, that is toys, sexual toys, you know, that also gives them pleasure, and using these toys for male as well as for female, both the sexes. Murugan sir, I am always equal to both the sexes. And unusual places and timing. घर पे bedroom is supposed to be the place to have sexual relationship. घर पे एक बार कोई नहीं है, मॉर्निंग में ड्राइंग रूम में सोफे पे अगर सेक्स कर लिया सुबह 7 बजे या 9 बजे, 12 बजे, yes. Yeah, but you have to see the dining table's legs are very firm and stable. Sometimes bathroom, you know, go to bathroom, have shower together, and there you get aroused, and on the floor or in your bathroom you can get into the sexual activity when shower is still on our body. Unusual timings, places तो बोले, but timings also. Normally most couples at bed time होता है या अर्ली मॉर्निंग में उन लोग का एक टाइम फिक्स होता है. बट अनयूजुअल टाइमिंग में करना भी एक ब्रेकिंग द स्टीरियोटाइप और ब्रेकिंग मोनोटोनी है. एंड फाइनली रोल प्ले. Husband and wife, sometimes many couples, just to get a kick or to get a proper arousal, they may say today we will have role play. मैं बॉस बनता हूँ, तू मेरी सेक्रेटरी कर. So as a boss, what I am supposed to give you the instructions. You do this, you do that, and finally you have to obey everything that I want. So this is how they sometimes have role play. Sometimes थोड़ा सा हटके, many of them they have role play like teacher student. These are just examples, but such couples can be anyone. Sorry? There are many, sir. These are just 2 examples I have written. Yes, doctor and nurse. Boss secretary बोला तो immediately इनको डॉक्टर नर्स आ गया. And finally, once you are a single trip, जैसे places like गोवा में आप गए हैं, गोवा थोड़ा बदनाम है ड्रग्स के लिए, सेक्स के लिए इतना अपॉर्चुनिटी नहीं है, मैं बताता हूँ, बिकॉज आई विजिट गोवा एवरी मंथ. सो इफ़ यू थिंक कि हमें बैंकॉक जैसा माहौल मिलेगा तो यू विल बी ग्रेटली डिसअपॉइंटेड इन गोवा, बिकॉज गोवा में कमर्शियल सेक्स वर्कर अवेलेबिलिटी इज़ वेरी पुअर. वहाँ का कल्चर है कि आप खुद ही साथ में लेकर आए. सो they also have some rules that they serve the needy, not greedy. But nowadays the greed has increased. You know, even if you have one legitimate partner, you are married, but given an opportunity, if you find some, if you have crush on something, and people get encash the crush. Surprising places. Now both of you will have a lot of options. Huh? Office table. It can turn into workplace harassment. Beware. Huh? Most men who are tempted, to have some kind of affair in the office, beware that nowadays when the relationship will take a turn, when the relationship becomes sour, you will be taken to task for workplace harassment. For 4 years, there was a good relation between co-workers, but when relationship turns sour, they can easily say that for 4 years you raped us. Because there is a very thin line between rape and consensual sex. Beach and sea, this is most common fantasy many people have. Beach पे चांदनी रात में हम अगर सेक्स कर रहे हैं. Dancing car we already talked about. Swimming pool में. Most people in the tourist places, you have the small pools, and you see many couples are getting intimate there, and their idea or the fantasy is to actually have intercourse if they find a good privacy there. Under open sky, farms, उसाच्या मळ्यात famous आहे ना Maharashtra. Ous is supposed to be a very good crop which gives enough privacy. 8 feet, 10 feet का ऊस will give you adequate privacy. उसमें थोड़ा जगह बनाओ, मस्त बेड बनाओ, and Karad, Sangli is belt is known for उसाच्या मळा. So farms under terraces. Now many places will start coming up. And ऊस आणि सेक्स टूरिज्म में पिकअप. लेकिन ये चीज है कि जो चने के खेत में नहीं हो सकती है. And open grounds, crowded local trains. You will be surprised, not penetrative sex, but there are many people who find the same sex orientation वाले लोगों को partner मिल जाते हैं मुंबई local train. If there is a too much crowded, you are squeezed between two. The people easily touch each other's genital. They mutually masturbate also, and by eye movement or by the visual contact and messaging, they find the same-sex partners. Long distance trains or buses, particularly with the sleeper berths. Nowadays the 3-tier AC, 2-tier AC, the curtains have been removed by Indian Railways after COVID breakout. They said that minimum the linen should be there on the train. But earlier there used to be curtain, and there were many couples who were indulging into sexual activity in train, running train. राजधानी चल रही है 120 की स्पीड पे, और यहाँ सेक्सुअल एक्सप्रेस भी 240 की स्पीड पे चलती है. Sometimes in toilets, running train, you find a very tempting person. लेकिन रनिंग ट्रेन में कहाँ ऑप्शन मिलेगा आपको. एक पर्सन जाता है टॉयलेट में, दूसरा पर्सन 2 मिनट के बाद चुपके से टॉयलेट में घुस जाता है. जब वी मेट. Changing rooms of clubs, sports complex. These are also some areas where very frequently IPL में सुना है, and those who have seen one web series, कौन सा था वो, नाम भूल गया. There were 3 seasons into it. So they have shown it कि changing room में कैसे hot sex होता है before inning and after inning. Shower room, bathroom is common. Kitchen, drawing room, sir, drawing आपका dining table. Hospital rooms, not necessarily between doctor and nurses, but patient and nurse also. It is common. It is common, and you will see many stories, such things. Staircase of a building. Nowadays most buildings have elevators, lifts. So staircase are just fire exit. वो ज़्यादा यूज़ नहीं होता है, कोई उसमें आता जाता नहीं है, तो people को अच्छा प्राइवेसी मौका मिल जाता है. Movie theaters. Young couples, they go to movie not to watch movie, but to enjoy intimacy. डार्कनेस में कॉर्नर वाला सीट, बॉक्स सीट वगैरह होता है. एंड नाउ डेज PVR आई हर्ड that they are giving a full cot also, two sleeper berths. So what they expect you to see movie? No, to create movie. And finally, lockup, jails are also known to have intimate relationship. So finally, take home message from this conference, this August gathering is, as a sexologist, as a practitioner of sexual medicine, we should not be judgmental for the person's sexual practices. You will see the masturbation, you will say yuck. I have heard and I have seen a girl who used to put live cockroach in the vagina. Cockroach goes into the vagina, gives the crawling sensation. Another girl, they put धागा होता है ना, सिलाई का धागा, सिलाई का धागे का रील इंसर्ट करते हैं वजाइना में, एंड देन दे पुल आउट द धागा. सो धागा पूरा अनवाइंड होता है. सो अनवाइंडिंग द धागा गिव्स कांस्टेंट टच टू द इनर वजाइनल वॉल एंड दैट स्टिमुलेट्स. सो यू विल फाइंड अ very weird sexual practices, masturbatory, even sexual intercourse. Many times we also give them some idea, to steam up their sexual life. Put some ice cream or melted chocolate around the nipple and then leak around the even genital and then leak. So such ideas many people have, by their creative minds, have created such things. So as a sexual medicine practitioners, we are accepting all sexual practices between consenting couples, I would say. Preferences, their orientations, can be any, and their behaviors. But what we cannot accept or we should not promote or we cannot endorse is certain behaviors like pedophilia. Some may say, I get aroused only looking at a young girls of 7 years, 8 years, 10 years. So this is something you be alarmed, don't approve this act, and suggest them to go to a psychiatrist for such abnormal paraphilia. Other paraphilias, there are some paraphilias which are sort of innocence, like say transvestism. I like wearing girls' clothes. Oh, am I harming anyone else? I'm doing anything injustice to someone else? No. It's one of the innocent paraphilia. But exhibitionism, if I have, I know many rickshawalas, they just stand at the corner of the street, open the zip, and कोई लड़की आती है तो उसको sudden shock करने के लिए they open the trouser. So these paraphilias need alarming attention. And there are some paraphilias of inflicting pain. While having a passionate foreplay, they may bite very vigorously to the partner. Kama Sutra mein Vatsayana has suggested to use a nakha, danta, and some other organs also. So you bite very gently, ear pinas, the nape of the neck, nipples, breast, thighs, anything, back also. And you use the nakha also. You gently scratch them, which gives good arousal to the female partner. But when you are inflicting pain to the other partner to get arousal of self, so this is known as sadism and masochism, which are the two sides of the coin. So this sadistic behavior is supposed to be disapproved. Discomfort to others, breaching privacy of others, sending some unwanted nude posts and messages to the other person, thinking that ये भेज के मैं उसको पटा लेगा. This is also a crime also. It's a form of sexual harassment. And all other activities these are considered illegal by law. As a ethical medical practitioner in sexual medicine, you cannot approve their behaviors or this thing which is considered illegal by law. So with this I conclude and I stop here. Once again, those who were not present yesterday, a small reminder, And information to the freshies. In April, we will be having a national conference of sexology. We labeled this Tulip Conference because April, May, Tulip is the season where which has a blossom there. 13th and 14th April. For more information, you can get in connection with me. I will send you the brochure and other details, and all residential, non-residential packages I will be sharing with you. Thanks. जी हाँ, दिल क्या करे.
Thank you very much, sir. What an awesome lecture. So much of humorous. And everybody got the idea what illegal they can do legally. Thank you very much. I would like to call upon Dr. Sangram Gadge, cardiac anesthetist and ICU intensivist at VishwaRaj Hospital, to felicitate our speaker and chairperson. Dr. Shirish Malde, please come on the dais. I request Dr. Sangram Gadge to felicitate our chairpersons, Dr. T.R. sir. Dr. T.R. Jadhav sir, please. I request Dr. Sangram Gadge to felicitate our next chairperson, Dr. Sushma Vairokar. Thank you. So let's move on to the next learning session. Something related to the first topic that we discussed today. The next topic will be a penile and clitoral biothesiometry. The chairpersons for the next session, I would like to invite Dr. Namdev Jagtap, sir. He is consultant physician at the VishwaRaj Hospital. Dr. Anand Shinde. Dr. Anand Shinde is a senior consultant obstetric and gynecologist. I request the chairperson to introduce our next speaker, Dr. Ajay Varghese. Over to you, sir.
Good morning, all. Today we have a prominent speaker among us, Dr. Ajay Varghese. He is Director, Institute of Sexual and Reproductive Medicine, Kozhikode. The introduction is on the dais. Over to you, sir.
Before that, Good morning. I am Dr. Ajay Varghese. I thank the organizers for giving me an opportunity for presenting this topic. Before going to that, I want to introduce our association, International Association of Sexual Medicine Practitioners Modern Medicine. This is the only association of sexual medicine practitioners of modern medicine. No psychologists, doctors of alternate medicine are not allowed. That means only for MBBS and above doctors. Then we conduct conferences, annual conferences, workshops, hands-on training for sexual medicine practitioners, modern medicine. Then we have a strong WhatsApp group. Any doubts regarding academic matters can be cleared in that group. Then we issue a membership certificate. You can display this membership certificate in your clinics. Then IASMB is conducting membership campaign. Our membership is only rupees 6,000 and the annual subscription is 1,500. Those who are joining in this month, annual subscription will not be there. That means with the 6,000 rupees you can be the lifetime member of IASMBM. Now, actually what is happening in our sexual medicine practitioners? All urologist, it's a multidisciplinary subject. Urologist, gynecologist, dermatologist, psychiatrist, neurologist, endocrinologist, and general medicine physicians and surgeons. And almost all of the doctors are practicing sexual medicine. But are they practicing in the proper way? According to our concept, they are qualified quacks. Why I say qualified quacks? Sexual medicine is a multidisciplinary subject. Urologists do practice sexual medicine. If they are coming with suppose a patient comes with erectile dysfunction, they simply prescribe tadalafil or sildenafil. That means any PD5 inhibitors. And psychiatrists also practicing in the same way, but there is something difference in this practice. That means how urologists consider only the organic part, psychiatrists consider the other parts also. While doing the practice, a sexual medicine practitioner should know what the actual cause behind it is. It can be diabetic ED, it can be due to other drug-induced ED or any type of erectile dysfunction. No investigations, nothing, simply prescribing tadalafil or sildenafil or any other PD5 inhibitors is being a qualified quack. IASMB trains them how not to be a qualified quack. That means you have to do the investigations. Without doing any investigations, without taking the proper history, we will not know what the actual problem is. It may be psychological, it may be organic, but we have to clear it. Whether it is, we have to by investigation, by taking the proper history, we will come to know what kind of erectile dysfunction is it. And one more thing is, a urologist, famous urologist from our side, said the patient that I am prescribing a drug for you, but it is dangerous to your heart. It's a misconception. Then suppose he is prescribing a sildenafil or tadalafil, it is not dangerous to heart. Actually, it is pro. That means it helps the cardiac function also. But the patient thinks that a doctor is prescribing something dangerous drug to him for doing a sexual intercourse. This misconceptions should be corrected, and those who are interested in sexual medicine practice, they can become IASMBM member, and we will train you. We will hands-on training we are giving, annual conferences we are conducting. Our next conference is at Delhi on 2024 third week of the September. Those who are interested in being membership, application forms are available here. We will provide that application form. Now by this month you can join as IASMBM member with rupees 6,000 rupees lifetime membership. Then let us go to my topic. Yeah, penile and clitoral biothesmometry. This is a new equipment which by that means several experiments we have made this equipment. It is here in this table. Actually, biothesmometer we all know in neurological diabetic practice we all are using biothesmometer. The main disadvantage of that biothesmometer is the range is from 0 to 50. While doing penile biothesmometry, we are not able to do this test with the 0 to 50 hertz. It must be minimum 200. I have made a machine that is 0 to 500. Normally what happens, biothesmometers are made from different companies at different hertz and different frequencies, and someone are making it with the voltage also. That means their range is on voltage. It may be from 0 to 50 only. Then penile erection can be compared to a three-legged stool. One is vascular, other is hormonal, the third one is neuronal. If any one of this thing fails, erection will not take place. Then we do have investigations for vascular problems. Penile Doppler study can be done. Investigations for hormonal study, we can take blood, testosterone, prolactin, thyroid test, each and everything can be done. Investigations for neuronal problems, there, that means CT is there, MRI is there, nerve conduction study is there, but all these things are not so practical. That means suppose a patient comes, we are asking them to do CT or brain, they will run away from our clinic. Then penile sensory and motor neuron innervation heavily depend on adequate neurological health. In office electrophysiological tests that measure somatosensory evoked potentials are available to assess neurological capacity in men presenting with sexual dysfunction. Valuable, complex, costly and uncomfortable. Penile biothesmometry became increasingly popular in the early 1990s and showed promise as a rapid, office-based, non-invasive. This machine is non-invasive means of evaluating sensory capacity. Then, biothesmometry is used in diagnostic of peripheral neuropathies with impaired vibratory perception threshold, mainly in diabetology, neurology, and sexual medicine. All diabetologists are doing this biothesmometry to assess the neuronal condition. Then, the biothesmometry device consists of handheld probe that is connected to a stationary amplifier. One machine is there and another amplifier is there. Probe is there. Contains intensity dial and an analog frequency meter. Penile vibratory innervation is distinct from other somatic modalities such as pain, temperature, and proprioception. Vibration as a penile stimulus is positively correlated with the sexual response because the vibratory nerves travel with the nerves of penile sexual sensitivity. That is most important. Actually, we are testing the vibratory sense, but it travels, penile sensation travels with the same nerve. Biothesmometry allows for assessment of penile vibratory sensitivity. It has proposed as clinically useful means of assessing penile sexual sensitivity. The effectiveness of biothesmometry in detecting sensory neuropathy has not been fully established. This is in part due to a lack of standard units of measurement in the literature. whereas some studies use heads, which I have explained earlier, and others use vibratory detection, and voltage also is considered. Then furthermore, no definitive procedural protocol exists, which makes it difficult to compare the results across different studies and practices. Okay, a nerve conduction study, that means other than biothesmiometry, where small metal wires called electrodes are placed on the skin test, release tiny electric shocks to stimulate the nerves. This speed and strength of the nerve signal is measured, but it is invasive procedures. Some patients get pain during this shock also. Then electromyography, where small needle is inserted through the skin into muscle and used to measure the electrical activity of the muscle. This thing also painful. Then there was no consistent methodology for biothesmiometry due to difference in how biothesmiometry performed among contributors. That means one manufacturer makes with voltage, other manufacturer makes with hertz. Then is frequency. It has been difficult to develop a universal determinant of what constitutes normal biothesmiometry values and which values are cause for concern. Then PSR value. This Adam Wiggins and their colleagues made a PSR value, penile sensitivity ratio, introduced a novel biothesmiometry parameter. Here there is no hertz or no voltage or nothing, because of it is a unitless value parameter in effort to address these limitations, because the PSR is a ratio between vibrotactile thresholds and differing points of the body. Okay, the units cancel within the equation, resulting in an output that describes penile vibratory function, overcomes the validity of biothesmiometry to significant intra and inter-individual variability in vibrotactile thresholds, particularly between individuals within a single individual across time. They used vibrotactile thresholds at additional peripheral locations on the body, such as index finger in finalized PSR glance by finger equation, to establish an internal control and reduce the variability of measurements. And given that all patients undergoing biothesmiometry in their study cohort presented for evaluation of sexual dysfunction, including erectile dysfunction, Peyronie's disease, ejaculatory dysfunction, or penile sensitivity, the absolute value for the glans and finger should be considered when interpreting the PSR, because a particularly low value, that means if any other disease is there, low value of the index finger may artificially increase the PSR glans by finger. Then how to perform it? Turn off the biothesmiometer. This meter is available, I will be placing somewhere here, you can check it. Turn off the biothesmiometer, patient in a supine position, penis in the flaccid state, place the probe in contact with the volar part of the index finger, continue the probe skin contact at 90-degree angle. Then turn on the biothesmiometer, increase the vibratory frequency in a continuous fashion, record the frequency when patient verbalizes perception of stimuli. First value we got. Then increase the frequency and confirm that the signal intensity is perceived as getting stronger. Then reduce the frequency progressively until the patient once again verbalizes no perception of the stimuli. This record the second value. Calculate the mean of these two values, that is up value and down value, divided by 2. Then continue the process for the right finger, left finger, and this thing, ventral and dorsal area of the glands, left and right and middle penile shaft, left and right inner mid thigh. The picture is very clear. Okay. Then components of 3 biothesmiometry data are converted into 3 iterations of the PSR. PSR glance by finger, you can see mean glance left and right, and PSR glance shaft by finger, PSR glance shaft and finger and thigh. These are the 3 iterations. Then healthy PSR values. Men with no sensory complaints have a threshold vibratory detection of the index finger 6 to 8, whereas glands 8 to 10. The glands by finger would be therefore in the range of 1.3 to 1.7. Below 1.3 and above 1.7, some neuronal disorder is there. Then PSR GSF glands by finger glands and shaft by finger is 1.7. PSR glands shaft by finger and thigh is 0.7. Glands threshold is 12. Index finger is 10. Video. How to play the video. You can see the video how I am performing it. Coming back to the where? This thing. Clitoral biothism. Clitoral biothismiometry. Clitoral biothismiometry is a diagnostic as well as therapeutic equipment. Low sexual desire for low sexual desire, sexual arousal disorder, orgasmic disorder can be diagnosed and treated by clitoral biothismiometer. Dr. Neeraj Yadav was explaining some points about neuronal. Then, genital tactile stimulation is regarded as the precursor to sexual arousal and a recognized initiator for central nervous system arousal. Pathways. Specific afferent neural pathways transmit sensory stimuli of arousal beginning at the epithelial level on the clitoris and following the course of arousal stimuli through the central nervous system. Limited knowledge exists of the pathway from the cutaneous receptors of the nerves originating in the epithelial tissue of the clitoris and continuing to the spinal cord afferents. Then, we have two iterations. Pressure point, place the probe in contact with the clitoris, increase the vibratory frequency in a continuous fashion, record the frequency when the patient verbalizes the perception of the stimuli as pressure. Then intolerance, increase the frequency. While increasing the vibratory frequency in a continuous fashion, record the frequency when patient cannot tolerate the stimuli. So we have two iterations. Then, what is the normal value of the pressure point and intolerance point? Is it age related? Which conditions and diseases affect these points? How does it affect the different phases of menstrual period and menopause? To find normal value, we have to conduct a study with the normal subjects. So far, no study is conducted. How to overcome practical difficulties? Volunteers are required. See, in my practice, I do check these things, but I cannot say this particular value is valuable for all patients because of in the population, because of I am getting patients only, not the volunteers. Then only we can assess this is the value. And for this purpose, we need a ethics committee and we have to conduct the study, all these things. It is very difficult procedure. Then, causes of FSD are diverse and overlapping. Organic elements such as hormonal, neurological, vascular issues are there. Psychological factors such as relationship issues, social stresses, mood, history of physical or sexual abuse, and psychiatric history. Then etiologies include imbalance of neurotransmitters such as dopamine for desire and epinephrine, norepinephrine, and serotonin for arousal and orgasm. Disorders and medications that disrupt the elements may lead to female sexual dysfunction. It is better to do hormonal evaluations and other investigations before going to clitoral biotespimetry. That means thyroid function test, testosterone, FSH, LH, prolactin, progesterone, and estrogen and AMH. Then the pleasurable sensations provided by clitoral biotespimetry can lead to desire in patients for sex. This pleasurable stimulation can lead to release sexual tension. What we aim to do is let the female acknowledge the fact that there is something called pleasurable sexual experience. Then, in brief, experience or sensation is an important factor. Past pleasurable sexual experience or sensation can lead to sexual desire. Clitoral biotespimetry can generate pleasurable sexual experience. In our study, by increasing the vibratory frequency to high level, female sexual dysfunction patients will experience pleasurable sensation at a particular point. Keeping the probe above this results in sexual desire. Female sexual, this slide you have seen. Then orgasm is a series rhythmic contractions occur in uterus, vagina, and pelvic floor. That all we know. Okay. Method with the clitoral biotespimeter. Increase the vibratory frequency in a continuous fashion till the point of intolerance. As and when patient says intolerance, reduce the frequency to 2 or 5 where the patient is comfortable. Keep the probe for 1 minute. Increase the frequency to 2 points per minute. Keeping the probe for 10 minutes. Most of the patients attain orgasm. This is I am doing it in a laboratory setup. That means those who are not having orgasm, few of my patients attain orgasm by this method. I didn't, that means all of the patients will not be getting orgasm. That may be due to other causes. We cannot say it is only neurological disorder. Then I will show the video. Okay. Go back to management of lack of interest with the clitoral biotespimetry. Stimulating the clitoris with the probe of the biotespimetry is the method, same method. Gradually increase the frequency and find the point where the sexual stimulation takes place. Continuously increase the frequency. Few subjects can attain orgasm. This experience can induce spontaneous sexual urge. Then, vaginismus. I have treated many patients with this mission. Vaginismus is nothing but penetration phobia. Still, the patient can enjoy clitoral stimulation. We must understand that they are afraid of penetrative sex only, but they are interested in hugging, kissing, and they will be enjoying the sex also. Then still the patient can enjoy clitoral stimulation. Then place the probe in contact with the clitoris. Continue the probe skin contact. Increase the vibratory frequency in a continuous fashion. Let it overcome the pleasure point, and when it reaches intolerance points, reduce it to 5 points. Continues the stimulation. When it attains the orgasm, slip the probe into vagina. thing with insertion to this. Yeah, here I am slipping, but consider that all vaginous patients you cannot slip into the vagina. It is very difficult. Then it's a grade 1, grade 2, grade 3 we can do this practice. Grade 5 the patient will be throwing you away and he will. Any questions? Or Dr. Nadesh, you can ask the questions. Let the yeah.
Orgasm is a very personal thing. So how would any woman just spread their legs and attain orgasm? This is number 1 point.
One thing is if it possible in the laboratory setup.
Yeah. In the hospital with like people standing by.
No. Yeah, that's true. But while doing the clitoral stimulation, first of all, you have to understand that.
No, my suggestion is that why don't you rent the machine to them, let them go home, practice and bring back the machine.
See, I have invented this mission.
I know, understand.
But listen to me. I am planning for this thing, giving this mission to them and let them practice.
Yeah, true.
So
that is the only thing.
Yeah. Okay.
And second, And second, I'm seeing that there is a conical thing. So will it transfer the vibration from the vibrating probe to the clitoris?
Sure.
It is transferring.
Sure.
Because you
are asking the technical
STDs.
point or
No, it's a very general point. Because to prevent STD, you are using the conical thing. That is the disposal part, no? Correct, no, sir?
No, conical also.
So it's disposal because in the machine we are seeing a small end.
Yeah.
That is going to revolve or rotate.
Yeah.
Fine.
No,
So,
it is not going to vibrate. This thing. It is vibration only. To and fro motion like that.
to one motion. So it is going to hit like this.
No, it will not hit like that. It is just a vibration. No, I will show it. No, I can show with your finger, not with the penis. Okay?
No, I understood that. But
Not with the penis.
No. My concern is, I'll tell you. My concern is, you
that's
have
a technical question.
yeah, you have used a conical thing.
Yeah.
So is it disposable?
Yeah, it is disposable.
That's what I want to tell you. Because to prevent STDs also.
Yeah. It is
disposable.
So one patient I am using this thing with the condom and all these things, I will be throwing it away and it can be glass dilators are there that can be attached. Each and everything can be attached.
Yeah, understood. So this is with that a general thing. Because we see a lot of devices like this, where there is a clitoral sucking machine, where there are multiple colors nipple sucking machine, which gives various.
No, that I will explain.
No.
Why? What's the just a minute. That's that machines are having only one frequency.
No, it is a vibrator machine. That is a sucking device.
Yeah,
so it is having.
Device, same thing.
No, what I'm trying to say is that there is a lot of academic or scientific controversies regarding the biosymmetry in penile itself. Regarding clitoris, I'm not discussing at all. But when it comes to penis, no, I'm completely not able to accept the point that this is useful to evaluate neuronal cause. A simple stroke with a plantar thing, no, as a
Chromatic reflex.
With the chromatic reflex, a simple string, you can probe the penis. He can tell whether touch or he can. But to prove it is having a sensory neural involvement, this won't be beneficial because I have read a lot of papers predating to Adam and even post-dating, but it is still there to validate. One reference alone might not be sufficient because the inventor, I'm just giving few insights where Indians, we need to evolve more.
No, I have.
From the point.
I agree
because
that.
what they made is PSR is with the index finger. Index finger
because
and
of
penis.
the median nerve.
Understand? Index finger, this is a concept. This concept has to be
clarified.
It has to be not clarified, established or
Yeah, that
proved.
see
The concept, because
we do,
and
that
one more
is-
thing, nowadays, if the machine is there, if you're going to sell the machine, it becomes a commercial thing. No, I'm saying you. In case if it goes next level, it has to be two things. So it has to be CE certified.
Yeah,
And second, it has to be under DCGI device classification.
I agree with you. That's why we are in the beginning stage.
Very much appreciated, sir, because
We are in the beginning stage.
there are a lot
My-
of devices which are being invented by
Yeah.
a non-medicos.
See, I searched so many biotismiometers. Their range comes from 0 to 50 only. Because being an electrical engineer,
That's why I want our emphasis here, because he himself is an electrical engineer also. Now he is going to combine both the knowledge. So this machine has an advantage of having these components, because we have multiple machine market, which doesn't give any scientific
That's
proof.
why I'm not going to sell this machine. I want to.
Even for using for your
Hello, sir.
even for using for your patients also.
We will conclude this by saying that you conduct multi-center studies, then DGCA comes into play. Till then, it is only a pleasure machine. It is a toy which you can sell or buy across the counter on the internet.
One more thing. So one more thing, just a comment regarding the vaginismus. If you stand in front of her and bringing some machine, she will aggravate more. She will not allow you to touch, even in the stage 2, 3 itself.
Yeah, that I will explain during next lecture is there. Vaginismus. I will.
Sir, as a chairperson,
Sir,
Varghese sir.
If with your permission.
Varghese sir, as a chairperson, I have a comment to pass. I am a gynecologist, I am a IVF specialist, and I practice sexual medicine because Dr. Vatsa was there and he started CSCPI. Shirish Malde is here. I think we joined the CSCPI same time, became fellows. But it is a broad organization. Your comment that they are glorified coax is not applicable. We as MBBS and MD people are also glorified quacks.
No,
unless we...
I will explain. That means qualified quacks, not glorified quacks. Qualified. That means in our, what I am telling, that means those who are practicing sex.
Sir, with your permission, can I just take 30 seconds? I am also a gynecologist, and actually majority of females doesn't know what is orgasm. So at least what Ajayan sir has demonstrated in their OPD, at least they realize ki yes, this is the orgasm. Probably this machine can help by that. I think so. Ajayan sir, what's your feeling? Because they many time I am gynecologist, a sexual medicine practice, people doesn't know, sir, what is orgasm? So at least by
it gives. Mary will explain.
Hello, my name is Dr. Mary. I have been working with Dr. Ajay. Actually, during these practices, when we are trying to give a clitoral stimulation, most of the time the patients, the females, doesn't know what the stimulation, that is the sexual stimulation is. So when we give the stimulation, we open the doors, that is we make them understand what the stimulation is. Most of, as we all know, Indian females doesn't know what an orgasm or what a sexual stimulation is. To let them know that sex is not only associated with pain, it is also associated with the stimulation or pleasurable feeling. We let them know that there is such things. So with this mission, it was possible, and it has been. We have been trying to let them know that this is the feeling that they are supposed to have, not only the pain that is associated with sex.
Sir, please include it in Make in India initiative. This machine, Dr. Malde, what do you say?
Pardon? I have a lot of money. I am not interested in this thing. Because of, practically speaking, all these things. When I submitted a project to Kerala, listen, when I submitted a project to Kerala government, that means replacing the incandescent lamps to CFL lamp, they appreciated me. I don't need money or anything. KSB KSEB approved that project and did it. It is just. And regarding the qualified CACs, that means suppose I am MBBS doctor, I am giving sorbitrate to a cardiac patient, I am a qualified CAC only. I should refer that patient to cardiologist. That's what I said. This machine I will keep somewhere here. You can see the vibration and everything. At his finger. This.
Well presented, sir. Thank you.
Thank you very much, sir, for a nice presentation. I would like to call upon Dr. Jayesh Desle, a pediatric surgeon at VishwaRaj Hospital, to felicitate Dr. Ajay Varghese. I now request Dr. Jayesh Desle to felicitate our chairperson, Dr. Anand Shinde. I now request Dr. Jayesh Desle to felicitate our next chairperson, Dr. Namdev Jagtap. Thank you, Dr. Ajay Varghese and the chairpersons. The session was well discussed and concluded. Let's move on to the next session. It's on prognostication of regenerative therapies in vasculogenic erectile dysfunction. So I would like to call upon the chairpersons for next session, Dr. Hemant Chaudhary and Dr. Abhijit Baheti. Dr. Hemant Chaudhary is a vascular surgeon. He is presently working as vascular and endovascular surgeon at VishwaRaj Hospital. Dr. Abhijit Baheti is a senior PG Registrar in clinical hematology at CMC in 2018. He is currently practicing at VishwaRaj Hospital. I now request the chairpersons to introduce our next speaker, Dr. Natesh Prabhu.
Hello, good morning everyone. So, to begin with next topic, I would like to introduce our presenter, Dr. Natesh Prabhu. Sir has a vast experience and very fantastic achievement. He's a medical director and men's health consultant at Androgen Clinic and the Androgen Medical Center, Trichy, Tamil Nadu. Sir is a professor and Department of Pharmacology at Dhanlakshmi Srinivasan Medical College, Perambur, Tamil Nadu. Sir finished his MBBS from the VMMC Karaikal, Pondicherry University and then did a pharmacology, MD in pharmacology from the KMC Bangalore, Manipal University. Has a fellowship in sexual medicine from the IMA CGP facility, Chennai. Just certificate course in the evidence-based diabetic management. Also attended multiple workshops like andrology workshop from the MPHO at Nadiad, the clinical andrology and certificate course from the ICAT Academy, New Delhi. Presently the President, Indian Medical Pharmacologist Association, Joint Secretary from the Indian Stem Cell Study Group, and the regional representative from South India about South Asian Society of Sexual Medicine. So I'd like to invite sir for the next topic. Dr. Natesh Prabhu.
Thank you, sir. So good morning, everyone. So it's a pleasure to be invited here by Dr. Sanjay's team. So it's overwhelming a courtesy, starting from hosting us from Trichy, then Chennai, then down here, because the journey is too far, and a courtesy made it more pleasurable. And of course, meeting my own persons, Dr. Murugan sir, Shiris, and bye, Amit bye, and many here, Rajan also. And so let me begin with my presentation here. So non-surgeons here, right? Any surgeons here? Non-surgeons? Surgeons? Non-surgeon? Surgeon there? So, okay, because my focus is going to be on any, like a biopsy. So that is why I'm just insisting here. So why am I here? Because to present few forgotten evidences amidst the commercially expanding pharma-driven or a surgically oriented treatments for organic ED. I'm requesting you to travel together with me during my presentation to understand my hypothesis, to approve or disapprove it. And it is for deep concern for the patients who had been and are being the candidates for corporo-cavernosal destructive surgeries, that is an implant surgery, which abolishes their natural ability to get an erection. By doing this, we are going to improve their quality of life, which will increase their work potential, and thereby contributing to the social and economic upliftment of it. Because many ED patients are being depressed and they are committing suicide, which will again affect the society. So, as a concept of, as an understanding of Vasudeva Kutumbakam, we are a part of a whole family, and our Brahma main deed is to serve the community and find the problem of the God's creation. Now, how to improve the management of an ED? First, we need to understand the cause. It could be psychogenic, it can be vascogenic. Under vascogenic, we have arterial, neurogenic, endocrinal, and many other things. And how to explore the cause? We have to do multiple investigations, starting in previous one like RG scan, pineal Doppler, and many things for very specific for MRI or CT. They have a few indications for ED also. Very specific blood investigations, treadmill tests for a few patients, and echo for a few patients. Treatment modalities, or I can say, is because even for psychogenic people, we are supposed to give PDFA inhibitors because it has multiple reasons, and we're going to give hormone therapies, statins, vitamin supplements, nutraceuticals, and we have various regenerative therapies which are like energy-based. Yesterday, Dr. Simply was talking about LIS, low intensity shockwave therapy, low-level lasers, and cell-based therapies like PRP, exosomes, or stem cell therapy. And of course, Indian implants and important implants are there, which comes under the surgical management. Now, everyone might be getting a sexual dysfunction patients. Ask yourself if you're going to prescribe a particular modality, either it's going to be a medication or a hormonal or a surgery, will I do it for myself if I get ED? Eventually, every man will get ED at some point of time. Will I do it for my son or son-in-law? Will I do it for my father? This is a question you need to ask. Then you will be able to understand whether should we directly give sildenafil, because Dr. Ajay was telling everyone you give sildenafil or tenofovir. By giving those medication, MAEER'S, you are pushing them for a implant surgery in future. That is an actual thing. Because those are wonder drugs, but it has to be handled properly. I'll tell you the reason. Nowadays, implant surgery is lauded as high-end surgeries because of the cost and the need in the society. I can show you, this is Dr. Gabriel Antoni, one of the very revered surgeons from Spain, and you can see his patient. He is actually a gigolo. You can go to his profile, you can see his well-built body, he is a porn star also, and this guy is having an inflatable pineal implant, and he is going to tell, please come to this, I am going to show the video how the implant works. Imagine how the implant works, because I am the patient of the doctor. How can implant work? Only by doing sex. And surgical implantation of a pineal processes have two indications, who are not suitable for different pharmacotherapies or prefer a definite therapy. This is what the conclusion is. Because once you go to a surgeon, they will tell these therapies eventually might fail for you, and you are not responding to this particular dose of therapy. You have no other option, you go for implant. It could be imported or Indian implant. And who do not respond to other. This is second one. Eventually you are making the patients not going to respond for the first line management. That is either a testosterone replacement or sildenafil or tetanafil or amanafil. Eventually you are pushing the patient for implant. So, high-end satisfaction are for 3-piece implants. When you go to a surgeon, they will tell, no, we have evidence. Implant gives good satisfaction. It is for 3-piece. But what we expect, many surgeons, they do SHAWs. SHAW has very poor concealability. It will stand like this. They have to keep under the underwear. Correct? No? Keep under the underwear. And if the patient is going to a temple, who is going to take a bath in the pond, and who is going to come out of the bathroom, his daughter or son will be there, he cannot enter without underwear. Because it is going to stand like this. And if you want a good concealability, he has to go for a bendable implant, which will cost, with the surgeon, cost around 4.5 lakhs. And inflatable, high concealability, the cost will come around 10 lakhs with the surgical thing. So this is what is about the implants. Now, imagine, patient has got an implant surgery. He is going to come and perform. He is going to bend his pin like this, press the implant from this. Scott, if you can see the implantable videos. Wife says, this is not what I've asked for. I want a natural erection. If I touch you, it should rise. You cannot meddle with this. My mood is gone now. Then next day he comes to the surgeons. He blasts him. This is not what I've asked for. You have made my life more terrible now. My wife doesn't like my penis now. Gone. If the wife doesn't like his penis, then however he is going to look smart is gone now. These are all patient satisfactory questions which have been elicited in the pineal implant, post-implant observations. Now, how to avoid this? We have few things. We have all those diagnostics workups now. Everything is fine. Many surgeons, they do pineal Doppler. They do pineal Doppler and they say, Doppler is normal, it is psychogenic, go home. It is not like that. Pineal Doppler shows only a bigger artery and it is going to show the response of a papaverine or a chlorpromazine. Very simple. But what is happening inside the corpora cavernosa, it won't show, or we are not displaying it, because normally what we do is peak systolic velocity in EDV. And they say whether it is arteriogenic or venogenic, it is a good modality, but it has evolved a lot and still, and it was a good tool in the treating doctor's stand. Those days, urologists do those Doppler. Nowadays, radiologists do. It is like a echo, which is being done by a cardiologist and an echo technician. Humongous difference between them. Echo technician can display the ejection fraction. Only a cardiologist can correlate it with this screen finding. That is what is the pineal Doppler. Only a treating physician can know what is happening with the patient and what is there in the Doppler. That is the main thing. Specific tests. Endocrine studies, people just do a testosterone. They tell you testosterone is normal limits. They don't understand what is low normal, what is subnormal, what is acute phase, what is, how it is interacting with hormones, nothing is there. So now, points pointed, okay? Have any of the current assessing parameters and medications helped in curing ED?
Is there any way to see or visualize what had happened with or within the patient's erectile tissues? By seeing it, will it bring change in the management option or protocol? That is how to prognosticate. You are giving a sildenafil, patient is having erection, or patient is having subnormal erection. What will do? Okay, now you are giving a 25 mg. You take 50. That is visually you are going to see the prognostication. Okay, the patient is coming with a low testosterone. He is saying, doctor, I am getting good amount of libido now. You see the value of testosterone has risen from 150 to 250. Okay, one more dose you give, it goes to 400. That is called prognostication. When it comes to regenerative therapies, very specifically nowadays, I am not going for cell-based therapies, that is very specifically stem cells, exosomes or BMAG. I am going to talk only about PRP because PRP is easily acceptable modality nowadays. How to prognosticate? People think PRP is a pro-erectile agent. No, PRP is a healing agent. It is going to assist in providing natural erection. People tell after getting PRP, 5-6 doses, there is no erection. That is because they don't know what they are seeing. That is where I am going to emphasize how to prognosticate in case of regenerative therapies. People should understand what we are going to regenerate. I am going to show some biopsy evidences. Starting from 1970, many urologists those days, sorry from Goldstein, they were very intrigued what is going to happen inside the penis. They took multiple seal biopsies of a single patient who are the cadaveric persons. Then they found out from the open biopsy we had evolved to a closed biopsy. Then Viagra came in 1977. Everything stopped, all funding, so because they thought they have found a cure for erection dysfunction. Viagra has actually helped many patients. It actually has destroyed the scientific advancement in the field of treatment of erectile dysfunction. It is actually a paradox. I'll show you the reason. So, my hypothesis is built on the available but neglected evidences. Please know this point, vasogenic erectile dysfunction is a chronic, progressive, degenerative disease. 3 words, chronic, progressive, degenerative disease. Which disease you know is? It is a chronic, progressive diabetes. As you all know, diabetes has no cure. We treat symptoms by lowering blood sugar levels. But nowadays there are multiple stem cell transplants. Things are evolving to cure diabetes, not cure, to give remission. Ultimately, these things will cause penile implant surgery. Currently, there is no possible cure, but we can stop or induce remission to the progressive nature, or we can downstage the disease. That means patients coming with a severe ED, you can downstage to moderate ED or to mild ED. So, based upon the disease severity, remission could be achieved, that is medication-free period, by stopping the disease progression. That we are going to avoid or at least postpone the penile implant surgery, increase the natural sexual longevity of the patient. When I ask a patient, comes to the age of 25 or 30, I'll ask, how much sex you want to have? Sir, at least I won't have till 40, 50, sir. Then I ask him, what do you think will be the maximum age of the patients? 87. So they 87 they have sex, yes, of course. But it will be a curse also. Imagine at 87, if somebody wants erection, they have to manage their low libido wife and their son-in-law, daughter-in-law, and the grandparents, the grandchildren. So it is kind of a different discussion. But anyways, I am emphasizing the point from that. They will require a natural sexual erection for a long period. So therefore, we are introducing the concept of reversing erectile dysfunction. Changes happen here needs to be reversed. We have to shift the focus inside the corpora cavernosa, not on the penis. Because most of the IEF questionnaires, it focuses on the penile erection. That is the outside thing. So what are the learning points here? Anatomy, histopathology and ultrasexual. Architecture I'm going to tell few technical things, but because there is no much of surgeons here, I must skip this because tunical publications, sinusoids, bed vessels, microarchitectures might not be relevant for this crowd. I'm going to make it more relevant anyways. And people know that when the penis gets hard, it is like a rock solid bone. So it's called bone. So what is giving this bony consistency? These are all the inward projections from the tunica albuginea, which consists of the vascular sinusoid spaces. And the yellow strings are corpora smooth muscles. This is the main diagram which you understood. People think penis is a hollow organ. It is not a hollow organ. This is like this. Sinusoids gets emptied by the Helician arteries and it has its own venous drainage. This is a cadaveric picture which I taken from the, which when I had a chance to attend a pineal cadaveric implant workshop. So I requested the organizer, they gave me a whole cadaver, so I was able to dissect. Then I was able to visualize what is happening. What you can see here, imagine it's like a sponge, a scrubber, where it's going to fill a lot of bloods, and the in between those struts is going to give the strength. As you use more and more, as you press it more and more, it becomes softer. But means it is strength, it goes down. This is the physiology which you'll be knowing by now. So main things, that's an endothelial cell dysfunction, therefore there is no endothelial nitric oxide. And in between the tunica albuginea, that's compression of the tunical medial plexus vein. So this is maintained by the sympathetic parasympathetic imbalance. Imagine this is tunic albuginea. People think a tunic albuginea is only surrounding the penis. No. Each and every sinusoid has its own tunic albuginea. This tunic albuginea is penetrated by the smooth muscles, artery, nerve and vein. And inside the sinusoid spaces, it has blood. And depending upon the sympathetic parasympathetic tone balance, the person might have an erection or a flaccid state. Again, a picture emphasizing this is in a flaccid state, this is in a contractile state. So, to prognosticate, we need invasive, non-invasive. In invasive, biopsy. Biopsy is the ultimate thing to visualize any regeneration. Non-invasive, we have gray-scale ultrasonography. How can I see? Because they have given a very important clue. Each and every organic causes have its own hallmark fibrosis pattern. Cavernous artery, intimal medial thickness. You know about carotid artery, right? For stroke. That's a concept for us. See, the same thing holds for the pineal arteries also. Shear wave elastography of penis. We heard for the fibroscopy of the liver. It is used for penis also. Corpora cavernosal electromyography. And nowadays, we even have home-based nocturnal pineal luminescence. Regiscan is being reintroduced as a home-based testing. Regiscan is a company which pioneered in measuring the nocturnal pineal luminescence. Nowadays, we can even go for the real-time luminescence, which is a part of the discussion now. And of course, pineal glucose Doppler, it has to be seen in a very proper way. Starting from, I think this is 1982, along first study where they did these cross sections. I'm going to skip it off because it can be boring for you, where you can see the tunical structure, meaning you see the collagen fibers or the elastins in various ages. Or the arteries is going. I'm going to skip it. What you understand from all these boring pictures is that these tissues are the functional tissues. Whenever you give stem cells, you give PRP, these tissues, these nerves, these will regenerate. You have to wait for those to regenerate. Until unless you're going to have this in mind, whatever medicines you give, it is going to be failing in a very soon. How soon depends upon the patient's pressuring stage. So multiple things they did. So they even found that is a nucleoli vacuolization. That is ultracentrifuges. I'm going to skip it again. Electron microscope, everything is there. So what you have to understand is that, see this. This is the picture showing the bar graph shows a percentage of altered smooth muscle cells in men with ED and non-ED. It is very clearly showing that in men with ED, the abnormal cells are more. How much time is there? So I will cross 30 minutes. Oh my goodness. So these are the things which we need to understand. So as a cell-based therapist, we see from only the cell perspective, and These are all the more technical, I'm going to skip it. And for the surgeon, for the urologist here, the organizer, this is what I want them to focus. In 1990, they introduced a very painless, no issueless biopsy gun. They even follow the patients to the home also. There is not even a single case of pain, hematoma with this procedure. They showed even where to take the biopsy also. Then came the era of Viagra and all. This is all the same thing. 1997, Viagra came and this whole thing got abolished. This is a pathology thing, so I'm just going to skip it. Fine. Now, in this, as a non-surgeon, how we can see? You go, sit with the radiologist, give this paper to him. If I am referring a patient, I will put the cost there. Either it is a pre-episode ED, or a diabetic ED, or a atherosclerosis ED, or a ED after repeated use of ICI, that is intravenous injections. Everything has a hallmark fibrosis. Now, what is fibrosis? ED comes because there is a whole body inflammation. Chronic inflammation leads to repair. Repeated repair failures leads to fibrosis. Once it is fibrosed, the functioning tissue is replaced by a scar tissue. So now everything has a pathognomonic non-functioning tissues over there. This is what you have to see. Now, how to prognosticate? After giving the PRP, see whether these changes are reversing. Very simple. These changes are reversing or not. You can always measure this. Tell them your cavernous IMT is so big. You have to go for PRP, else the whole artery gets occurred very fast. Shear venoscopy. Many of you have heard about fibrosis of the liver, right? They see for the fatty liver, fibrous cirrhosis. Same principle they can use for the pineal tissues. They are very clearly shown 25% index in the elastography. If the fibrosis is more than 20%, then you go for implants. Until then, you can wait. You can proceed with other therapies. Don't jump for implants. This is electromyography. This shows the cavernous smooth muscle functioning. That's what we're doing with our Rajendra. Sensation goes deep inside. We need to measure those things. Wearable sensors for home base. This is now in the market. Let's go and search for Adam. Adam is a company which now they have marketed home-based NPD device, which comes at a cost of $179. I don't know how much effective it is, but you can tell the patients these many erections you are having per night. By giving tadalafil, you may have more. By giving PRP, we will see how much is being improved. And this is all other benefits because this is available everywhere. You can see. You just go, bone marrow stem cells can improve ED, PRP can improve ED, stem cells can improve ED. You can see that. And this is called as platelet lysate. See, we have evolved from the concept of PRP. You know what is PRP? You spin it, you take the platelet-based plasma, you give it. What is the dose? For example, if a patient is having headache, we give 500 mg of paracetamol. You can tell, depending upon your body surface, you need 650 or 1000 or even T80 or QID. For PRP, what they do, you give 5 sittings, 6 sittings, not like that. Now it is proven that in patients with erectile dysfunction, the VEGF, that is vascular endothelial growth factor, it is less. It is less by 6 times. So if you want to achieve this erection, you have to give 6 times VEGF. That can be achieved only by platelet lysate. Now what lysate? You take the PRP, you activate it, you take all the VEGF, then you introduce it. That is where you are going to heal it. Now why do you combine this? As age progresses, stem cell quality comes down. Stem cells are like seeds. PRP is like a fertilizer. As age progresses, seeds gets damaged. So you have to give stem cells along with PRP. So one-stop solution, every age group, for every reason, one PRP, it is going to kill the science. And it is killing the science. You can go to the styles, you can search for multiple evidences from stem cells or content. No, India is promoting stem cell research. We are the first in the whole world to have stem cell approved therapy for osteoarthritis, for CLI, for eye diseases, for cosmetic. Research is going on. This is the first time. This is my mentor here, Dr. Ravi, who is standing in the. Here, this is myself, and this is Dr. Pawan Kumar from the Asst Manipal. They gave us CLI. After Dr. Ivy was in the field for past 10 years. I'm a student for this in case of internal medicine. So we have to come forward, open our brains beyond PD5, beyond testosterone to promote this in a proper way. I'm not telling this it is the cure. We have to adopt this modality with a caution, else we will kill the result ourselves. And this is, I want to emphasize this tipping point, this also has to be in hand. We know this sexual response cycle, old concept. Dr. Perelman's concept is a new concept, sexual tipping point concept. So, various diseases have been researched for these stem cell based therapies. So, we need a team, we need a biotechnologist or a cell biologist, we need a proper research lab, and we need a therapy area specialist. Institutions like VRH can adopt this. If a person from a small clinic in Trichy, if I am able to coordinate with multiple persons outside the setup, institutions, an academic or a hospital inside this campus has to initiate these things. The urologist there, a gynecologist there, a psychiatrist, cell therapist. We have to do very, it is not costly at all. Long-term cost is actually less. And they can get more funds also. And even the owners like it. My team is working so hard for research funding. They like it. This is very old news. India is, under this new government, they are giving a lot of funds for stem cell research. See, and now it is more only, the funding is increasing anyway. So, regenerative medicine is cellular pharmacologist. Pharmacologist, I am very proud to say this. This is a present, never considered as a future by a conventional pharmacologist, PD5 inhibitors or testosterone. You are going to substitute or give a symptomatic treatment. By giving cellular pharmacology, you are going to regenerate and reverse process. So my team, my mentor, my Dr. late Shankaran sir, who left us in the sapphire accident, and Dr. Serial was using stem cell for post-cardiac surgery patients, and Dr. Anil Bansal from PGI, who had pioneered in reversing diabetes, and due to lack of funding, he stopped, but you can go and search for his papers. Dr. P. Ramachandran here, again mentor, is a plastic surgeon who have abolished more than 253 amputations by giving stem cells for CLI and for TIO. And of course, my mentor, Dr. Ravi is here anyway. So you can always look at the changes, go deep inside and see what we can adopt in this. Thank you.
Thank you, sir. Floor is open for the questions.
Hello. So just one question came to my mind. As a urologist, should we send a patient before penile implant surgery to you for the regenerative therapy?
Sir, I will tell you one thing, because now to adopt it, before adopting, I would request you to sample the tissue, which we cannot. While doing an implant, you can measure the penis for anything, because anyway you are going to take out all tissues. There you go for a penile biopsy. You send that to us. Then you will understand that these patients are very high fibrosis. Now you are mastering the biopsy. Next time, when the patient comes ED, for every patient, after getting HSP approval, you take biopsy. Then give PRP. Then after 6 weeks, you take biopsy. Then send it to us.
Okay.
That is very required, because you have to manage. Regarding preparing the PR protocol, I can help you with that. How to maximize the PR efficacy, I can help you with that. But I am insisting you to take biopsies, because you have an institution, HSP approval is required for this procedure, because you are a surgeon. You can take, and every other thing I told, there is no pain, no trauma if you go in the Belano prepucial group under local anesthesia with a 19 gauge needle. That's it.
I'll try for this.
That is challenge, but in the penile Belano group, the side base, if you go like this, you may injure cavernous arteries, then hematoma comes up. That you can't, because it is a cutting needle. You understand? No? It cuts it. If there is artery going transverse, it cuts it, it gets blown up. to avoid that they're going in a surgical way.
The biopsy should be taken through the lens or directly from the camera?
You should not be using, we don't have to group from the, like behind the gland, from the corner sulcus, just go inside. I tried with cadaveric tissues. It is working fine. I'm not able to convince my plastic surgeon. Urologists, no, they don't do that because, I don't say that because as a urologist, you do that. That is what I require.
So that means we have to convince the patient.
No, you have to convince your team, sir. Patients will definitely, implant patients, they are in your hands. On the table, he will never know what you can do with the penis. Anyway, you're going to take out all the tissue. Before doing that, get the consent, we're going to take biopsy. Just do that. Anyway, you'll be having open sample. You try this all, one or two things. Nothing's going to happen. No, that is what they have shown that. They have shown that single biopsy is enough. There is no patchy change. It is a diffuse change. Single biopsy is enough to understand the whole tissue pathology. If you want to practice more, you can have 2 biopsies. It gives more advantage on the practice side. Thank you.
More and more old elderly people are living alone. Okay, so I have at least 7 to 8 above 80 patients, and the highest is 87, whom I started treating 87 5 years back, 4 or 5 years back. Now in this particular case, why I want to share this, he has 4 kids, all are living their own lives in their home. He and her wife, who happens to be mid-70s, and wife wants to have sex once in a while, even at this age. So, and for them this is one of the ways to have recreation. Okay? So there is no age bar whether it is male or female about doing sex or desire. And as per one case report which was published in Germany, journal JSM, 100-year-old female from Denmark used to have a not very regular sexual activity, but once in a while, and she used to experience orgasm. So I think age is not a bar about sex. It's just like situation and the sociological parameters which are changing. They are dynamic. So all these factors have to be taken into consideration.
Highest age with a mentor who did the surgery for implant was 97, he was telling me. 97 years, the guy came for implant surgery.
Not only recreation, but establish the intimacy also.
That is also there. Thank you, sir. Thanks for coming.
Thank you, sir. It was a very nice and informative session. I would like to call upon Dr. Anand Narnavare, pediatrician and neonatal intensivist at VishwaRaj Hospital, to felicitate our speaker. I now request Dr. Anand Narnavare to felicitate our chairpersons, Dr. Hemant Chaudhary. I now request Dr. Anand Narnavare to felicitate our next speaker, Dr. Vijay Baheti. Chairperson, I am so sorry. Thank you very much, sir. So let's continue the session. In continuation with the VRH GYAAN, now we are going to get some highlights on the diabetes and erectile dysfunction. I'll call upon Dr. Vasu Charan, hematologist at VishwaRaj Hospital, to chair the session.
Good morning, ladies and gentlemen. I have an immense pleasure in introducing Dr. Hambire, who is one of the very popular physicians in Southeast Pune. He is academically active. Besides being an associate professor of medicine, he is a teacher and examiner for DNB. The topic of diabetes is very close to his heart, which can be judged from the fact that he is recently enrolled for PhD in diabetes. Today, he is going to talk on erectile dysfunction in diabetics, which is not at all an uncommon complication in diabetes. Depending upon the duration of diabetic and glycemic control, almost 30 to 70% of patients will develop erectile dysfunction at some stage or other. Now, how this is caused, how to investigate, and how can manage, this is being told by Dr. Hambire. Dr. Hambire, stage is yours.
Thank you, sir, for kind words. Honorable Chairperson, dear delegates. Good morning, and thank you, organizing committee, for touching the untouched topic. Most of the alleged speakers have already spoken about erectile dysfunction. Since yesterday you have been bombarded with erectile dysfunction, my views will be restricted only for diabetes mellitus and erectile dysfunction. As you know, diabetes mellitus is one of the most common chronic diseases in all countries of the world, and it has been declared as global pandemic in 2012. This shows the global and Indian burden of diabetes. World today harbors near about 537 million adults living with diabetes, and it is expected to reach 783 million by 2045. While China currently is number one with people with diabetes, India ranks second with 74.2 million people living with diabetes. Sexual function is a complex blend of anatomic, neurologic, metabolic, endocrine, and psychic factors more than any other human activity. Alteration in any one of the factors can lead to sexual dysfunction. Among the systemic diseases, diabetes mellitus is the main cause for sexual dysfunction in males. So what is erectile dysfunction? Erectile dysfunction is defined as persistent inability to achieve or maintain penile erection for successful sexual intercourse, causing decreased quality of life in men. The natural history of ED in people with diabetes is normally gradual and doesn't occur overnight. This helps to differentiate it from psychological causes of ED. So what are the causes of ED? 10% causes are psychological, 85% causes are organic, whereas 5% causes are of undetermined origin. Out of organic, diabetes mellitus is the leading one, constituting near about 33% of cases. Whenever I am talking about diabetes mellitus, it includes both type 1 and type 2. Disease of blood vessels, radical pelvic injury, spinal cord injury, drugs and substance abuse fills the rest of the organic causes. The ED incidence increases with age, duration of diabetes, and deteriorating diabetic control. Compared to men with diabetes tends to suffer ED at an earlier age. They suffer more severe ED and they are less responsive to treatment. That's why in cases of ED, diabetes history needs to be explored. Not only hyperglycemia, treatment of diabetes mellitus, which drugs you are using in the treatment of diabetes mellitus, comorbidities, treatment of comorbidities, complications, and treatment of complications may have favorable or unfavorable effect on erectile dysfunction. Now, this is the prevalence of complication of diabetes, where the CKD is a leading one, whereas strokes considered about 6.6. So, where the ED stands for. So, prevalence of ED in diabetes patient, Corona et al. Reported approximately 19% prevalence of mild ED, 15% prevalence of mild to moderate ED, 10% prevalence of moderate ED, and 21% prevalence of severe ED in men with diabetes mellitus. The severity of ED is highly dependent on duration of diabetes mellitus, type of treatment chosen to treat diabetes mellitus, and its comorbidities. Now, what are the prevalence of ED in type 1 diabetes mellitus and type 2 diabetes mellitus? Federal et al. Concluded that the ED in type 1 diabetes mellitus there was a prevalence of 27%, whereas prevalence of ED in type 2 diabetes was near about 37%. Ethiopia study concluded that type 1 diabetes mellitus has a prevalence of 60%, whereas type 2 diabetes mellitus has got a 79% prevalence of ED. So this concludes that rather than insulin deficiency and hyperglycemia, insulin resistance has some role to play in ED. What is the physiology of penile erection? So normal male sexual response consists of phases of excitement, erection, orgasm, and resolution. The factors which are required for erection include adequate desire and arousal, adequate testosterone levels, anatomically normal penis, adequate arterial inflow, effective venous occlusive mechanism, and integrity of autonomic and sensory neural pathways. Any deviation from above factors can contribute to ED. So most of the patients will be having deviation from more than one or the other factors. So this is how the erection occurs. Sexual stimulation occurs through physical, auditory, or visual stimuli. CNS processes these, cerebral cortex processes these stimuli, give efferent impulses through spinal cord and nervi irriganti. There is activation of neuronal nitrous oxide synthetase. There is increasing nitrous oxide which causes cavernous smooth muscle relaxation. There is blood flow mediated shear stress which in turn activates cavernous P13 kinase. And there is phosphorylation of endothelial derived nitrous oxide synthesization, and which releases endothelial derived nitrous oxide. So neuronal nitrous oxide initiates the erection, and whereas endothelial nitrous oxide maintains the erection. And after ejaculation, the reversal of this occurs and penis goes in a flaccid state. So this is complex slide or busy slide. I'll simplify next subsequent slide. So this is the pathophysiology of diabetic ED, type 2 diabetes mellitus or type 1 diabetes mellitus. Causes raised blood sugar. In type 2 diabetes mellitus, there is additionally insulin resistance. Most of the type 2 diabetes mellitus will be having associated comorbidities like hyperlipidemia, hypertension, obesity, and sedentary lifestyle. These patients with continuous hyperglycemia are known to cause vasculopathy. Maybe it is macrovasculopathy, microvasculopathy, or endothelial dysfunction. These are known to have neuropathy, both autonomic and peripheral. These are also known to cause hypogonadism by decreasing sex hormone binding globulin, decreasing free testosterone, and decreasing total testosterone. Most of the diabetes mellitus patients will be having local factors such as balanitis, phimosis, fibrosis, coupled by or complicated by few of the psychological factors like depression, anxiety, and decreased libido, which in turn all contributes to decreased nitrous oxide production and decrease in vascular cavernous smooth muscle relaxation, which ultimately leads to erectile dysfunction. So again, these slides elaborate the same thing: hyperglycemia leading to advanced glycation end products, oxidative stress causes molecular alteration, endothelial dysfunction, and functional alteration in the endothelial smooth muscle, leading to erectile dysfunction. So this diabetic ED is contributed by hormonal changes, endothelial dysfunction, neuropathy, and cavernous and structural functional changes. Why diagnosing ED in diabetes is important? ED screening may identify underlying coronary artery disease, or it may sometimes uncover diabetes, as ED may be the first symptom in up to 20% of cases. It reveals the presence of hypogonadism, and it can identify occult cerebrovascular disease. So this is an important slide which shows interplay of cardiovascular risk factors, endothelial dysfunction and erectile dysfunction. All are aware of that. Endothelial dysfunction is a common factor which is present in erectile dysfunction and coronary artery disease. Diabetes along with its comorbidities like hypertension, dyslipidemia leads to structural changes in the vessels causing atherosclerosis, and it also causes functional changes with impaired endothelial dependent relaxation, leads to arterial insufficiency, which are known to cause both erectile dysfunction and coronary artery disease. So what are the risk factors for ED? Diabetes mellitus, age, dyslipidemia, hypertension, cardiovascular disease, obesity, metabolic syndrome, lack of exercise, smoking, low testosterone levels, neurogenic and iatrogenic factors will be posing a risk for erectile dysfunction, out of which age is the only non-modifiable factor, where rest all can be modified. So, but to be very honest, diabetes patients will be having more than one or the other factors contributing to ED. Again, this is a complicated connection between diabetes and erectile dysfunction. Diabetes, along with its comorbidities like hypogonadism, obesity, hypertension, insulin resistance, psychological factors, along with its complication, maybe macrovascular, microvascular, nephropathy, neuropathy, will add to the burden of erectile dysfunction. So this is the important slide which shows connection of erectile dysfunction with coronary artery disease. As you know that atherosclerosis is a continuous process affecting at all the places at single point of time. Threshold for symptom development depends on percentage of lumen obstruction. More than 50% lumen obstruction will lead to the symptoms. As you are aware of size of all the arteries, penile artery is 1 to 2 mm, whereas proximal LAD is near about 2 to 3 mm, whereas internal carotid and femoral artery constitute about 5 to 8 mm. So penile artery can be symptomatic earlier than the coronary artery disease. So ED can precede the onset of coronary artery disease by 2 to 5 years. This provides a great opportunity for the early diagnosis of silent coronary artery disease and stroke, particularly in patients less than 60 years of age group. Atherosclerotic complications affect smaller arteries such as those in cavernous areas before affecting the larger ones like coronary and carotid arteries. That's why ED should be considered as effective zero-cost predictor of CVD and requires further diagnostic investigation and aggressive risk decreasing therapy, especially in young men. This should be the crux or take-home message of today's my presentation. Diabetic nephropathy and ED. Diabetic nephropathy, which occurs in near about 20 to 40% of patients with diabetes mellitus and is dependent on increased arterial resistance and therefore glomerular pressure. Erectile dysfunction is therefore common in most of the patients of chronic kidney disease. There has been noted a strong correlation between albuminuria and erectile dysfunction. As you know, the activation of renin-angiotensin increases the production of pro-inflammatory and pro-fibrotic molecules, which further increase the arterial resistance and decrease the production of nitrous oxide. Diabetic neuropathy is another important microvascular complication of diabetes. Ischemia and advanced glycation end products and free radical formation can impair axonal transport and nerve conduction, causing segmenting demyelination. Diabetic neuropathy is involved in most of the cases of ED along with vascular causes. Both peripheral and autonomic neuropathy contribute to ED. This is the same repetition of similar ED and diabetes mellitus share common risk factor and are associated with diseases causing endothelial impairment such as hypertension, dyslipidemia, obesity, and metabolic syndrome. Now, what are the drugs? These are known to cause ED. As you are aware that diabetes mellitus patients, they have got multiple comorbidities, and patients apart from oral hypoglycemic agents and insulin, they are on multiple medications to control one or the other comorbidities or one or the more other complications of diabetes. Most of the patients, they do suffer from hypertension, BPH, GRD, or one or the other cardiac abnormalities. Antibiotics like beta blockers, methyl dopa, thiazides, antidepressants like SSR, which are commonly involved in treatment of peripheral neuropathy, antihistaminics, acid reflux medications like cimetidine, ranitidine, alcohol, cardiac drugs like digoxin, clofazimine, 5-alpha reductase inhibitors like finasteride, which are involved in treatment of BPH, will add to the burden of drugs causing ED. So before we proceed how to evaluate a case of ED, I'll just run to the slides where the treatment of choice to treat diabetes can affect maybe favorably, unfavorably on male sexuality. Metformin is a class 1 drug used unless until contraindicated in type 2 diabetes mellitus. It has been beyond doubt proved that it has got a possible positive effects on endothelial dependent vasodilation. A correlation between improvement in the endothelial dependent vasodilation and a reduction in the insulin resistance after administration of metformin, that is 500 mg BID for 3 months, has been reported. Metformin could decrease excessive sympathetic nerve activity and is useful in the erectile function. Metformin treatment for insulin resistance could be hypothesized to improve testosterone levels, and consequently it is known to improve erectile dysfunction in diabetes. Pioglitazone, second commonly used drug in treatment of diabetes mellitus, which acts on PPAR gamma isomer, which has got a favorable outcome on endothelial dysfunction, oxidative stress, and metabolic disorders and atherosclerosis. It is known to improve ED through nitrous oxide mediated pathway with a dose dependent mechanism. It has been proved that pioglitazone at a dose of 0.6 mg per kg is known to have a favorable effect on erectile dysfunction in diabetes. SGLT2 inhibitors, now one or the other trials has proved that these SGLT2 inhibitors are class 1 indications in treatment of type 2 diabetes mellitus. Empagliflozin significantly improved erectile function in response to electrical stimulation of the cavernoid nerve, and it has improved the sensitivity to phosphodiesterase inhibitors. This has been attributed to the improvement in the metabolic parameters by generating more nitrous oxide. DPP-4 inhibitors, commonly used in treatment of type 2 diabetes mellitus, improves the erectile function by promoting vascular repair and endothelial function. It improves the effects of vasorelaxation mediated vascular endothelial growth factor. Insulin, which is most physiological treatment involved in the treatment of type 1 diabetes mellitus and type 2 diabetes mellitus, it improves ED by reducing levels of pro-apoptotic factors and by increasing levels of anti-apoptotic factors. It also modulates sex hormone receptors. Now, how to approach a patient of diabetic ED? One needs to go for clinical assessment, vascular assessment, neurological assessment, and hormonal assessment. Clinical assessment, history and physical examination may indicate probable cause of ED, hypertension, addiction to alcohol, smoking, concomitant endocrine diseases must be looked for. Examination of genitalia is essential to detect primary penile abnormalities such as balanitis, hymosis, penile curvature, or Peyronie's disease, which are more common in diabetes. Testicular sensation is a simple OPD procedure. The loss of testicular pain sensitivity may suggest neurogenic etiology. Again, interruption of urination is again a simple test. Willful interruption of urination and restart. This manual is possible only if your autonomic nervous system is intact. Nocturnal penile tumescence, lot many allied speakers have already spoken about NP2 testing. It is normal individuals, they do get 3 to 5 times penile erection in a night, lasting for 15 to 30 minutes during REM sleep. This helps to differentiate psychogenic versus organic ED in diabetes mellitus, as most of the psychogenic causes, psychological patients, they will be getting normal erection, whereas in diabetic organic ED, these nocturnal penile emissions will be decreased or will be absent. Vascular assessment can be done by clinical assessment for peripheral pulses. It can be done by penile Doppler, which is a OPD procedure. Penile to brachial plexus index can be a good measure for vascular assessment. Normally it is more than 0.75. Penile plethysmography can be sometimes used for vascular assessment. Rarely contrast studies are used for vascular assessment. If the patient is going for a arterial bypass, contrast studies are required. Neurological assessment, clinical assessment for peripheral neuropathy, as we do in OPD, checking for reflexes and all that. Penile biothissimetry, Dr. Rajendra sir has already spoken about penile biothissimetry. Cardiac autonomic reflex testing for autonomic neuropathy, just like tilt table test can be utilized for neurological assessment. Pudendal nerve regulated latency can be checked in NCD. Sacral evoked potential, as Dr. Prabhu has already spoken, can be useful in neurological assessment. Hormonal assessment in selected patients may reveal hormonal causes of diabetic ED, testosterone levels, FSH, LH level, prolactin levels, and thyroid function test to be done in selected patients. So apart coming to the last part of the session, that is treatment of ED in patients of type 2 diabetes mellitus or type 1 diabetes mellitus, apart from achieving a good glycemic control. So none of the treatment in diabetic in ED in diabetes will be completed without achieving a HbA1c goal. So HbA1c has to be individualized depending on age, risk factors and comorbidities. So generally it is advised that HbA1c has to be less than 7. So incidence and prevalence of ED goes higher if your HbA1c is on a higher side. So apart from good glycemic control, whatever the drugs are you are using, the rest of the management I am going to discuss today. Lifestyle modification and glycemic control. Weight loss is highly suggestive. Weight loss of 5% of initial weight has been minimally recommended for clinical benefit. Greater the weight loss leads to even greater benefits in terms of reduction of blood pressure, improving LDL and HDL levels, and it also improves insulin resistance. It also helps to decrease the number of medication to control diabetes, hypertension, and dyslipidemia. Weight loss is strongly recommended to improve erectile function, considering that it can increase the testosterone level mainly by improving testicular function, reducing the conversion of testosterone to beta estradiol via aromatase activity in the adipose tissue, as well as it is known to increase the sex hormone binding globulin concentration as a sequence of decreased insulin levels. Physical exercise is strongly recommended for both type 1 and type 2 diabetes mellitus patients, given its contribution to weight loss, improved blood glucose control, reduced cardiovascular risk, and improved well-being and sexual function. Strict control of hyperglycemia prevents the worsening of ED, may reverse the ED also. Patient education regarding stopping smoking, alcohol, recreational drugs is of paramount importance. So what are the treatment options? Most of the speakers, they have already spoken about the treatment options. I'll be touching all of these. So phosphodiesterase inhibitor, 5 inhibitors, androgen replacement therapy, intracavernosal injections, stem cell therapy, vacuum erection devices, low intensity extracorporeal shock waves, penile prosthesis implantation can be the treatment options for diabetic erectile dysfunction. Phosphodiesterase PDE5 inhibitors have been considered the first line therapy for ED of broad range of causes. Let it be whatever the cause, these drugs are first line therapy. These are known to inhibit the this inhibition is known to increase the cyclic GMP levels in cavernosal tissues, leading to smooth muscle relaxation, increased arterial blood flow, and venous constriction and erection. Examples you all know: sildenafil, tadalafil, vardenafil, and avenafil. So this is sexual arousal comes it leads to the nitrous oxide pathway activation, which in turn causes guanylyl cyclase activation, and there is more cyclic GMP in the penile tissue. This cyclic GMP are metabolized by phosphodiesterase 5 enzyme. So sildenafil or tadalafil acts on this pathway, and there will be less harvesting of cyclic GMP. There will be more availability of cyclic GMP in the penile tissue, which leads to the smooth muscle relaxation and persistent erection. These drugs are administered in graduated doses, enhance erection after sexual stimulation. The onset of action is approximately 30 to 120 minutes. They do not affect ejaculation, orgasm, or sexual drive. Side effects include headache, flushing, dyspepsia, and altered color vision, that is called as blue halo effect. Though they are these drugs are specific for phosphodiesterase 5 enzyme, few molecules they have got a affinity towards phosphodiesterase 6, which are present more commonly in cones and rods photoreceptor in the eyes. That's why they do get altered color vision after maybe 1 to 2 hours after peak plasma levels. This is a transient effect which lasts for a few minutes and then it wanes off. These are contraindicated in patients receiving nitrates, as it is known to cause precipitous hypotension. So these are the various studies which has been conducted in type 1 and type 2 diabetes mellitus, showing various efficacy. I will not go into deep into each and everything. Second option are vasoactive agents, injection papaverine, quintolamine, or PGE1, alone or in combination are used. They are injected at the root of penis 2 inches from the glands with insulin syringe. Erection occurs within 10 to 30 minutes and lasts till ejaculation. Sometimes the ejaculation, sometimes erection may last for 2 to 3 hours, leading to priapism. Side effects are pain, priapism, fibrosis after multiple injections. The injection should not be repeated within 2 weeks. Medicated urethral system for erection, that is MUSI, alprostadil, is a PGA preparation in a pellet form. It should be inserted with a plunger-like mechanism into urethra. Efficacy is poor. Near about 30% patients, they report satisfaction. Side effects involve pain at local site where you insert into urethra. VCD compression devices. Penis is inserted in a cylindrical tube and suction is applied from other end by hand-operated pump. Expansion of sinusoidal spaces, just to say. Suction band is applied at the root of penis. Side effects include pain, bruises, and penile numbness. This advantage is that it is on demand and it doesn't have any contraindications. Surgical treatment involves microvascular arterial bypass and venous ligation and penile prosthesis. I will not be going deep in surgical treatment as rest of the speakers have already covered surgical treatment. So this flow diagram shows the treatment options in erectile dysfunction. Assess and modify life risk factors, identify and treat the hormonal disorders, educate and counsel the patients and partner. If it doesn't work, we have an option of phosphodiesterase 5 inhibitors. If there is no adequate response, satisfaction and side effects, then we have an option of intracavernosal injection and intraurethral alprostadil. We need to again assess the treatment response and satisfaction. If despite of everything it doesn't work, then penile prosthesis implantation and penile revascularization can be the option. So take-home message will be: diabetes is the leading cause of ED. Do ask for the symptoms of ED for every patient of diabetes mellitus. And ED is a zero-cost predictor of cardiovascular risk. Thank you.
Thanks, Dr. Hambire, for your splendid presentation. Dear audience, you will agree with me. Dr. Hambire has made a very elaborate presentation on the topic of erectile dysfunction. He has covered all aspects, right from the physiology of erection to the various risk factors, how to investigate, how to manage this disorder. He has made it very lucid presentation and has left no scope for asking any questions. But still, if somebody has got questions or comments, one or two will be welcome.
Sir, one question.
Yes.
During in your clinical practice, do you really think of sexual function before prescribing the medications for diabetes?
The sex is a private thing in India. Most of the patients, unless and until we ask for, they do not give the sexual history. So most of the patients, they come to the OPD with vague complaints, saying that diabetes is not controlled and I am getting weird sensation. Whenever they go haywire, you need to think that the patient might be having a sexual complaint, and we need to ask upfront that whether you have got a sexual dysfunction. And whenever the sexual dysfunction is there, we need to definitely evaluate the cause of sexual dysfunction. As I told, the crux of my presentation is that we need to take this as a zero-cost predictor for CV. Most of the patients who suffer complaints of erectile dysfunction, they generally have got a high HbA1c values. And if you say that I am going to prescribe you insulin for sake of mitigating the risk of coronary artery disease or cerebrovascular disease, patient will say that no sir, you manage me with tablets. The moment I say that you might get erectile dysfunction with this, patient gets convinced for starting insulin therapy. So erectile dysfunction for me is to convince the patient for insulin, and patient generally they get convinced for insulin.
Thank you, sir, for your elaborate presentation.
Thank you.
I have one doubt. You said about the good glycemic control. Will you define more, sir? Because many physicians, many diabetologists convinced when their blood sugar level more than 200, they are going on. Is it enough, or we have to bring it down?
Rather than saying individual readings, like sometimes your fasting blood sugar can be 150, next day it can be 100. So 100 you will term as it is a good glycemic control, and next day it can be 200. So rather than targeting individual values on a particular day, I will say that you should target HbA1c, which is a good target to achieve in case of HbA1c. Look, HbA1c again has to be individualized. Suppose I am treating a patient who is 50 years male, who has got a cardiovascular risk factor. I will still say that HbA1c should be less than 7. If suppose I am treating a patient of 65 having neuropathy, who has got again a comorbidity of say stroke or something like that, along with neuropathy, who is having hypoglycemia unawareness, I would like to keep HbA1c around 7 to 7.5, because such patients may respond late to hypoglycemia, and that can create a catastrophe. So HbA1c goal has to be individualized depending on your response, your education levels, and your comorbidities.
Dr. Datta, very nice presentation. Couple of things. Number one, as you said, in the history, normally you don't include the sexual health as a part of diabetic management. But if you include, you will get a good obligation from patient and their partners as well.
Yes.
Number one.
True.
And number two, the frequency of ECVAD that you have mentioned, the intracavernosous injection, the frequency, you have mentioned somewhere once in 2 weeks or something.
It should not be repeated prior to 2 weeks.
Normally, it's not so. Whether it is a diagnostic or therapeutic use of intracavernous injections, normally the word of caution is not to repeat in 24 hours. But more frequent, I mean, if they use say twice a week or thrice a week as per their need, it's perfectly permissible and will not cause any problem.
Only concern is that these repeated injections can lead to fibrosis, local pain and all.
Yes, I mean, depending on depending on person's need, one can always modulate it. Thank you.
Yes, Asha. Look, phosphodiesterase inhibitor is something like which acts instantly. No. Look, as I told that your target HbA1c should be less than 7. Plus, if you are treating a erectile dysfunction, look, sugar levels in father, probably as I have concerned, you should not be bothered about. Sugar levels in mother, you must be more concerned about. So despite his HbA1c is 8, and if he starts taking phosphodiesterase 5 inhibitors, and if he gets a good erection, there is no harm. it is a medicine which acts within 30 to 60 minutes of taking pill. Yeah, it's multifactorial. That's why I told you that PDS 5 inhibitors are drug of choice for broad ranges. Once you start taking, patient gets the erection. The range of success rate is around up to 90%. Yes. Look, if you give a target to any patient that you need to have a physical intercourse during this time, this is going to always create anxiety. Yes. Yes, sir.
So then only the children will go. She wants.
No, sir. Most of the complications they will not be fully reversible. But what we want is it should not get deteriorated. Likewise, I told you these phosphatase inhibitors, along with some of the other medicine that I already mentioned, that which has got a favorable outcome on the male sexuality, will definitely will at least if you see the international erectile function score, if you compare this one, this will definitely improve over a period of time. Yes. Once you start taking, but look, what Madam told me, asked that what is the time period before it starts? It starts instantaneously.
I think we'll close the session over here because we are encroaching upon the next speaker's time. The fact that so many questions have been raised proves the point that Dr. Hamirez's topic was very interesting and he's made it very interesting.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you very much. I would like to call upon Dr. P.N. Shinde, Head of the Department of Gynecology Department at VishwaRaj Hospital, to felicitate our speaker, Dr. D.N. Ambire. I now request Dr. P.N. Shinde to felicitate our chairperson, Dr. Vasu Chavan. Thank you very much, sir. There is a situation, a couple has planned their activity and all of a sudden both of them are surprised. Like we had a discussion in the morning, sex in a surprising place. Now what if you had each and everything, but now the couple is surprised? So what do you do next? Same is the situation here. So our next topic is related to that, relevance of penile size for sexual intercourse. So for the next session, I would like to invite Dr. Aniket Zarkar to chair the session. Dr. Aniket Zarkar is the head of the Department of Surgery at VishwaRaj Hospital. I request our chairperson, Dr. Aniket Zarkar, to introduce the next faculty. Over to you, sir.
Good afternoon, everyone. I would like to call upon Dr. Amit Mutha, sir. He is a senior consultant. He is an associate professor of Grant Medical College, and he is eminent professor. He is working at various places, and he is a known sexologist. Please, sir, continue your talk.
Thank you for that kind introduction.
I request Dr. Parag Gulane to chair this session. He is a urologist working at VishwaRaj Hospital. Sir, kindly come on the dais, please.
It's almost every male's fascination with the size of penis, and at some point in time every male thinks about it, whether small, large, measures, particularly during the growing up years. And I have come across patients who are worried in their 70s and 80s also. सर छोटा हो गया, सिकुड़ गया, तो छोटा हुआ है कि सिकुड़ गया है कि क्या है, और असलियत क्या है, और what is reality and what is scientific, that is I am going to talk about. So to begin with introduction, the erect state of penis is masculinity. If you see patients from rural areas, they will say that sir mardana ताकत कम हो गई है, mardana मतलब erection कम हो गया है. So that is how they describe. In many cultures, the penis size has been attributed with such as largeness, strengthness, endurance, ability, courage, intelligence, knowledge, dominance over fellow men, possession of women, a symbolic love and being loved. Some concepts date back to thousands of years, like right from the caveman's time. Indian sadhus using weights to increase their penile length and girth. Dayak men in Borneo of the Indonesian islands, piercing glands and inserting items in resultant holes to stimulate the partner. Topiama men, Brazil, get bitten their penis with poisonous snakes so that because of the inflammation it gets enlarged for 6 months. Prehistoric cave dwellers, symbolic values of strength and power to penile size, as well as virility and fertility also mentioned in our renowned Kama Sutra by Vatsayana. It is no surprise, even men today place great importance on the size of penis. No two penises are same. I have come across patients who both father and son have come to me as a patient. Initially, the son came and because of some reason, the father later, he also came as a patient. And even father son don't have the same penis, exactly same dimension, they are different. It's just like our thumbs are different, our penis are also very independently different, not exactly the same dimensions. Sorry because of this. So men with a larger penis have the greater length and circumference have better body image, genital image, feeling of a greater sexual competence and confidence, which is very obvious and psychological. Women do not necessarily believe that a larger penis is better. It has shown that 90% of women prefer a thick penis to a longer one. The issue of attractiveness to women is complex. Penile size is much lower in the list of priorities, but it does matter. That many people and many researchers claim, but I think adequate size of penis definitely matters. Smaller penis has its own problem. Then man's personality and external grooming. So this is all being done and talked about, and there are various surveys, internet-based surveys who have carried out these studies, and particularly I would like to highlight on this. A huge, beefy, muscular guy doesn't mean having a long or large penis. He might also have a small penis. And particularly true about those who are on anabolic steroids. They, depending on the duration of anabolic steroids they are on, their testicular sizes, their ball size goes down, the scrotal sac also becomes smaller one. And this is not some fantasy, these are real patients I have come across. Then coming to penile dysmorphic disorder, it's a part of a bigger body dysmorphic disorder where the patient, in spite of having a normal penis, he is obsessed that his penis size, he has some lacunae in his penis, the lengthwise, girthwise or angle-wise. Men diagnosed with body dysmorphic disorder, the size and shape of the penis is their main concern, causing significant shame or handicap. No specific measures for identifying with men with penile dysmorphic disorder compared to men anxious about size of their penis, but they do not have penile dysmorphic disorder. Such a measure is helpful for treatment planning, reducing unrealistic expectation, measuring outcome for any psychological or physical intervention. So you have to as a physician, you have to work more with people having penile dysmorphic disorder. Based on my experience, I just judge whether he needs a psychiatric opinion or not, and I prefer to refer such patients to a psychiatric rather than manage myself. Size shame, also known as small penis syndrome, which is the most common in a OPD of a sexual medicine consultant. Men who have a normal size penis but experience shame about its size, and it is particularly driven by comparison when somebody sees the phallus of a person urinating in a common urinal. Sometimes the next person might be experiencing an hard-on erection, so his penis appears bigger to this person who has a soft penis and it is not erect. So this is how it is. The seeds of what you can say is inferiority complex as far as penis size is concerned is sown into the person's mind. The medical definition excludes men who have a micropenis of less than 7.5 centimeter erect length less than 4 centimeter of flaccid state. Coming to definition of small penis syndrome, anxiety about genitals being observed directly or indirectly when clothed because of the concern that flaccid length and girth is less than normal for an adult male despite evidence from a clinical examination to the contrary. An obsessive rumination, part of a body dysmorphic disorder or a psychosis. The degree of emotional distress and behavioral impairment is much greater than the defect sensed within the self. Penile size is not an overtly acknowledged issue and is situational or context driven. So sometimes the patient might feel that his penis is normal and of adequate size, particularly in winters when there is a difference in temperature. Some people experience that their penis is, it quite shrinks or because of contractility of the erectile tissue. So that might lead to suddenly the patient might experience that his penis gone as berserk, it has become small. Embarrassment and fear of being scrutinized or mocked. So avoid social situations and intimate relationships. Victims of poor self-image, do not show sufficient social skills, are single or divorced. And some people might have not experienced a good hard-on erection because of lack of availability of a partner. This also can lead to lead for a thinking of the patient that the size has gone small. Coming to prevalence, a large internet-based survey was done where 52,000 men and women participated. Most women rated their penis as average, which is 66%, 22% as large, and 12% as small. Self-reported penile size was correlated positively with height, negatively with body fat. About 85% of the women were satisfied with their patient's penile size. Only 55% of men were satisfied, with 45% wanting it to be larger. Most women who reported their partners as small were not satisfied. So then that is an indication of there is some issue, definite issue. But I would like to share one particular clinical experience here. A lady married, both husband and wife, they were residing in Pune, and they had been to many people and normal guys, but both of them had a second marriage. A failed first marriage for both of them. The reasons of the first failed marriage were different. But for the lady, she was not, I did everything possible and the patient had a perfectly normal penis size, girth-wise and length-wise, 6 inches plus and everything. But the female was like blaming right in front of me. Sir, ये तो बच्चे जैसा है, बच्चे जैसा है. बच्चे जैसा है, then I had to talk a one-to-one session. In that, the lady revealed that I asked her why she divorced the first husband. She said that because of the in-laws, our mother and this first husband was a mama's boy. Okay, then how was your sex life? It was excellent, terrific. We had very good sex, and his organ was big. So she was comparing this normal penis with that endowed penis. So this is how the things play out. You have to delve into the details of the background of the reasons of people's behavior. Men reporting a larger than average also rated their appearance favorably. The men's general body image influenced their estimates of size. So this is a scale for objective analysis, 10 items: depression, anxiety, body image, quality of life, social anxiety, erectile function, overall satisfaction, importance attached to size. So it was not found to correlate with actual size, able to discriminate between those who had concerns or they were dissatisfied about their size and who were not. BAPS measures manifestations of masculinity and shame, internal self-evaluation, negative evaluation by others, anticipated consequences of a perceived small penis. Not anthropometric characteristics, a systemic review. The top level of evidence is a meta-analysis and a systemic review. So this systemic review of various studies published globally about penile size was done. An average flaccid length of 3.6 inches, circumference of 3.7 inches, stretch length of 5.2 inches, erectile length of 5.1 inches, erect circumference of 4.5 inches, stretched penile length correlated highly with erect penile length, provide a useful tool in clinical practice to illustrate variation in penile size. So this is how many people they commit mistake while measuring the penis, even doctors. Actual thing is that you have to, from the root of penis to the tip of the glans. That is the actual measurement. What they do is just the exposed surface of penile shaft to tip of the penis. So that gives a wrong impression about penile size. These are the various studies, only one from Kerala and the sample size was very less. From India there was only one study, that too from Kerala. And the sample size was less and it cannot be applicable to the entire geographical extent of India. So etiology, SPS or locker room syndrome origin is in childhood. The young boy observes a larger phallus of an elder sibling or a friend or a father. Relationship with others, fears and anxieties about penile size arise after breakdown of the relationship. As I said in that example, after derogatory or malicious remarks by a partner during sexual activity. Arey, itna chota hai kya? This is a very casual remark, particularly those visiting prostitutes, and the women are into business, they want more customers. So if they don't like a person, they will just make a random comment, Arey, tumhara to itna chota hai, or whatever. So that hits the person hard. Developmental issues for men with poorly developed and small testicles. The problem might be attenuated with a smaller ball sac. General confidence can be impaired if there are small testicles. History of congenital abnormalities, hypospadiasis, commonly I come across. Epispadiasis, I have come across 4 cases in these last 12 years and only 1 cases of completely exposed dorsal surface of the penis, complete epispadiasis. And the couple was married for 5 years and they sought multiple consultation, but nobody bothered to examine or find out, and this complete epispadiasis was the reason for unconsummated marriage. These are all real cases. This is the infantile penis. The boy is around 18-20-year-old, brought to me by concerned parents, and this is the penis even after injecting intracavernous vasoactive drugs. This is definition of fits into the definition criteria of micropenis, less than 7.5 centimeter. This patient had around 6.8 centimeters of penile length. Then this is not exactly small, maybe workable, but it is not up to the mark. It's around 4 inches. Pretty okay. Not I cannot say that it's a micropenis, but definitely size is a concern for this patient because the wife was also complaining that she is not able to feel the penis. Then this is Peyronie's disease. You can see both different. In the first one, this particular case, 72-year-old male, going for the 4th marriage. He comes from Middle East. Never experienced sex last 5 years, but somehow he has an opportunity of marrying a young girl, 22-year-old something, and he says, Doctor Saab, mujhe kam se kam 4 bacche hona chahiye. You should make me that way. Then this is what we got after intracavernous therapy. I put him on a regular intracavernous therapy because he was not responding to tadalafil and sildenafil. Basically a failure case which is quite common these days. So if you observe properly, here this is Peyronie's plaque and here too. So somehow with huge plaques he was able to get a good stiff hard erection. Otherwise with such big plaques there is an angulation which I will be showing you in the next slide. Here. This patient also had not a huge plaque but multiple small plaques and resulted into this curvature over here, and he was not able to penetrate. First of all he was not able to get stiff hard erection like this. This is stiff hard erection, and this angulation, because of this he is not able to enter the wife. his partner. So I advised some changes in his position, and he was able to enter the partner. Now this is the shaft is normal, but because the ball sac is small, the perception is of a small penis. And this too, small sac but normal sized penis. Severe fungal infections also can lead to sometimes the perception of a small penis. So very bad. The normal sized, normal characteristics of the penile anthropometric measurements, but the fungal infection is so severe that it is unsightly and gives a feeling that it has become small. Now coming to etiological factors, psychiatric disorders, obsessive compulsive disorders, social phobia, anxiety, depression, body dysmorphic disorder, sexual dysfunction, again inadequate. This is another common reason for perception that the penis has become small or shrunk. There is inadequate erection, insufficient rigidity, that automatically the penis is not as big as earlier when used to experience complete hard erection. So that is one of the reasons. Then other factors in obese men, again this is one of the common presentation where there is a dual factors of perspective issue and the presence of significant suprapubic fat leading to buried penis, concerns of high levels of female sex hormones and industrial pollutants in water, particularly people in vigorous gymmers, they are taking various types of gym supplements, particularly those who are on whey proteins, which the source is soya protein. Soya is known to increase E2 levels. So the increased fat deposition is also seen. So this is buried penis. Normal size shaft was seen on erection, but while presentation it was buried. This is another one of the reasons for a smaller shaft, corrected hypospadiasis, where the opening from the mid shaft is brought to the tip of the penis, leading to a slight shortening of the penis. Now this very interesting case, this patient was referred to me because of a long-standing issue, and suddenly both husband and wife want to have sex. He was in mid-50s. This fellow never experienced erection for last 3-4 years. He was an operated case of complete colectomy because of his lower GI cancer, large intestine cancer. And because of various reasons they were not indulging in sex. Now since he was certified by his oncologist that your cancer is, you should not be worried about it, suddenly he started wanting to have sex and with his partner. When I injected with the intracavernous therapy, again typically he was not tolerating the PDE5 inhibitors, so I put him on intracavernous therapy. He experienced a very wonderful erection in last 4-5 years, and because of he was complaining that his penis has gone small. The reason was that he was not getting erection. So this was more than 7 inches shaft, perfectly normal, rigid, hard erection. Now most patients are concerned about the flaccid state. They describe feeling insecure, anxious, low in mood, impairing day-to-day functioning, display social phobia, avoiding men's urinals, common showers, swimwear, stable relationships. Increase in men concerned with erect size who know they are normal but want to be larger. These are porn affected or inflicted. Pornography shows unrealistic, highly endowed men, which is not actually a real thing. They can, because of various camera angles or some other stuff, or maybe nowadays they are injecting the hyaluronic acid to make it appear thicker and bulkier. Online sexual images and advanced cosmetic procedures offering length and girth enhancement. Societal influences, impact of internet is pervasive, can occur both online and offline. It is less common to develop small penis syndrome in adulthood, but they do get when they are in comparative mode with their peers. Assessment. The clinician must determine whether the main concern is flaccid or erect length. If girth is a significant concern, a full medical psychosexual and psychiatric history should be undertaken. I prefer to refer the psychiatric cases to a psychiatrist. Specific things to be explored, but appearance and body image is very important. General beliefs, values, assumptions and behaviors around genitals and sexuality should be inquired. How does this affect man? Should be probed. What is he unable to do in his life that bothers him? Again, there are variables. Only a few minutes, couple of minutes. Can he use public toilets? Actual paraneuralsis might occur for many men and might need specific treatment. So, swimming or participate in athletes, does he avoid a potential partner because he is afraid of his own small, less endowed organ? Most men have a normal sex drive but might have a partner. Has he avoided certain occupations if the man is in relationship? Psychological profile scores might be helpful to assess self-confidence, self-esteem, quality of life, social anxiety and symptom distress. If physical examination is paramount, detailed genital examination with careful exclusion of genuine penile anomalies such as hypospadiasis, epispadiasis and Peyronie's disease. Presence of significant suprapubic fat pad should be noted. Careful measurements of the flaccid length, straight length and flaccid girth should be seen. If the erect size, particularly of girth, is an issue, then measurements for intracavernous alpha-stadial trimix are also helpful. And as endocrine abnormalities can cause true micropenis, a general assessment of secondary sexual characteristics is very valuable. So management, normalize and provide education. Most of the patient needs reassurance, and if they experience hard-on erection, good erection, their anxiety about penile size will go down if they had a normal size to begin with. Then mirror work, the perception in mirror changes just like this size of a mirror. So when you see face to face and see it sideways, the perception changes. Can be done in home or clinic. Useful for a man who avoids looking at himself naked. Now coming to psychological therapies. Psychotherapy is very important in men with concerns having small penis. Again, cognitive behavioral therapy can be used for building confidence and counteracting negative thoughts, which might be perception driven. Physical treatments, which include vacuum erection devices, basically they are advised as a penile enlargement devices by some practitioners, which is highly unethical according to my understanding. Then you have penile extenders, traction devices, spinoscratal and penile rings. Evidence on their efficacy is very limited and the patient should be aware of this. At least we as a physician should make the patient aware of these things. Vacuum erection devices are used as a treatment for ED but can be used to exercise the penis also. But again, marketing it as a way of increasing the length is unethical, I feel. Psychological and uplifting effect for patient, but evidence suggests minimal physical change. Medications, we are all aware, SSRIs, fluoxetine, buspirone for anxiety component. Then you have antipsychotics for body dysmorphic disorders. Treatment is minimum 8 weeks on SSRIs or adjunctive treatment with buspirone or pimozide. Testosterone therapy is only valuable for micropenis. Patients with micropenis. Some of the patients have improved. Self-help resources, inevitably many men, they will seek the physician help in this regard very later. They will consult people who are not specialists or maybe, there are all types of practitioners. Plus we have highest number of quacks practicing in India. Quacks, by quacks I mean those who don't have any healthcare degree. The quacks who are the real quacks and not the medical practice degrees. Small is beautiful and smaller can be celebrated by both men and his partner has been highlighted by the Greco-Roman sculptors. They are not well endowed. This is Poseidon, Zeus 43-6 BC in Greek. If you see the Greek sculptors, all have less endowed genitals, smaller genitals. This is Rome, Italy, the fairness of Hercules, 3rd century BC. Surgical management, I'm not going into the details, several techniques have been described about bulking the penis with hyaluronic acid or fat grafts and this and that, but they are not, they don't provide any long-term solutions. And most of the people who have been, a doctor had undergone recently with this dermal flat. He had a normal organ according to me, but still he was advised a dermal fat, and he had subjected himself to it. He came to Pune from Mumbai and came to see me after doing that. Then after doing that, what can I say? Why you did, what you did, in spite of understanding whether it was needed or not needed. Large spectrum of surgical procedures are available. Suspensory ligament surgery is one such thing. It will increase the length by 1 to 1.5 inches. But in my opinion, the stability offered by a suspensory ligament to the penile shaft is more important than the length enhancement offered by releasing the suspensory ligament. Injection of autologous fat cells, as I said, along with usual operative risks, specific risks such as paradoxical penile shortening is also observed, altered sensation and post-operative erectile dysfunction. Particularly, this is also seen with post-operative erectile dysfunction with penile implant surgeries. Careful patient selection and full assessment of patient expectations are essential. Conclusion: SPS is distressing and invalidating syndrome. More research is required on the effects of race and age on penile length, conservative approaches to therapy, education and self-awareness, as well as psychotherapy. There is poorly documented evidence to support the use of penile extenders. Dividing the suspensory ligament can increase flaccid penile length, but it has its own disadvantages. Limited data relating to the operations designed to enhance penile circumference. Effect of surgical treatment on penile dimensions. There is much less information about patient satisfaction with the outcome of surgery. Multidisciplinary team approach for assessment and treatment is recommended. So take men with SPS seriously. They suffer from a great distress and pursue. See, not only this is true about small penis syndrome. It is true about any patient who is complaining that he has some sexual issues. It's a normal practice of practitioners also to brush that. अरे कुछ नहीं ये सब दिमाग में ऐसा नहीं. His concerns are genuine, whether it is psychological or otherwise. But the concern is genuine and that needs to be addressed properly, scientifically, with appropriate management. All men with SPS should be referred to a specialized psychologist or a sexologist for psychological and sexual assessment before deciding which treatment to propose. Psychoeducation using normograms and pictures. If negative perception and cognitions as well as unrealistic expectations are present, counseling or more extensive psychological treatment is required. Recommendations: SSRIs and psychiatric consultation for BDD or psychosis. Use of penile extender devices should be offered only for highly motivated men. And after 11 o'clock, most of the TV channels are flooded with penile extenders. Do not perform surgical treatment because of risk of dissatisfaction with the results or shifting of the problem to another area of or body. Surgery performed after thorough biopsychosocial history taking, extensive psychoeducation, careful exploration of concerns and post-operative expansions. And most to remember that the vagina is an organ which is designed to accommodate all the sizes of penis. If something is not getting accommodated size-wise, it needs to be addressed. Thank you.
Thank you so much, sir. Any questions from the audience? So I would like to ask you one question. If at all you feel any of your patient, say if at all you feel any of your patient needs a physical therapy, which therapy would you rely on, or means which therapy you used most commonly in your practice?
You mean penile enhancement?
Yeah, physical therapy apart from behavioral therapy, apart from medical treatment. If at all you feel,
if at all a person requires enhancement in size, I will refer to a plastic surgeon who will do for length. He will do a suspensory ligament release surgery, or for girth enhancement, the fat grafts, or which are temporary in nature. Fat graft or hyaluronic acid can be injected.
Before that, sir, have you ever tried for vacuum or any other physical form?
Vacuum erection device, I feel it is not useful for length enhancing. It will just increase the perception by inducing an erection, which can be done by using drugs for enhancing the erection.
Thank you. Thank you, sir. Any questions from the audience? Okay, fine. So we thank you, Dr. Mutha, sir. It was really a very valuable presentation. Thank you so much. You covered all the points very well. Thank you.
Thank you very much, sir. It was a nice presentation. I think the audience would have got the idea of the relevant size. Small doesn't matter, large also doesn't matter. This could have been just a take-home message for all the audience. I would now like to invite Dr. Nanakunji to felicitate our speaker, Dr. Mutha. Dr. Nanakunji is chest physician at VishwaRaj Hospital. Please continue, sir. I now request Dr. Nanakunji to felicitate our chairpersons, Dr. Parag Gulane. I now request Dr. Nanakunji to felicitate our next chairperson, Dr. Anikesh Zarkar. Thank you, sir. Thank you very much. Last week, a young 50-year male came to my OPD with a very small complaint that his genital area is not looking so good. He complained, actually his wife expired 10 years back. He was alone. He found a partner. He told that his partner is not liking the area. So then they started blaming each other. He told that now our relationship is not going well. So how can I improve? So with this thing in my mind, let's continue with the next topic, pleasure hygiene. Just an announcement from Dr. Mutha.
We are conducting the 40th National Conference of Sexology in this our own very city, Pune. The dates will be probably will be announced, exact dates, but it will be in the month of September. So all the audience, please gear up for this academic event. Thank you.
For the next session, I would like to invite Dr. Umesh Nagre to chair the session. He is head of the orthopedic departments at VishwaRaj Hospital. I would like to invite Dr. Chagan Khatode. He is physician at VishwaRaj Hospital to chair the session. I request chairperson to introduce the next faculty. Thank you, sir. Over to you.
Good afternoon, everyone. This is the first time I am attending such conference as an orthopedic surgeon. It's a pleasure to attend such events, and I'm glad to introduce a very eminent faculty, Dr. S. Murugan. He is a consultant in sexual medicine and HIV medicine, practicing in Shifa Hospital, Tamil Nadu. Sir, it's a great honor to have you here, and he is a consultant in sexual medicine. He is a former professor of dermatology and venereology in Sri Mukambika Institute of Medical Sciences, and he is executive member of lots of societies. He is awarded Oration of Silver Jubilee Institute of Venereology and Lifetime Achievement Award Shaft 2023, and he is reviewer for 3 international journals. And person like him having on the podium is one of the best thing we can have. Sir, mic to you. Thank you.
Thank you, Chairperson, for your wonderful introduction. Good afternoon. Good afternoon, everybody. At the outset, I thank the organizers, Dr. Sanjay, Dr. Pathan, for inviting me to meet you all in this city, Pune. It's a good thing. And today my talk is pleasure hygiene. Genital hygiene is the one basic thing, neglected thing. Sex is always a pleasurable thing for human beings. It should not be miserable. And the genital hygiene, basic thing, we have to observe to keep it more pleasurable forever. We teach our children how to brush their teeth. We teach our children how to take bath. Do we teach our children how to clean their genitals, which is more important than others? Naturally, as it is a way of expulsion of the excreta also. When the parents don't know themselves, even medical people, of course, there are differences between men and women. We don't have sex education in our curriculum, both in schools, colleges, even in medical curriculum, it's not covered a lot. So, naturally, challenges in men. I am going to talk about the genital hygiene in men, women and children. Lack of sex education in schools and colleges. Parents' role, they have to know themselves about their genitals and teach the children from the childhood onwards. Men have the common passage for both the excretory and reproductive system. So naturally it has to give more attention. Variations of the prepuce, long, tight, retracted prepuce, adhesions, phimosis are all common. So variations. Presence of smegma, many not knowing to importance of the cleaning of the smegma. All these things I am going to cover. Lining epithelium of the urethra in men, especially in hypospadias and epispadias individual. Normally, prepuce becomes retractable from the age of 1 to 2 years. We can educate the child to retract the foreskin from the age of 5 to 6 years onwards. But we should not try to retract forcibly. That may lead to the child have a phobia, never attempts to retract. Some will get retracted only during puberty period. 1% of the individual will never be able to retract. That's called as congenital phimosis. Many don't know that foreskin is retractable even at the age of their last, that is even the age of old age. Prepuce is not a vestigial organ. It protects the sensation and texture of the glans penis and coronal ridges forever. Protects from the trauma and abrasion. Keeps the natural moisturizing effects safely. People with hypospadias are more prone for infections. It offers extra protection for them, the prepuce. The extra skin is useful reserve in some urethroplasty and skin graft. So keep it in mind. So it's also protects from friction and dryness, preserve the color, sensitivity and texture of the glans penis, ultimately restores the integrity of special receptors. Intact prepuce is about 4 times more sensitive than a circumcised glans penis. Phimosis, inability to retract the prepuce. It could be a congenital or it could be a inflammatory. Circumcision and smegma, we'll talk. Paraphimosis, inability to put forth back the prepuce. So that is also very important. It is usually follows with a tight prepuce or sometimes secondary to some ulcerative condition or some swelling of glans penis due to growth or something like that. So it has to be, sometimes it may be very anxious, the patient will be very maturing, and it can be easily reduced by multiple puncture technique. Role of circumcision. Congenital phimosis, tight prepuce and prepuce adhesions are indications for circumcision. Inflammatory phimosis, correct the basic so we have to attend that. When it is healing, sometimes it may be okay. If it is not reverse, if it is not, even then it is very difficult to manage, then we have to go for circumcision. Try to preserve as far as possible. Serves as a reserve source of skin graft, already I told. And the prepuce has a role in sex play. Presence will enhance the pleasure of both sex, the rolling movement. Prepuce has a protective act for the glans penis, and regular cleaning is very important. Plain water is enough. Better avoid soaps and other chemicals inside the foreskin. Even people use cleaning before and after sexual act is preferable. Includes coronal sulcus, inner aspect and outer aspect of the entire prepuce. Pissing immediately after intercourse is also recommended. If you follow above, circumcision usually not necessary. Smegma. Smegma may be appearing. Smegma sebaceous modified. I am not touching. Smegma is secreted by a pair of glands called the Tyson's gland on either side of the frenum, and this is a modified sebaceous gland and tissue debris along with some non-pathogenic mycobacterium that is called as smegma acid. That is a mycobacterium smegmatis. In the corners, I have to keep around the ridge of the coronal sulcus. It is penile polypapule, and near the frenum, that something is appearing. That is the opening of the Tyson's gland. It may be present some people, it may not be visible in some patients. Smegma protection increases from adolescent to young adults, and also it has to be only when they are retracted prepuce, it may not be present. In circumcised individual, it may not be seen. Otherwise, it will be seen. Smegma was found to be risk factor for penile cancer and also cervical cancer. Both males and females. In males, smegma will be produced, accumulates under the foreskin. In females, it collects around the clitoris and clitoral hood. It contains the commensal atypical mycobacterium, that is smegmatis. Incidence of cancer cervix and penis is almost nil in Jews community and negligible in Muslim community. So that is in clinical importance. Because of this acid fast bacteria, when the patient collects urine for TB, it may contaminate and give a false positive result. Presence of smegma in the introitus is a sign for intercourse, that is in the court of law. So, common inflammation, that is, it can produce Zun's balanitis and also sometimes smegma lith. It is a hard substance under the prepuce, radio opaque, and it may cause dyspareunia. And hypospadias and epispadias individual will lack the terminal squamous epithelium lining of 12 millimeter that offers the squamous epithelium offer good resistance against bacterial infection, which is lacking in the hypospadias individual. So here also the prepuce offers a good quality of protection. And circumcision is to be avoided as far as possible. But hypospadias individual, it has to be maintained. It has to be kept. Chordy curvature of the penis during erection. The hypospadias individual will have a shorter penis, epispadias, hypospadias comparatively. So because of that, during erection, they will have a curvature, it's called as chordy. And infertility in extreme degree of hypospadias because they are not able to deposit the semen in the correct place. Paraurethral duct, sometimes 2 openings may be present. So that is also common. So you can see in the near the hypospadias and another opening is there. So paraurethral duct opening will be there. So that's also more vulnerable for infection. So now genital hygiene. In a child, weekly once cleaning may be enough. Since adolescent, daily cleaning is preferable. Trained to visualize the cornal sulcus. Everybody, if you say, I am clean, I am washing, I am taking bath, then nobody will accept that they are not clean. So we have to train them. Train to visualize the cornal sulcus, demonstrate on the patient. Otherwise, they will be afraid of pull it back completely. They don't know. It has to be exposed, the cornal sulcus has to be exposed. Inner aspect also, folds should be clean. Clean with plain water, enough. Not to use soap or irritant. Some individuals live with phimosis even the late years, but don't take risk. Pissing and washing after coitus will always be helpful. If you follow this, usually circumcision will not be necessary. So this is the way to retract. We have to demonstrate this in patients. Retract completely and expose the cornal sulcus and inner aspect of the prepuce. Otherwise, the cleaning will not be complete. That is very important. So similarly, and variations may be there. Some people may have retracted prepuce also. So irritant pyelonoposthitis, what are the hazards of non-cleaning? The patient may have irritant pyelonoposthitis, Zun's pyelonoposthitis, cancer penis, cancer cervix in the partner, dyspareunia, infection to the partner, subpreputial infection, all can occur. One more thing, when the patient is phimotic, it is difficult to clean. Some patient may have phimotic. We will refer to circumcision. Till then, they have to clean. So for they have to find time to go for surgery. So till then, they have to clean. How to clean? So this is subpreputial discharge. Sometimes the infection, it is not gonococcal infection. It is the space in between the prepuce is get infected, secondary organism. So it has to be clean. That we used to advise, stretch the prepuce forward beyond the urinary opening or glands and close it and ask him to urinate and release it. Once again, close it and release it. During one act of maturation, they can do with 2 or 3 times. So by doing that, the urine will collect inside and it will clean. So by which they can clean themselves. So now genital hygiene in women. Challenges in women: shorter urethra, they are having menstrual habit, usage of sanitary pads, sexual activities, close approximation of vaginal opening, urinal opening and anal orifice, and foreign bodies can be remain. So, for example, exposed to foreign bodies, condom, tampons, menstrual cups and others. Every time after toileting, inadequate and intolerant restroom facilities, lack of privacy to change pads, faulty washing habits, all these things are posing more challenges. Apart from that, more area is exposed during sexual act. Receiving infectious materials remain more time in spite of vagina have a capacity for self-cleaning and spontaneous cleaning is there, but in spite of that, it remains more time, not able to visualize their own external genitals and also intragenitals, nobody can visualize themselves, but even extra genitals also in obese person, in pregnant women, they may not be able to see themselves. Difference between the child and the adults, the pH difference is there, the lining epithelium is difference there, so because the child is more vulnerable for infection. So 50% of the girls does not know about the menstruation before they have one, and 16% of the women girls use sanitary pads. The 16% only they are using because of the cost, and 28% of the women girls in Indonesia miss their work because of menstruation, and in Nepal they will not attend the gathering during menstruation, and many people will drop out from school education because of menstruation. How can we help? Access to proper sanitary facilities, bathroom and many places, it has to be neat and clean and should be available, water facilities need. So then only they can care themselves. So the women, the genital cleaning includes normal daily cleansing, menstrual hygiene, sexual hygiene, care during circumstances like vaginal discharge, infections over the extremes of age. Day-to-day hygiene, clean vulva and vagina with plain water after micturition to avoid smelling. Every time they have to clean after using toilet. Wash from the front to back, never to back to front. So that is very important. Most of the people will not know. So from the back to front, when they are cleaning, they may lodge the fecal material to their genitals. So many girls, pre-pubertal girls or even prior to sex, they may have some problem of itching or void discharge. They may be due to false washing technique only. And use soap sparingly. Taken care to clean the folds of the labia also. And pad dry with a small cotton cloth or tissue paper after washing. Use loose fitting cotton wears. They have to use. Change underwears at least once daily, twice during humid condition. Avoid forcible washing, high pressure jets of water and vaginal wash, and harsh chemicals, soaps not to be used, frequent douching not necessary. Pubic hair removal. Many people thought that the removal of hair is hygienic. It's not so. It offers a cushion and protective barrier for the vulva. So if opted for removal, it has to be trimmed rather than shaving. And if you opt for shaving, use one-time disposable thing and adequate light and one direction only. And waxing, repeated waxing may lead to folliculitis. Depilatory creams to be avoided because of irritation and sensitization. Laser hair removal may opt for sometimes permanent, semi-permanent method. Hygiene tips during menstruation. Change sanitary pads every 6 to 8 hours. Safe disposal of used sanitary pads is also very important because of the blood transfused, blood-borne diseases, maybe HIV, hepatitis, all these things. So it has to be disposed as incinerated or deep buried. Hand washing after changing sanitary towel before and after, that is very important. And using tampons, do not forget to remove that. Sometimes forgotten, left it inside. and twice day bathing during the menstrual time is preferable. And other things like using tampons, menstrual cups, also very comfortable for some people. Menstrual cups, they need not change every time. It may kept for even 12 hours, and it can be reused, and it's economic also. So we have to train them that they can go for menstrual cups. And so menstrual cups in session, we have to demonstrate them. Squeeze before the menstruation, they have to wash their hands and fold it, squeeze it, and introduce and fit it. Initially, it may be difficult. Once they have accustomed, it will be very comfortable, very useful, and very economic also. Sexual hygiene. Wash genital area before and after sexual intercourse. Use barrier protection always, unless you want to conceive. Though sexual intercourse can be attempted during menstruation, slight chances of infection is more. And there is, when you are using condom, lubricant, spermicidal jelly, sometimes it may be allergic or contact dermatitis or irritant dermatitis can occur. Avoid multiple sexual partners. Vulvovaginitis in children. Vaginal orifice is remain closer to anal orifice. Protective hair, vulval fat is not there. Poor hygiene among the children. They can sit on the floor without underwears in children. Usually, sometimes in the poor people. Children vulvovaginitis is more common. And symptoms will be pain, itching, burning around the vagina. Vaginal discharge may be present. Pain during maturation. Infants cannot take care themselves. Customs and fancies of their parents have influence. Usage of diapers, pampers, nowadays it is very much. Cleaning habits, mother's hand hygiene, all play an important role in child's morbidity. Washing habits of their genitals land on their own when their single parent is there, or sometimes mother is not well mentally oriented. So that is also have influence. Certain illness exclusively for infants, childhood infants like diarrheal disease, likewise also will influence. Vulvovaginitis in children can be caused by fungus, parasite, irritant applications, skin diseases, and sex abuse and foreign bodies. Economic conditions: not wearing innerwears, maceration, friction, playing with the objects, foreign bodies, worm infestation, and sex abuse also can produce vulvovaginitis. Diaper rash will not affect the folds, groin fold, whereas in others it will involve the groin folds also. It may be due to fungal or bacterial or all these things. Female infants and children wash genitalia with water after maturation and defecation. Dab dry with cloth or tissue. Avoid chemical douches. Gentle non-soap cleansers can be used. Cleaning should be done from front to back, not back to front. That is very important. We have to teach the children from childhood onwards. Remember, dry all the folds of the skin, and disposable diapers should be changed every few hours. Zinc oxide can be used as a preventive measure for the diaper rash. Genital hygiene in old people. Postmenopausal vulvar atrophy, because of hormonal decline may be there. They may have itching, and liberal use of moisturizers will help. Sometimes estrogen supplement creams also they can use. Avoidance of synthetic undergarments, and they have to attend the stress incontinence, control blood sugar levels. Overcare also, enthusiastic obsession also should be discouraged. Vaginal spray, deodorant spray, scent spray should be avoided as far as possible. They may lead to pigmentation and irritant and allergic rashes. Role of jet spray, very forcible jet spray may displace the bacteria inside, or sometimes it may displace the normal microflora and susceptible for infection. And P safe, using before toilet, another 2 slides. And before using the toilet, public train and flight, we can use the P safe. It can clean the seat. Vaginal spa usually recommended, in sometimes it is not recommended, and vaginal piercing also should be discouraged for fancy purpose. Sex education is very important from school days onwards. Genital hygiene should be stressed in this sex education. Regular cleaning and of genitals is necessary for happy, healthy, pleasurable sexual and reproductive life, and also in future. Over enthusiastic deeds will worsen the situation due to hypersensitivity, alteration of the pH, normal flora and ecosystem, make it vulnerable for infection and pathological conditions. Unnecessary obsession also is to be avoided. Avoid browsing, and Google will direct you, mislead you. And one more thing, Dr. Sanjay was telling ugly, that is, look, my genitals are looking ugly. So that is due to so many conditions, vitiligo, fungal infection, and so many things. But I am not able to cover. I cover only the genital area. Thank you very much for your patient listening.
Thank you very much, sir, for giving this extensive, elaborative talk on personal hygiene. And this was an eye-opener for all of the audience sitting here. I just had one question. I have one question. That for doing a surgical correction for phimosis or paraphimosis acceptable, and the religious thing also for doing the circumcision. But there is a myth or misnomer going on in the young population that if you have a circumcision, you can have very good performance in the bed, or you can last longer. And what's your opinion on that?
There are many studies are there. You see, that is two things. Circumcision, there is a prepuce is supplied by enormous sensory nerve endings. So it has a role in play and sexual play. It is a rolling movement also for both partners. It will be helpful. And when it is the glands is covered for longer years, so when the circumcision in due course, the glands slowly loses its sensitivity, and the color change will be there, texture will be there, looser. And if it is covered for up to 70 years, it will retain, especially in old age. In old age, the sex needs, they cannot fascinate, they cannot assume, they cannot imagine. Only the rolling of movement of the prepuce will help. So the keeping in the prepuce will be always helpful. What I want to stress is, if you are observing the genital hygiene properly, circumcision may not be necessary. So that is the thing. But circumcision has definite indication in phimosis, tight prepuce, adhesions, all these things, this is necessary.
Yeah, that's correct. And second thing, I was listening to the previous talks also. One more thing I want to elaborate, that in our Indian society, most of the hospitals, they are having now booklets, like leaflets. So leaflets are really important for when you tell them about something like diabetes with a side effect, or tablet side effect, or personal hygiene. Because if you, nowadays there is a sex education in the schools, they are introduced now for so many years now, which is helpful for the children in their adolescent age or something like that. But having the booklets, I will just give the example. In our orthopedic practice, I learned this in UK when I trained there. I trained in India also. After the hip replacement, nobody talk about the sex. That which are the position you should not take, which are the position you should avoid, and which are the positions are successfully you can take it to avoid the hip dislocation. And the personal experiences, I always talk because there is a big hindrances there that patient don't talk to you. So they want to talk to you, but they don't ask you. Now you ask them, Azun kai tumhala kai prashna आहेत का? Do you have any more questions? So you always ask them, and I think as a surgeon or as a physician or as a sexologist, we should give them the booklet. That works very well, because I have seen that over the period of practice of like last 13 years that people have appreciated that, patients. The doctor is really good that you have given that booklet to us. And that booklet we got it in UK when we were practicing. We used to give them that safe sex practices after the hip replacement.
Yes, sir. Sometimes, most of the time, patient does not come forward to ask, but they will have it in mind, especially following a myocardial infarction. When can I resume sex? Following hysterectomy, when can I have sex? When can I have sex? All these things. It has to be told by the appropriate surgeon then and there, even if they are not asking also. That's very important.
Thank
Thank you.
Thank you very much, sir, for the informative session. I would like to invite Dr. Suraj Ingole, Head of the Department of Cardiology, VishwaRaj Hospital, to felicitate our chair, to felicitate Dr. Murugan.
हेलो फेलिसिटेशन से चालू करा समाचार करना
I now request Dr. Suraj Ingole to felicitate our chairperson, Dr. Nagre.
फैकल्टी कौन है प्रसन्न गद्रे
I now request Dr. Ingole to felicitate Dr. Chagan Khatode. Thank you very much, sir. Continuation with the previous topic. What would happen if your patient says you don't call them private parts? In your OPD, if a patient says like this, it will be really a horrible situation for the physicians. So for this session, our next session will be don't call them private parts. I would like to call upon Dr. Archana Shinde. She is gynecologist at Shinde Hospital and Nursing Home, Hadapsar. Dr. Sumit Saxena to chair the session. Dr. Sumit Saxena is a surgeon. I now request chairpersons to introduce our next speaker, Dr. Prasanna Gadre.
Good afternoon, everyone. So post-lunch session, and we are going to discuss something very important. When a patient comes and speaks to you, that don't call them private parts. So sir is going to probably humor us and enlighten us at the same time with his talk. Sir, as Dr. Prasanna Gadre, he is a BJMC alumni, and he has done 29 years of practice in the sex, genital, urinary medicine. He has been faculty speaker at multiple places and done his clinical observership from UK and US and South Korea. He has a podcast on Storytel with highest ratings, and he has also done corporate psychology, HR sexual trainer in multinational blue chip companies. He has authored 2 books, and he has been a facilitator in many university grant commission. He has been a sex education therapist, counselor, expert, and a lot of things. So let us hear from him. Don't call them private parts. Yeah. So over to you.
Please give that halogen. And yes, yeah, because if in sexuality, am I audible by the way? Hello? Decently audible? Because I am not getting a reverb. Hello? 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 Yeah, I am audible. Yeah. So I would request to start that halogen and close up this halogen if it is possible, because when we are teaching our patients that in human beings, face-to-face contact and romance is very important. Yeah, yeah, absolutely okay. So that the judges won't be disturbed. Face-to-face contact is very important, and the romance between the speaker and audience is also important. But of course, if you get a glare, then you can slightly turn your direction and then focus. So don't call them private parts. This becomes important. So friends, what is your opinion? Should we call it or should we not? Vijay? Because this is very important topic. Yeah, so Madan Kamble and Mr. Jadhav, Dr. Jadhav Neeraj, he is here. He was here. And Dr. Madan? Okay. So, considering that since 2008, World Association for Sexual Health has declared 8 September as the World Sexual Health Day, this becomes all the more important. And hence, let us please give a loud clap to Sanjay, Pathan and team for keeping this topic. So let us give them, and for the organization. But this is an admonition, okay? So it's a command. As per transactional analysis, we are having 3 centers, that is the parent, adult and child in our brain, which is equivalent to superego and ego ideal, ego and the id. So id is emotional. Out of security and safety, consciousness and parenting got evolved the superego. And the superego gives this admonition and commands, don't call them. Okay. So it is like not only just don't call them, but don't see them. Don't say them. इसके बारे में कुछ नहीं कहना. Don't talk them. Don't touch them. And don't smell or suck them. The last is the reason why some partners do not like oral sex. And those who do not like oral sex usually have a disgust and aversion in their mind. And they are also the people जो कभी छुआ हुआ कुछ लेंगे नहीं. Ask this history, especially in a women who doesn't cooperate for oral sex. As you know, that in sex, till everything is mutually consented, everything is normal. If it is not, then it is abnormal. So, teachers and parents and others, they start inculcating disorders, which I also call, we can call it as a fatwa. And see, the word fatwa can mean an edict or ruling. So it's a ruling, don't call them private parts. That is official order or a proclamation issued by a person in authority. Here in sexology and psychology by parental figures and teachers, as I stated, or by recognized religious authority. The process of issuing a fatwa usually begins confronted with a problem of life. Belief or a law, and authority is unsure what to do. So the parent is unsure. If he finds his or her child doing masturbation, or if a teacher finds condom in the bag of a school student, Everybody knows this. Because this is the thing. And remember, friends, that existence is related to our life, this earth life, which is related to our private parts and sex. So whenever the patient comes to us, what I do in pre-counseling, I always do pre-counseling before counseling. The patient should know that what we are going to do in counseling. And I tell them 3 things. Number 1, that somebody did sex. Somebody means my parents, obviously, and hence I am over here. So, कितना अच्छा wonderful life और दुनिया मिली है देखने के लिए. So when we are talking as regards sex, we are actually talking as regards life and existence. When we are talking as regards private parts or genitals. So private parts, sex, or life and existence are 4 corners of the same plane, bindhast bola. That is the assurance which should be given in pre-counseling. Yes. So to do sex and sexuality education or not to do. Okay. And then there are certain rules that what should be said as regards private parts in which age group. Okay. So let us not enter into the detail. Same question. Porn should be seen or should not be seen? And I think we should not miss this. The most important part, okay, I would say 3 idiots, but the 3 intelligent ideas giving. तो सबके पास रहता है, देता कोई भी नहीं. और इस महापुरुष ने आगे जो उसने बताया है वो. So that is what it is. And without this slide, I think it won't get completed. So I think we are making a U-turn now. 150 lakh years to 60 lakh years ago, or maybe till recent 3000 and 5000 years ago, private parts were open. Then they got closed, and now again they are getting open. And the same is happening with assisted reproductive biology. In evolutionary biology, we know that with very few exceptions in mammals, in all the lower invertebrates and vertebrates, there is always throwing of semen and ovum outside. Due to multiple evolutionary reasons, it became intrauterine, and again what we are doing now, extrauterine. So this is also U-turn. Okay. So it's a U-turn, and in many things we are doing U-turn now. So then, instead of that, shall I call it as a public property? Huh? Isn't it? त्या वराड निघाले लंडनला म्हटला तो डायलॉग आहे ना टिपिकल. मी त्यांना विचारणार आहे तुमच्या देशात गोट्या केवढ्याला असतात आणि कशा खेळतात. अँड देन द फ्रेंड्स, तुला काय करायचं त्यांच्या देशातल्या गोट्यांशी? त्यांच्या गोट्या इंग्रजांच्या गोट्या केवढ्या, आपल्या गोट्या केवढ्या, वगैरे वगैरे. सो if I start saying this, then you will definitely say that Gadre has become wiser, isn't it? After taking this stage. But now see the use of words for the private parts from right hand side to left hand side, and they change, the meanings get changed. Okay. So in a logos, in a scientific discussion, we use the word phallus. In a formal literature, okay, this is called as an analytical philosophy, penis. Amongst 5 to 6 branches of philosophy, analytical philosophy is that philosophy which says that all knowledge in human beings is related to words and concepts at a final and a fundamental level. So words, playing of words is very important, and every word has a significance, value and a meaning, and something called as a bhavartha. Okay, so that bhav badlat jato. Then in puritanical sophisticated language, we call it as a genitals. Colloquial, formal, public circles, inner circles, private parts. Okay, still inner circles. Okay, you are having a beer or a vodka with your friends in a closed room, then these slangs and words start coming. Ludos, okay. So we are moving from logos to erotic, then ethos, that is the culture, ludos, that is the play, ludo. And then the cuss word, okay. So the word cuss has been derived from the word curse, and it means offensive and derogatory. Actually, it is an aggressive word, as you know, the F word and the so-called Z word. Incidentally, the Z word in Marathi has been derived from Sanskrit, Punjab language and Konkani. It's a combination of that. You can check it on Google, okay. Actually, it is so paradox and contradiction that when the F and Z words is said, actually the person never means to have any carnal knowledge. Rather, it is aggression. You go away from me, get lost, okay. And obviously, in a profane language, then it becomes a verbal attack or a sin. And in profane language, there are different types of what we call as a profane language, manje shivya. Every culture's important part, it is an every culture's important part, okay. And the shivya, which is a combination of the genital area and the loved ones, are supposed to be the highest level of shivya. There are different types of shivas or profane words, okay. So something new, okay, isn't it? Words, language which we use as a concept, they have transmission of data, information, knowledge. Here I am there to impart more of insights and wisdom rather than data, information, knowledge which everybody is having. What I would like to give you. Every field has its paribhasha, just like sexual medicine. To form a therapeutic alliance with the patient, this is very important. The therapeutic alliance, instead of you and me, it should be we. We both will fight against that erectile dysfunction or premature ejaculation. But for that, relationship is important. For that, communication is important, interaction, and there it comes the language. So if a decent person is there, you can ask phallus or penis. But if a person comes who is not so educated, from say from rural area, and sort of lower socio-economical structures, then the colloquial language puts him into a comfortability. And I always tell, use the word, or while asking the history, do you enjoy, first I always tell this in almost every conference, do you enjoy tobacco, then the whiskey, the cigar, and then you come, do you enjoy your private parts? Do you enjoy homosexuality? Because when we use the word enjoy, the message goes, doctor is comfortable and all lines of communication are open. So from today onwards, start using the word enjoy. Okay. Hello. Yeah. I think so. This is audible. No? Hello. Yeah. So to articulate and connote exactly what we mean, both. Yeah, you can keep both of them. With the reference to the context, this is very important to make the patient relax, comfortable, and convince him. Ultimately, we together are over here to increase our competencies of our sexology practice. Don't call them private parts, which is an order or admonition. So are private parts really private then? So this is a stimulating brain pondering, asking to think. Our education has always been, I tell you and you just do it. Our education should be reverse, and that's why I'm asking you this. Ponder, think, quest. Okay. See, now the thing is that in psychology, there is something called as a cognitive error. Remember, friends, that in life, in our existence, in sex, many questions do not have this black and white answer, yes or no, or digital, or polar. Okay. There are so many shades that are there in between. And that is very important. North Pole और South Pole के बीच में 14-15 geographical regions है, isn't it? Between black and white, there is less black, less white, shades, 50 shades of grey, and the Vibgyor. Okay, so remember that the action potential in physiology has all or none law, but in our existence, life, and sexuality, private parts, we have potential to take actions in a spectral way. So I can decide upon. Okay. So understanding privacy from a biomedical psychosocial and psychosexual point of view. So the thing is that when we talk as regards these three things, what will come out, and that is very important, and through this we will start gradually having. So evolutionary biology, what happened, that we were quadrupeds initially and then we became bipedal. Because of that, the breast and the genitalia came in front and it started stimulating. And in order to avoid that, and of course to protect the genitals from the dust, from the germs, from the allergens, from the temperature, the loin was there. And that's why what happened, it got covered. And then anything which gets covered rose the curiosity. And if it is uncovered, then ultimately, due to the evolution and civilization and socialization, it was started to be labeled as indecent. Okay, माने जो आप दिखाते हैं ना खुलेआम, वो indecent हो गया, क्योंकि अगर मैंने मेरा loin खोला तो indecent हो गया. And that's the reason that evolutionary biology has definitely influenced mind, sex, cultures and civilization, especially sexology. And the thing is, we should also ask ourselves, what about psychological nudity? Are we psychologically nude with our partners when we are in our bed? And psychological nudity is telling our intentions, our opinions, our wants, our needs to our partner. And of course, we should have that thing in mind, that when we should open and with whom, but that is very important. And society's laws, politics and economics. So private parts has all these connotations. So in the primate, we can call that a primatology as a sexology of a primatology. Okay. Incidentally, in primates, human penis is the largest one. The carnivorous habit has influenced our sexuality. Okay. And we are opportunistic feeders. They survive by eating whatever is available. So this, even the pornography, if a person is alone, whatever is available, masturbation or pornography. So with whatever is available, so there are parallels in food and sex. Whatever is available in food can be consumed. So the same is applied to the sex. Right or wrong, ethical, unethical, moral, immoral, these are later and different questions. And medicine and technology has definitely influenced. Now before medicine, before the BC, it was more of a medicine and drug oriented. Okay. Effect of plague, and of course then at the time of till medical renaissance, traumatology was also there because wars were there. Then the effect of plague was there on antibiotics, and finally we have landed up with 21st century. And all this has affected our private parts. And as andrologist and urologist, two things. Now the average age of human beings from 1940 to 2021 has increased from 32 years to 84 years of life. So we are going to get more and more patients of erectile dysfunction, number one. And second thing is, I'm sorry. Yeah, so transplants will come in a huge big way. Implants you are doing. In 2006, that was the first penile transplant, you must be knowing. In China, it was done, correct? Guangzhou or that city is there. So, future of private parts, okay? And the woman who rejected, bits of future, biosensor, implants, transplants and stem cells. And this is what I got. So, यहाँ पे भी घोड़ा आ गया. And she is a lady who severed or cut the penis of her partner, Lorena Bobbitt. So in human anatomy, evolution of future sexology, okay, my weird sexiest fantasy. So I imagine that I am a dermatologist, isn't it? And my father is say andrologist, my mother is gynecologist, my wife is a psychiatrist, and my sister is a plastic surgeon, and my brother-in-law is a psychologist. So this is a weird fantasy. Maybe a day will come when all the members are sexologists. okay, dealing with the parts. So I will just miss this. Sex as a joke and human because of lack of time. So what is privatology? It is I and you versus I versus you, me versus thee, myself, thyself, we and others. The concept started building from 1590 onwards when the property and ownership laws started coming. It paralleled with that. Okay, pri means first and V means from within, from center of gravity, center of weight. It's a personal matter. Are they really personal? State of being in isolation, seclusion and solitariness. Are they really isolated? All alone by oneself, for oneself and of oneself, truly democratic and free from knowledge and observation of others means private. Presence, existence or happening of that organ is not sensed by the other. Okay? Not to be disturbed, access denied. This is important. For sexual consent as regards private parts or sex, permissions to be asked in an explicit, articulate, specific, clear and consciously. And Article 20, 21 and 22 deals with it. Exceptions to this act are there. Yes. So now, thing is that, see, private parts in humans have different forms. This is very interesting. First thing is that dreams, nightfalls, fantasy, imagination and ideas, they can be verbalized as we have. There is an erotica. Art, statues, sculptures have it. Photographs, motion pictures, and what are ultimately private parts. See, when an erectile dysfunction patient comes, it is a symbol of possession. Okay, surety, abundance and image. An erectile dysfunction patient first feels that he is deficient of something, that he is powerless, he is having uncertainty, and what about his social or sexual image in front of his partner, and that has to be addressed. Okay, in counseling, what is supposed to be done? Actually, these are the only 4 or 5 problems in our life, problem which are called as problem of adaptations. So metaphorically conceptualized. Okay, now this is very important. That last say 5 to 10 minutes, this is very important. That the in sex, existence, life and private parts, the meanings, the first thing is that the answers to the question, they change when our perceptions and attitudes looking towards a particular thing changes. I told you, there are no yes and no questions. There are whole spectral analysis or spectral answers which we have. Second thing is the reference and context changes the meaning. And third thing is the intentionality. Sex as an end in itself, or sex as a media for some different end. Say for example, in office, a particular female can offer a sex in order to get promotion, or prostitutes offers a sex in order to get money. For both of them, they are having sex not as an end in itself. It is a means to achieve some different end. In the first case, promotion. In the latter case, paisa. So that is very important. Confidentiality, secrecy, okay, nudity, nakedness. These are all the concepts that are related. And the most important is the rasa nishpatti. Are we looking at private parts through vibhatsa ras, vikrut ras, bhayanak ras, tamasik ras? Okay, rasa nishpatti is nothing but psycho-neuro-immuno-endocrinology is called as rasa nishpatti, which we had. And or I was saying, are we looking towards sex through hasya ras, through ananda ras, through shanta ras? That is very important. And in counseling, we need to do that. Private, this is very important. Private part have nothing to do with gender orientation and identity. And as you know that in LGBTQ3I2S2A+, okay, so LGBTQ, there are 4 axes depending on the social construct, that is the gender, that is my outer expression, the androgynac, the genitals, the genotype, phenotype, the sexual orientation, that is the love, sexual love, okay, and the identity, what my brain is sensing myself. And remember that there are huge permutation combinations, more than 80, it is said till today, on this 4 axis, and they are not static, they are fluid, and they can move with respect to time for a given individual. Say for example, there are few people who I have a case, something called as a split homosexual. He likes to have sex with men, but likes to have love only with women. So that is what it is. Yeah. How much time is there? So, Freud, Kohlberg, Charles Clooney, Erik Erikson, Vygotsky, Piaget, Mead, and social influence theory. Let us not enter into the details, but these are the theories which tell the connection of private part sex with mind. Okay, some important things as an andrologist. For the erectile dysfunction or any patient didn't receive breastfeeding or healthy weaning might develop fixation for oral sex and partner's breast and nipple, nail biting, cigar, excess eating, addictions, oral functions or verbosity, reflects less awareness of importance of it in mothers. Breast awareness, breastfeeding awareness, definitely that is the drive which we take on the breast health day. So that might be reflecting the Indian scenario. Those who enjoy penoanal sex. So in Freud basically he has given 3 main stages: the oral, the anal, the phallic, the latent and the genital. So in the first is the oral, the second is the anal stage of the psychosexual development. So those who enjoy penile sex, oral, anal, complementary fixations are fixated at anal stage in potty and toilet training, or whose training was so strict that they started hating the sex. Hate oral kissing due to fear of germs, this I told you. Castration anxiety, okay, develops when genitals are not respected and parents threaten with injuries. EDS is reflection of that, loss of possession. Peer parents ridicule, teasing, do teasing and insult in front of others peers can reduce interest in games and plays between the age 6 to 12. And if the child is a victim of pedophilia, where private parts are handled, the child might get fixated on a person, either have a loss of interest in all sorts of plays, games, and hence interest in foreplays. The gray is paralleling with the gray, and the blue is paralleling with the blue. Victim of pedophilia getting arrested in neoteny, that is 6 to 12 years, and love for the same sex. Okay, so it is because of the parents, teachers, and the peers, these 2 things happens, that one of the reasons amongst many reasons that why a child who is victimized, okay, starts getting homosexual if victimized by the same sex. And whether how sportingly you are in a play reflects, in a child play, reflects how sportingly you are in a foreplay. And what's the difference between play and a game and a sport? A play is without rules, without regulations, while a game and sport is with rules and regulations. And that's why we never use the word for sport or for game. We use the word for play. Take your freedom and creativity to enjoy it is what has to be told to the patient. Yes. So I will just quickly go through the slides. And this was the Kronos who cut the testes of Uranus. It is there in the mythology. And the penis envy by the Karen Horney. भला उसकी कमीज मेरे कमीज से ज़्यादा सफ़ेद कैसे? भरत उसके पास मर्सिडीज है, मेरे पास कम गाड़ी है, उसके पास 4 BHK, मेरे पास 2 BHK. So penis envy is an envy. Karen Horney gave this. And this is Charles Clooney looking at the glass self. Okay, what is that? Our own view of our genitals depends on how it appears to others and their approvals and judgment. Please ask this question. Okay. So instead of my own personal or a sex physician's opinion, evaluation has become important by press, peer, parents, public, and the pseudo doc, that is quacks. You want this slide? Her evaluation is important than sexologist. What my girlfriend said as regards my erection or my boner. So she ridiculed, she was disappointed, frustrated, oh my God, catastrophization, worried, अरे तेरा तो इत्तू सा ही है, isn't it? And this is the Kohlberg stage. Don't touch is the for avoiding punishment. Reward if no touch is there. So if you don't touch your organ, I will give you a chocolate. Then good boys never masturbate, and good or smart and good girls never take initiative in starting sex. So law and order. If you do something with private parts, then it is sin, vulgar or indecent. Oral ka kitna lengi tu? Okay, social contract. The client asking the prostitute. Or financial contract. Ha. From her side it's a financial. From his side it is sexual. Yes. So this is the Kohlberg stages of moral development. Okay. And I would say that this is the last. Now see how we will be going private parts and sex and scenarios. So this is the thing, crimes and perversions, where actually the private part should not be made public, but it is made. Okay. Or it is against the sexual consent. So right from rapes to exhibitionism, portrism, voyeurism. Okay, just ulta ho raha hai. On the left hand side, it should not be made private, but it is made private. I'm sorry, it is made public. Okay, it should be kept private. It should not be made public, but it is made public. Okay, on the left hand side. Then we move technology and victims of sex. Nowadays, we know that deep fakes are there, and we get a call. You must have got this message. And suddenly that video starts, a shooting is taken, and then your face is being projected or morphed while having different kinds of sexual activities, and then the threat comes that I will make it viral if you don't again give me money. Or the boyfriend tells the girlfriend to undress, okay, and take the video and send, and then he starts emotionally blackmailing her. And these on right from her breast, dressing, undressing, her private parts, sexual activities, or they shoot their own sexual activity and try to make it viral. So technology के वजह से यहाँ पे भी ये नहीं करना चाहिए, मगर हो रहा है, उल्टा हो रहा है. जहाँ पे प्राइवेसी रखनी मांगता है वहाँ पे पब्लिसिटी मिल रही है. Okay. Then cults, events and peer pressures. So something like nudist scams or swapping of sex partners. I had a case where 4 people came, 2 couples, and they wanted to swap, and one of the couple's wife, she was actually not willing to, but out of force from the other 3, the 2 respected husband and the girl which was enjoying that, she got very much tense, and I had to counsel her and tell them that suppose I made them sit in my cabin, and I told them that she has the right to go against, you should be aware, and there can be an injuncture of the law or the police in such cases. We have to make aware. वहाँ पे हमारी मर्यादा रुक जाती है. Okay, and 2 more cases were there of swapping, but I have lost them for the follow-up. So then obviously the sex markets. Okay, यहाँ से अब दोनों बाजू से है. Okay, देता कोई नहीं, छुपा के रखता है या inside the room. So pornography or nude photographs. So huge OTT market is there. So this is between the spectrum. Sublimated scenes are there. So that aesthetics. Okay, so aesthetics are there. So sculptures, photographs. Socially, legally accepted scenarios where obviously the patient is coming to the doctor or to the sexologist, and it is an implied consent that you test my private parts. Okay, and the mutually consented, and this is very important, we must ask that here actually the entire body and the private parts must be visible to increase the eroticism and pleasure. But in many couples you will find married, live-in, as is, okay, irrespective of that state, that while enjoying the sex, they are doing it in total darkness or with the clothes on. and the history should be asked. That these 2 points, Amit must have told Mutha in his maybe the sharing, that are you doing the sex in darkness? Are you doing it with your full dresses on? Because then how can the stimulation and eroticism, romance and foreplay really happen? And there is a huge number of couples, I would say maybe sometimes 40 to 60%, that do the sex in this manner. Yes, but blind claims do have virtues, but what I am saying is, yes, they have the virtues for exploration in sensate focusing, but the thing is that this is not a variation, it becomes a pattern. That is what they are enjoying. So pattern is 80 to 90% for most of the times, at most of the places, okay, they will be having sex in the darkness. Okay, so this is what it is. So from on the right hand side, so it's a flipping. On the right hand side, yeah, they should be totally public in front of your partner, or they should not be private on the right hand side, and there they are kept secret. And on the left hand side, they should not be public, they should be totally secret and private, और वहाँ खुलेआम उसका प्रदर्शन हो रहा है. So this, and I told you that with reference to the context, with the intention, with the situation, with the meaning, this is how the things change. So that is all. The crimes, the rapes, pedophilia, exhibition, voyeurism, calls, shoots, deepfakes, nudist scams, just a revision. You can have a slide if you want. Photograph, porn, striptease, aesthetics, street exposure. Now this has become very common. After 2012, on Facebook, on Instagram, so many women, okay, to attract the attention. Basically, they are attention seekers. I have taken interview of 10 women. 3 of them my friends, 3 of them totally strangers whom I contacted on Facebook with this intention that I am going to do a research, and 4 of the ladies were sort of, I got their contacts through some intermediary. And I asked them that when you are posting such so-called sensuous or sexuous or so revealing photographs, do you really mean to have sex? And 8 of them said, no, we do not want to have sex. We just want to have that feeling of power, that I can seduce humans, I can seduce, just to have that importance, just to have that attention, just to get that high. So what has happened in today's society, that on one side, women are in conflict. On one side, they are being stimulated to be sexually open, but on another side, they are not ready to have sex. And this is what it is. Okay? Yes. So, and of course, the last one is important, parent-child talk, mutually consented. Okay? So, I will just skip this. Yeah, I think this is important. Tell your patients to imagine, this is very important for the andrologist. Hypothetical question after taking me into good confidence. 2 minutes. Einstein's entire theory of relativity is based on hypothecation. Imagine that you are traveling with the speed of time. So, you get all the answers. So, what are these questions? You should ask to your patient that what if you are born as a man but with a congenital deficit of penis or micropenis? What if it was totally cut or amputated in accident or injury? Ask this question to erectile dysfunction and see beautiful responses you will get. And that will give him that a feeling, दुसऱ्याचं दुःख बघितलं की आपलं दुःख कमी वाटायला लागतं. What if he was suffering from a cancer and total phallactomy had to be done? How will you stimulate your woman or sex partner, get her high, get her orgasm, if you are not allowed to use your penis before you ever have had an erection problem? Erection problem होण्याच्या आधीच पेनिस वापरायचा नाही. आता बोल तुझ्या बाईला तू कसा ऑर्गाझम देशील, कसं प्रेम करशील? Hypothetical questions. See what happens, whatever that cognitive errors and rational emotive therapy, okay, how awful, how terrible, how catastrophic, immediately this drops away. And that is very important for the patient. Ask, and I would say that please get back to me with your patient's responses for all of our questions on this number. By keeping their names private but making their responses public, we can form our group. Either by reaching to me on my phone, WhatsApp with your full identity. तुम्ही विचारा, don't accept, okay? Test me, T-E-S-T. Don't accept me, okay? Don't take whatever I am saying, please don't take at a face value. You are a scientist. You are a science people. Skeptic. प्रसन्न गद्रे म्हणतोय बरोबर आहे का? नाही गद्रे, मला हे बरोबर नाही वाटत. हो हे मला फुल्ली बरोबर वाटतं. This is what science is. Okay. So, which is more private? Bra, breast, buttocks, boner or beach? Or owner of all this? That is the mind and brain. I think the brain and mind is private. ये तो इधर है, छिप गया है. Private parts तो दिखते हैं. तो अगर पेनिस डाल दिया स्कल में तो क्या होगा? जो है ही, तो या ऐसा होगा. One penis for urine, one penis for semen. And people do or men do sex by keeping their brain and mind out, isn't it? So we should tell that the beauty of the sex is not just lying between the two legs, but between the 2 ears, and that is brain. And this is my book, Myths and Facts of Masturbation. And yeah, I will just skip this slide. This is the last one, cyber crimes. And this was the question which was asked by my daughter to me in 2008 when we were moving in a condominium in a lift. तिने सरळ असं, she was 6 years old. बाबा ते FUCK म्हणजे काय रे? I closed my eyes and सरस्वती और धन्वंतरी का मैंने धावा किया कि अरे बाप रे, आता माझी परीक्षा है. My wife was there with me. 3-4 people were with us. I answered that question. धीरे धीरे लिफ्ट नीचे जा रही थी. And then when her curiosity dropped, which I came to know afterward, she only said to me, अच्छा असं आहे का? बरं मग बाबा tell me those words which sound with that F, fully K. मैंने देखा और बोला buck. Then she asked me what is buck. Then I told her money. Then she said LUCK, luck. So see, when children are asking the questions, they are asking out of curiosity, or topic khali dadlay kai, and we should answer that. And that, rather than sexologists going and giving the training, I tell the parents, I take parent seminars that how to actually answer these questions. And that is very important, because see, intimacy develops when we start talking about sex and talking about finance and death. Death, life, finance and sex. If you talk with your children, ekdam khuleam, bindas, with, of course, there are a lot of techniques with that, okay. Again, no yes, no answer. There are many answers or many strategies to do that. You will be able to do it, and that will produce a better India, a better future generation, and a better citizen with a better overall and sexual health. And this is that book, and I will proudly say that this is that fellow, and this is his father. He is actually my brother-in-law. This is my book, and I have imparted them the training, how to train this child, their own child, and this child stood first in Maharashtra in 10th standard. त्याचं 6वी-7वीत झालं ट्रेनिंग त्याच्या आईवडिलांकडनं, आणि आईवडिलांनी माझ्याकडनं घेतलं. मला सांगण्याचा अर्थ तो आहे, आणि आज तो IIT मद्रासमध्ये BTech करतोय. सो imparting sex educations can produce students who are coming first in Maharashtra and going for IIT. Okay, so well, I think I am just winding up, and okay, so I think that's it. There are many slides, but due to the want of this book is available, okay, with a special discount out of 400. It will be 300, but I will not be giving you in the conference because it is against the sanctity. I am just informing you. If you are interested, then after the conference gets over, okay. So, or you can contact me at my clinic. That will be also a rather probably a better choice. अँड या ॲमेझॉनवर नाही अजून टाकायचं आहे. So that is what it is. Thanks for that patient listening. I took more amount of time, but I will see to it that performance anxiety also becomes interesting, and that will be fast. Okay, thank you so much. Thanks. Sugar levels must have gone down.
You can ask questions till then, no problem. Questions from the audience.
Thank you, sir, for excellent talk.
Yeah, sure.
Vapu Kale has very nicely said की दाखवणारे आहेत म्हणून बघणारे आहेत की बघणारे आहेत म्हणून दाखवणारे आहेत हे सांगणं कठीण आहे.
या क्या बात है.
सो युअर टिकटॉक आणि ऑल इन्स्टा रील्स वगैरे वरती ज्या एक्सपोजिंग आणि रिव्हिलिंग बायका असतात सो दे आर ऑल व्हॉलेंटरी. कोणी कानपट्टीवर घोडा ठेवला नसतो.
हो अगदी बरोबर.
अँड ॲज यू सेड की दे आर नॉट शोईंग ऑर एक्सपोजिंग फॉर सेक्स बट जस्ट टू see their seducing power.
Correct. That is what I said.
Second component of course म्हणजे त्यांची रील जास्त तर जास्त व्ह्यू होईल आणि कुठेतरी त्यांची चॅनल मॉनिटाइज होईल.
करेक्ट.
हा एक उद्देश असतो.
अगदी बरोबर.
आणि दुसरं
नॉट दॅट एव्हरी टाइम दे आर हॅव्हिंग दॅट सेक्शुअल इंटेंट.
ते जे दोन एक्स्ट्रीम होते
एका
बाजूला जिथे अपेक्षित असतं पण लोक एक्सपोज होत नाही.
करेक्ट.
आणि एक्स्ट्रीमली ऑपोजिट 180 डिग्री की जिथे प्रायव्हसी ठेवणं गरजेचं असतं पण लोक एक्सपोज करतात.
येस.
तिथेही समाजाचं एक डबल स्टँडर्ड आहे. जर पुरुष एक्सपोज करतो तर तो गुन्हा होतो. स्त्री एक्सपोज करते तर तो उत्साह होतो.
अरे वा क्या बात है. दॅट वॉज नाईस वन. अँड सो द इमिजिएट रिफ्लेक्शन ऑन वपू काळे इज वपू काळे ऑल्सो सेड whatever is personal is universal and whatever is universal is personal. And as is the demand, so is the supply. And that is what free markets is all about, whether it is sexual or of the shares. Okay? The sexy shares or the share of the sex.
Thank you, sir. Very nice and informative presentation. It looks everybody enjoyed. So I would like to call Dr. Sushant Shinde to felicitate our speaker, Dr. Prasanna Gadre. Dr. Sushant Shinde is head of the Department of Medicine at VishwaRaj Hospital. I require Dr. Sushant Shinde to felicitate our chairperson, Dr. Archana Shinde. I request Dr. Sushant Shinde to felicitate next chairperson, Dr. Sumesh Saxena. Thank you, sir. Thank you very much. Let's move on to the lunch. We'll meet after half an hour at 3 o'clock.
Hello. Good afternoon, everyone. Welcome once again, post-lunch session. We will start our next lecture. The next lecture will be by Dr. Ajay Varghese sir on management of vaginismus. For this lecture, I would like to invite Dr. Ravindra Shinde sir to chair this session. Please, sir. Dr. Ravindra Shinde is a consulting physician. He is attached as a consultant to Asst Hospital. Please, sir. I request Dr. Ravindra Shinde sir to introduce our speaker.
Hello everyone, thank you for inviting me here. Now I want to invite Mr. Dr. Ajay Varghese. He is the Director of Institute of Sexual and Reproductive Medicine at Kozhikode. He is the founder chairman of International Association of Sexual Medicine Practitioner, Director of ISRM, that is Institute of Sexual and Reproductive Medicine, Wayanad Road. Then, sir, hand over to you. Thank you.
Thanks for the kind words. After lunch, post lunch, we are sleepy, drowsy. Okay. Anyhow, it's a matter of vagina. That's why I don't think sleepy and drowsy. Then I am going to present vaginismus, how to manage it. Let that light be. Okay, put off the light. Okay. My topic is vaginismus. Vaginismus, management of vaginismus is difficult, and whether it is a gynecological entity or psychological entity or psychiatric disorder, anyhow, it's a phobia. How to treat the phobia? Phobia can be treated by desensitization as well as flooding. Here I am going to present my methods, how I am managing vaginismus. Unconsummated marriage is a term that is used to describe a situation in which sexual intercourse between a married man and woman has yet not taken place. This study is focused on vaginismus in females, which are more common in unconsummated marriages. Vaginismus is the vaginal tightness causing discomfort, burning pain, penetration problems, or complete inability to have sexual intercourse. It is a condition where there is involuntary tightness, that means tightness of the vagina during attempt intercourse. The tightness is actually caused by involuntary contractions of the pelvic floor muscles surrounding the vagina. It is instantaneous involuntary tightening of the pelvic floor muscles, anticipation of vaginal penetration. How does the anticipation occur? It is induced by peer group, family members or close friends, or through books or internet, from where the first information about the sexual activities occurred in exaggerated way, that is about pain, bleeding or pregnancy and delivery. Anticipation of the fear and circuitry of the fear you will be knowing. Then conventionally vaginismus is treated by psychotherapy and gradual insertion of dilators along with the psychotherapy. Then how does vaginismus happens? Vaginismus is nothing but penetration phobia. Phobias can be treated by flooding or desensitization. Then flooding. During flooding, the client is completely and utterly exposed to a thing that or a situation that causes him fear. The client prevented from escaping the situation or object. The client is kept with the source of fear until stops responding to it. Flooding is impossible in the treatment of vaginismus. It ends in the section of IPC 375, 376, 376A and so on. Then, during systematic desensitization, the client is gradually exposed to a thing or situation that causes him fear. The exposure happens in such a way that the client is slowly exposed to the thing that scares him in progressive increments, keeping him below the threshold fear where fear and panic would start. See here the snake, it is fearful, ice cream, pleasurable, then snake and ice cream, it may be unresponsive response comes, okay. Then penetration, that is fearful. Clitoral stimulation, that is pleasurable. Clitoral stimulation plus penetration, we can do penile penetration also. Then for psychotherapy, 1 hour sessions of 20 weeks is required and it's a quite long time. Results are disappointing. To overcome these disadvantages, long duration of treatment, ISRM developed a combined method. Systematic desensitization by biothesmometry and dilator therapy. Mode of treatment, gradual desensitization by biothesmometer and gradual dilatation. Written consent from the couple must be taken. Educate the couple about the sex, male, female and organs, sexual intercourse and other processes related to sex. Couple is also explains about the mode of treatment. Inform the patient that we are not going to enter anything into the vagina, simply touching the vagina from outside only. Gentle and smooth touching of the vagina is must for developing a rapport. Ask her, is there any pain or discomfort? If the patient feels comfortable, do the same procedure for 5 to 10 minutes. Touch the vulva, notice the reactions, convince the patient that you are not going to enter anything into the vagina. Then the issue is that if you are touching the vagina, if the patient is violent or if she is not allowing it, then it may be grade 4 or grade 5. That special care is required for grade 4 vaginismus and grade 5 vaginismus. Video. See here we are simply touching the vagina. Patient is not objecting. Okay. Then request the husband to do so. Here husband is doing, she is doing. Okay. So this is, we can diagnose that it is grade 1 or grade 2 or grade 3 vaginismus. Then place the probe at the clitoris. If she is comfortable, increase the frequency to pleasure. Morning session I have explained about the biothesmometer. Then pleasure point, note the pleasure point, gradually increase the vibration. If she is comfortable, increase the frequency to pleasure point. Increase the frequency little above the pleasure point, allow 5 to 10 minutes. Check the lubrication. See, here we are simulating the clitoris with the biothesmometer. If the patient is comfortable, go for Foley's catheter dilatation, show the catheter and explain about the consistency. Request care to insert it into the vagina. If inserted, request care to pull it out. Repeat the procedure for 5 to 10 times. Here what I am doing, I will show a Foley's catheter, which all of you know. Take the Foley's catheter and ask her to touch it. While touching the Foley's catheter, it is soft, and I will request her to insert this Foley's catheter inside the vagina. Care should be taken. That means she should not insert it in the urethra, because we have to pull it out. If it is in the urethra, we are inflating the bulb. That urethra can be damaged. So you must take the care. It is there in the vagina itself. Foley's catheter. Look, here Foley's catheter is being inserted. Actually, now I am inserting it. The patient can insert herself. It will be better. Now we are inflating. Then after I am requesting her to pull it out. She is trying to pull it out. You have seen the bulb. See, note that we can start it with the 5 ml. Then second session you can go for 10 ml. Never try with the 30 ml at the first time, because of 5 ml is tolerable, dilating them. Now you can inflate the catheter with 5 ml of water. Let hair remove and insert the inflated catheter 5 to 10 times. Not a single time, 5 to 10 times. Show the size of the bulb. Then let her repeat this procedure 10 to 15 times. After that, you can increase the inflation up to 15 ml. Repeat the same process 10 to 15 times. Now we can request her to insert smaller dilator herself, because of dilatation is complete. Small dilator. Small. Yeah. See, I am giving a dilator. She herself puts it inside. See. Now she is comfortable. It is not painful. You can see the dilator now. I am giving another dilator. She is pushing it inside. It's a bigger dilator. Okay? Again stimulating the clitoris for sexual pleasure. Then lubrication will come. Lubrication will occur. This will allow more dilatation. Yeah, I am pressing that probe. Now the frequency is most important. If patient is doing, she will not be moving it to and from motion will not be like this frequency. Now she is comfortable. If she is comfortable, you can insert the dilator server, which I have to increase the speed of to and from movement, come back to the clitoral stimulation. Then if she is comfortable, increase the frequency near to orgasm. Let us repeat the catheter dilatation 15, 20 and 30 ml. Now we can insert the catheter and dilate it for 40 ml water also. Care should be taken. If you are using 18 gauge dilator, you should not go for 40 ml. It may break. For that purpose, the catheter must be changed. It should be 21 or 22. Then we can allow 1 week homework for the couple because of it is dilated already. Then homework, clitoral stimulation. Hold the clitoris with the 2 fingers, stimulate it with the to and fro movement. Ask the female partner whether she is sexually excited. Then after completing this, he can check for the lubrication without putting the finger inside. Then he means her husband. If lubrication is there, it's a good sign. Then if she feels comfortable, continue the clitoral stimulation. Now he can penetrate the finger in the vagina, saying that he is not deeply entering into the finger, into the vagina. If clitoral stimulation is proper and reaches to the excitement stage, her brain will allow finger insertion inside the vagina. Then if she feels, then if the finger is completely inserted, ended inside the vagina, ask her if it is comfortable or painful. Convince her nothing has happened to her vagina. Then, after completing the homework, she have to come to the clinic again. Now she is convinced that the penetration of the finger doesn't harm her. Then proceed with the insertion of dilator or artificial penis or dildo. Then, variable rigidity vaginal dilator having an inflatable balloons are available. Relatively pain-free vaginal dilatation is obtained by inserting into the vaginal canal a variable rigidity vaginal dilator having an inflatable balloon in a manner that avoids insertion into the urethra. Air is introduced into the balloon. That it is not available in India. It is available in states, and it is a patent product. For instead of this thing, I am using Foley's catheter. Then explain the couple that they can perform the sexual intercourse. Direct penetration will worsen the condition. Let the male partner perform it step by step. Educate him about the steps. If he is directly going to insert the penis into the vagina, it will harm her. Then male partner can now start clitoral stimulation, breast stimulation, then go for penetration of the finger in the vagina. If this part is not painful, rotating the fingers in the vagina should be practiced. If they have penetrated the finger and she couldn't enjoy it, both clitoral stimulation and finger insertion, ask the husband to do clitoral stimulation and 2-finger insertion by twisted method. See, now understand that proper stimulation of sexually sensitive areas will lead to the activation of sexual areas of the brain. Once the sexual areas of the brain gets activated, anxiety produced by the cortical areas of the brain gets suppressed. This is the basic theory. Then this helps to overcome the vaginal spasm, thus penetration becomes possible. Care should be taken. Never enter dilators on a sudden, enter it gently and gradually. Then orgasm, like all experiences, is brought by electric impulses following along paths of concerned nerve cells. Orgasm happens when the specific pleasure pathways are turned on while the defense pathways are turned off. This procedure I am not going to explain. Regarding the brain and amygdala, that part you will be knowing. Then, sir, through the libido, sexual hormones energize our body with the triggered releasing of adrenaline and norepinephrine, and increasing our heart rate and creating a state of arousal which triggers the dopamine. Oxytocin is clearly involved in the human reproduction and serves an important role in sexual arousal. Oxytocin serum levels were measured before and after sexual stimulation in 12 healthy women. Values of oxytocin 1 minute after the orgasm were significantly higher than baseline level. This finding supports the hypothesis that oxytocin plays a major part in human sexual response, both in neuroendocrine function and postcoital behavior. So pleasurable stimulation, that means we have to increase the oxytocin level by producing the orgasm. Pleasurable neurotransmitter provides drive to find the objective of desire and achieve the most intense neurochemical reward for sexual contact and orgasm during this period. Even though patient is having vaginismus, her fear-producing areas will not work. Oxytocin plays an important role in sexual arousal. During arousal, oxytocin inhibits the areas of brain that produces negative thoughts and foster distress and fear. Then androgens, estrogens. That time there is no need of penetrative sex for attaining sexual orgasm. To attain sexual orgasm, we are utilizing other sexually areas like clitoris, breast, and other sexually sensitive areas. When one is sexually aroused, anxiety and stress will be suppressed. During this period, penetration of finger is possible as all other areas are moved. Then we can control one's anxiety and get back results in treating vaginismus in unconsummated marriages. Conclusion: when systematic desensitization by biothermometer was given to female subjects, majority of them could overcome the vaginismus through dilator therapy. Dilator therapy means this thing, Foley's catheter you can use and glass dilator you can use, grade by grade. Any questions?
Thank you, Dr. Rajendra, for the able talk. Now
Hello.
I request if anyone has any questions.
Yeah. So total, how many weeks duration this program goes on for a given female?
Depends on the patient's condition. I have few patients, they could do this thing, intercourse within 1 day. Normally, it takes 1 to 2 weeks. In some patients, it takes 2 months also. When we have to go on dilatation, homework, then come back, like that. Some institutions, like in Kerala, 2 institutions are there. They are admitting the patients for 2 weeks. And they are charging about 3 to 5 lakhs rupees for this course. But I am not doing this thing because I don't have facility, and I send them back to their home, let them practice it.
Kya baat hai? Very good, sir. And before that, do you happen to get it checked with the sonologist and gynecologist that whether she is having any other vaginal problem, like septate in vagina or whatever?
I myself can check it
You
whether
check,
vaginal
okay,
problems,
okay,
because
yeah.
of I do have that much
good.
of
Okay.
experience. That's
Great.
No, I am not blaming both.
No. I got the part. Rather, that should be done. We are all MBBS. We are taught.
No, because I have worked in gynecology departments. I am not a gynecologist. I have worked in somewhat about 5 years. I have
that's
taken
great.
somewhat about more than 500 deliveries.
Oh.
Myself. At
Wonderful.
that time, gynecologists were not available.
Yeah.
Not done cesarean, episiotomy and everything.
Thank you, sir. Any further questions? Ma'am.
Hello, sir.
Yes.
So in today's era, where the modern females are using the menstrual cup, is this vaginismus rate reduced as compared to the earlier ones? Like, what is your call from the cases?
Your question is if vaginal cup is used, whether
No, my question is, as in this modern era, many of the females have started using, even the teenagers, they have started using the menstrual cups. So is this use of menstrual cup having any effect of not having vaginismus? Like the cases have reduced or what? What is your take on that for the present scenario?
I will explain. If they are penetrating anything inside the vagina, vaginismus will not take place. And menstrual cup is a good idea. And one more thing, if they are doing masturbation with a finger or any sex toys or anything, they don't have vaginismus. Normal, my patients do masturbation. That means vaginismus patients do masturbation, but with the clitoris only. They never enter anything into the vagina. That is the main problem. I have to teach them how to do the masturbation.
Just a second. So I think if we can flip the question in modern era, if a girl is using pad instead of the cup, we might ask her, are you having that fear of insertion? I'm just flipping it. Yeah. So that could be, we can go in a reverse way to find out.
Yeah. Question can be modified.
Yes.
Any other question?
Oh, sir, apart from desensitization, is there any pharmacotherapy for vaginismus?
Some doctors, that means especially one infertility specialist prescribed alprazolam for vaginismus. I don't think it will work. And normally what happens, gynecologists mostly, those who are not exposed in sexual medicine practice, they will say, they will blame the husband. Are you a man? And why don't you give more force and everything? Whatever force they are doing, it will not enter at all. And one more thing is there, they will 101 excuses will be there from the female partner. It will go for 8 years or 12 years. I have treated one patient, one couple, that means they have married 12 years back, and it was very difficult case. I could manage that. Yeah, botulinum, what it is, suppose I am closing this eyes, it will not be dark in this way. That means it is something like that only. That means botulinism, that means we are paralyzing that muscles. Then also the fear will not go. Fear will be there. Then it may be able to penetrate, even though the patient's attitude and everything is not going to change. Someone is using hymenectomy also. I never understand the role of hymenectomy in vaginismus patients. Hymen may be intact or anything, whatever it may be. Hymenectomy is not advisable for vaginismus patient.
Thank you, sir. I would like to request Dr. Jignesh Mehta, sir, to come on the dais and please felicitate Dr. Ajay, sir. Dr. Jignesh Mehta, sir, is a dermatologist. He is a consultant attached to VishwaRaj Hospital. Please, sir. Thank you, sir. I should request Dr. Jignesh sir to felicitate Dr. Ravindra, sir. Please, sir.
Please come.
Thank you, Jignesh, sir. Thank you, Ajay, sir. Move on to the next lecture, Dr. Prasanna Gadre sir. The topic will be Bhagavad Gita approach to treat the performance anxiety in male and females. For this session, I would like to request Dr. Girish Kakade sir and Dr. Makarand Dongre sir to come on the dais to chair the session. Girish Kakade sir. Dr. Girish Rokade sir is a rheumatologist. He is attached to VishwaRaj Hospital, Sahyadri Hospital, Jupiter Hospital. He did his MD Medicine and DNB Rheumatology. He has many papers and posters in national and international conferences. Dr. Makarand Dobre sir is a consulting physician. He works in a Lonand. He runs around 25-bed hospital with ICU setup. I would request our chairperson to introduce our speaker, Dr. Prasanna sir.
Hello. Is this on? I'm audible because of my voice fatigue. Actually, I'm taking aid of the two mics. Not this, the other one. Performance anxiety.
Hello. Another interesting lecture, post-lunch session. We have heard, sir, pre-lunch session also. Dr. Prasanna Gadre, sir, done his education from BJMC Pune, and now he is in 29 years practice in skin and sex genitourinary medicine. Pre-lunch session, we had a very interesting lecture by him. So over to you, sir.
Sorry for the technical wait and the technical delay. Next. No, sir, don't. Yeah, we are getting it. Yeah. Thank you. That yeah, you can switch off that light, both the halogens, and please give me that focus in the corner. Because remember, friends, sorry, yeah. The reason is that again, audience में कोई भी performer हो, face दिखना बहुत ज़रूरी है. Because थोड़ा अजून जास्ती चालेल. Is it okay for the audience? मेरे को कोई problem नहीं. I am used to it. Yeah. So the technology is for us. We are not for the technology. For any performer. Again, imagine hypothecation that if this is not working, then what the speaker is supposed to do? Have the contact. Anyway, directly. So, Bhagavad Gita, chapter that is 18 verse 6, which deals with karma, that is the past life and the karma that is present. Now, few things at the outset. Number one, recent advances is our topic, but Bhagavad Gita is 5,000 years ago. Then how come this is applicable? The reason is Bhagavad Gita is the truth. It is reality. And what is truth? That is which is a universal constant, which doesn't change with respect to time, place, person, context, reference. Okay? So, chirasthai jala apan म्हणतो. Point number one. Second thing, I have not read Bhagavad Gita, but I know and I have used in my life chapter 2, 46-47 verse, which is a subset of chapter 18. अध्याय 18 श्लोक 6. Point 3 to be noted. I am not going to talk anything spiritual or mythological, but absolutely practical, application oriented, and this I am saying with conviction because that is what I have done in my life. Unknowingly. When I came across the references, I realized, oh, I am living my life in this way. Not in a great sense, you will come to know. So I usually never have performance anxiety, or rather, touch wood, thank God, I don't know what performance anxiety is. Okay. The original name of the topic is Bhagavad Gita Approach for Performance Anxiety, from bedroom or bed to boardrooms via business, batting pitch and beauty pageants. So this is applicable for everything. So let's move ahead. So just chill with 7 points. Now the thing is that initial topic, which was private parts, I had to be quite exhaustive. I myself, I like to dig. And because छोटा है, मगर उससे जुड़े हुए subjects बहुत है. This is just the reverse. Actually, you will feel performance anxiety is the chunk and a bigger part of the practice. But this will be a very focused talk. Why there is a performance anxiety? What's the main cause? Whether in the bed or on the batting pitch, in the business, in the interview room for promotion, in the examination hall of MBBS, or at the viva voce, which we have confronted. What is result orientation then in performance anxiety? What negative cascade or phenomena we get in these two things? That is performance anxiety or result oriented approach. So the most important thing, which is a game changer, is what kind of a change or a shift in focus should be done so that the performance anxiety goes away. See, even one of the greatest performance anxieties which many people have, and which has all the representative fears from death and of uncertainty and every damn thing, is mancha bhay, stage related fear. And most of the people I have seen, facilitators from the corporate I am seeing, who teach Rangamancha बोलायचं कसं, 3 things are important. The content of the speech, the skills, but the final and the most important is confidence. I focus on that. And I have made up my model from reading so many things, which works because, not because of me, but because it is logical. It will give that result only. And the result is getting the confidence. And when we will get, why the confidence is not there? Because fear is there, anxiety is there. Why? So we have to make them fearless. Confidence will get generated. Because on the stage also people say, कळलं आम्हाला, content छान पाहिजे, style, पण तिथे जेव्हा येतो ना आम्ही, तेव्हा गडबड होते. मग ते बेडवरही तसंच होतं सगळं. All intellectualization, rationalization is there. But dear doctor, when I actually land up in the bed, कळलं पण वळत नाहीये आणि वर पण जात नाहीये. So what then? So that is what is important. And here the shift of focus, style, positions, content of sex, just like that of stay, will come later. What is important is become fearless, निर्भय, निडर, अभय. मग आत्मविश्वास जागृत होतो. कसं असतं की why things backfire is because कलश में अगर गटर का पानी है और उसमें गंगा जल भर दिया तो it's going to backfire. पहले गटर का जो पानी है ना वो बाहर फेंकना पड़ता है और फिर गंगा जल भरना पड़ता है. So the fear and anxiety should be out first. The confidence will automatically come in. What is the difference between then goal orientation and result orientation? And this is the shift. Okay. The Bhagavad Gita approach to decrease PA, that is performance anxiety. So what should be the goals in any kind of sexual interaction or transaction? So why there is a performance anxiety and what is its cause? The only thing is result, result and result. We have become result-oriented human beings. Right from the beginning, I will tell you how. And what is result ultimately? Whether erection hoga ya nahi hoga, ejaculation hoga ya nahi hoga, non-consummation, consummation होगा या नहीं होगा. So what is that? That is an outcome. That is a consequence. It might happen. It need not happen. It might happen partially. So what is the result orientation in performance anxiety? Now I will be telling you something called as a grammar of psychology and psychology of grammar. So what's that? So the first is, see how the grammar of psychology and psychology of grammar has evolved. Result orientation's पहिला content, adjectives. Oh, what's the definition of amazing sex? We had an amazing sex. Oh, we had ekdam bakwas kind of sex. Use of adjectives. Why you are coming fast? Use of adverbs in sexuality by partners. The wife or the girlfriend asking, किती पटकन झालं रे तुझं ejaculation? किती fast? Prepositions of time. Grammar of psychology, psychology of grammar. कल हुआ, आज भी होगा, परसों होगा. हमें तुमसे प्यार था, आज भी है. तो हमें इरेक्शन का प्रॉब्लम था, कल भी था, आज भी है और वापस परसों भी रहेगा. Then degrees of comparison. On the katta, I can give 4 shots. What about you? Oh my God, I can give only 2 to my ladachi girlfriend. मेरा इरेक्शन तो पूरा 180 डिग्रीज में होता है, जो कभी होता ही नहीं है एक्चुअली, अगर बोलते हैं लोग. तो मेरा तो सिर्फ 90 डिग्रीज या 100. सो कंपैरिजन्स, सेम थिंग. भला तेरी कमीज मेरे कमीज से ज़्यादा सफ़ेद कैसी? मर्सिडीज तुझ्याकडे, मगाशी मी म्हटलं, यू हॅव गॉट 99% मार्क्स, I got 97. Okay, so everywhere it is there, and all zero sex life. Okay, so we move on to further. So this started happening, the performance anxiety from our school days. Okay, and mark किती मिळाले, grades किती. Parents, teachers, and entire education system is responsible to make us result oriented, give us performance anxiety in everything, and hence in the bed for sex also. Because from 0 to 100, there are 101 possibilities. 1 to 100, 1 out of 100 to 100 out of 100, and 0 out of 100 are 101 possibilities. And I have counted, if integers are taken, 398 possibilities are there. Okay, half, 1/4, 3/4. So, to what degree my erection will happen, doctor? Yesterday इतना पावर कितनी आ जाएगी, कितनी रिजिडिटी होगी, वगैरह वगैरह. So you can remember NAC et al. NAC accreditation म्हणतो ना आपण. So all these things, that is the adverb, adjective, comparison. Okay, and the emotion, I will come to that, the emotional part, and the nouns also. We label people, isn't it? अरे हा काय असाच आहे, तो काय तसाच आहे. So N for noun, just to remember the acronym. Now what is the negative, and one more thing, yeah, an interesting thing, N also stands for number. Now I will tell you how these things happen. 20 lakh years ago, we got our opponents' policies, the only primate, the only human being in primate which has got opponents' policies. No other animal has this. That is the reason counting started. That is the reason complete prehensile grip, whether it is for masturbation or holding the penis, which is like a tool or a rod, okay, or for anything, or even for the dexterity of the hand. And then we started measurement. So it is because of counting. What is today's world? Information. A person who has information, who is having information first in today's world from the OTT, he will score over you. And counting has started. So we have become number oriented. Everywhere there is a number, and that's why it's a performance anxiety. And म्हणजे जे आपलं सामर्थ्य आहे, तीच आपली आता मर्यादा झाली आहे. कशी? किती नंबर ओरिएंटेड होतो बघा आपण. फ्रॉम द बर्थ अपगार स्कोर. तुझ्या पोराचं किती, माझ्या पोराचं किती. तुझं माइलस्टोन काय पोराचं, माझं माइलस्टोन माझ्या पोराचं काय. देन after from 3 years to almost 21 years or whatever, 15 years, 10, 12, मार्क किती IIT, NEET, अरे काय चाललंय, किती प्रेशर त्या मार्कांचं. आफ्टर दॅट 15 to 30 or 25, how sexy you are, 36, 24, 36, six-pack abdomen, number oriented. After that, from 25 or 30 to 60, 65, पैसे किती कमवतो. ते मेडिकल कॉलेजला हुशार होता, प्रॅक्टिस किती तुझी, पेशंट किती येतात, नंबर बोल नंबर. उसके बाद में 60 के बाद उल्टा हो जाता है. हाँ, भरा मेरा कोलेस्ट्रॉल, बीपी, थायराइड, शुगर तेरे से कम कैसे, and then how many years of life I am surviving. So number, and the number is the problem. So the moment we become result oriented and number oriented and all the grammar and the psychology, question of doubt immediately arises. समजा झालं नाही इरेक्शन किंवा लवकर इजॅक्युलेशन झालं किंवा संभोग नाही झाला तर काय, नॉन कन्झ्युमेशन और इन्फर्टिलिटी में सेम थिंग. 14th डे बिकम्स फ्रायडे द 13th. त्याचंच टेन्शन. ओके, मेकॅनिकल सेक्स होऊन जातो. ओके, टेन्शन ते राहतं. सो क्वेश्चन और डाऊट, अँड देन वी आर फिजियोलॉजिकली अँड इव्होल्युशनरी totally primed and wired our brain for 60 lakh years that the fear response comes out. See the beauty of the neurological system. Imagine that the entire neurological system is for sex and for all other things. And imagine that our trunk is like an amoeba. Then the locomotion and sex controlled by, from that point of view, I am coming to the human spinal cord. And these two hands and legs are like the pseudopods. Then you go up, then the controls of the system, as you know, central axis मध्ये होतं हा सगळं, medulla oblongata and the vagus. The vagus, there was initially along with the spinal cord, evolutionary sympathetic chain came first, because sympathetic chain was important either to go away from the predator or hunt the prey. Relaxation was naturally, और आफ्टर द सिंपैथेटिक सिस्टम केम, देन केम द वेगस नर्व. वरच्या आल्यानंतर वेगस ऊपर से आती है. अभी उसका क्रेनियोसेक्रल आउटफ्लो बाद में हो गया, शिफ्ट हो गया. देन मेडुला ऑब्लोंगाटा के पास बेसिक फंक्शन गए. देन व्हाट एज पर द फ्रॉइड, ओके, व्हाट इज इंपॉर्टेंट, पेन, प्लेजर, रिवॉर्ड्स, एंड इफ आई वांट टू सर्वाइव आई शुड बी ऑन अ हाई अलर्ट, फटकन. And I should be having the drives. See the beauty. Thalamus, pain, hypothalamus, drive, the basal ganglia and the nucleus accumbens stria ventricularis for the pleasure reward, and niche amygdala. So all are in very close loops. Then came the limbic system with the parenting and the mammals. And then the side brain, cerebellum was there. And finally, the angulate gyrus, the ventral part, the dorsoventral and the dorsolateral part of the prefrontal brain now does two things. It takes the entire input of interoception, and it is also a center of word, concept and cognition of sexuality. So ये पूरी chain है, उसमें सबसे पहले fright and fear response, and that gets triggered the moment the question is there, and there is no gap. Okay, so freeze, flight, flop, fawn, fight. Now what happens again? So there is the stress because of this, and the feeling that everything is gone, hopeless, no erection, so sex and our relation is hopeless, useless, worthless. And then the irrational thinking and the cognitive errors, let us not go detail. नीचे से ऊपर तक आया मैं अभी. Human error, and the human error of action is, instead of coming to the sexologist, the well qualified, the patient goes to the quack. So that also happens in the stress. And then what happens? Nani durawa ho gaya in the relationship, and the emotions come. All the patients are having these fundamental emotions. Remember that jealousy is a sexual emotion found in other animals also. alpha male fight and competition. But as I told you, in private parts, because we are covering the parts, if they get open, shame, shyness and guilt. Animals do not have guilt, shame or shyness. They do not have any shyness or shame coming on the stage because they are private parts and nude bodies are not covered. Nange se khuda darta hai, everybody is nude in his or her own clothes. So, shame, guilt and emotions are strictly human emotions because of civilization. And all these emotions the person is having, we have to ask and then address every emotion. And what is Nani Durava ho gaya because of performance anxiety in the relationship? Na is Naraji, Ni is Nirasha, Du is Dukha, Ra is Rag, Va is White Vatna. Nani Durava ho gaya. Okay. Acronyms. So what is the shift in focus should be done? And that is the importance. So this is the difference between the goal orientation and the result. Right side there is a goal, right hand side there is a goal. Goal is a goal post. Goal is not result. Left hand side is result orientation. Whether the arrow after leaving my bow or the bullet after leaving my gun, or when the patient is thinking or the couple is thinking, then the semen after leaving the penis, whether it will hit the ovum or not in infertility. Okay, same thing. So goals are unfortunately converted into results. The arrow can hit the center, give you 100 marks, and concentrically coming centrifugally out 80, 60, 40, 20 and miss the target. And that's the reason why in corporate trainings, when I also go, which is my parallel profession, medicine, dermatology, sexology, aesthetic medicine is my prime profession. I tell them that please do not be patient OPD, or rather in our case, but in corporate case, don't be target oriented, be customer oriented. Customer shi bandhan kara, okay? Because the laws of marketing are the laws of our life, are the laws of life. 1,000 seeds you plant, 100 will sprout, 10 will grow into plant, and 1 tree will make you rich with fruits. Meet 1,000 people, 100 will plant to give you order, 10 will give you order, the customers, and 1 customer will make you rich. So, target, so much pressurized in corporate. And our generation people between 30, 40, 50 are getting heart attacks and dying because of that. So, we should be goal. So goal is customer relationship. Target ho jayenge na. To waisa hi hai. So what is the difference between goal orientation and result orientation? And now here comes. So Dronacharya asked Arjuna, काय दिसतं रे तुला? Arjuna म्हणला मला फक्त डोळा दिसतो. He was goal oriented. Had it been that Arjuna would have said that I am thinking whether my arrow will hit the eye, the bird's eye, or the head, or the trunk, or the tail, or miss it, Arjuna would have been result oriented. He would have got tension, stress, pessimistic, nahi झालं तर मग काय? And then he would have started getting tremors of his hand and miss the target. And you know why the tremors of hands are there? Okay, in anxiety, because in the jungle there are 2 choices. Either I attack or I run away. Escape or pounce. So tremor is nothing but evolutionary alternative reaction between antagonistic muscles. Thar कापणे is what? It's a play of antagonistic muscle. मग अर्जुनाचा हात थरथर कापला असता आणि मग काय झालं असतं? मग त्याचा बाण मिस झाला असता. And the same thing happens. What happens is when in all types of performance anxieties from interview to bed, I am saying that basically the sympathetic reflex is there, isn't it? Now the thing is that because of the sympathetic reflex, the muscles get tightened and the blood is shunted, you know, and there is no blood because it's a die or do situation. So the no blood to the throat, so घशाला कोरड पडते. No blood to the prefrontal brain, काही सुचतच नाही, block बसतो. These are the things which happen. And see, the gammat baga kashi hai, in erectile dysfunction, it is because of the parasympathetic system, isn't it? The person should be relaxed. But if person is becoming result oriented, he gets stressed, he gets a sympathetic high which is opposing a parasympathetic system. And in premature ejaculation, sympathetic, it's a sympathetic, isn't it? It's a because of the sympathetic nerves, there is an ejaculation. So then also he is stressed. And that's why he ejaculates more faster. So he khari make hai. So apart from all the other therapies, what we should tell them is make the shift. But Arjuna was also a victim of that. And in actual Mahabharata, Arjuna became result oriented from goal orientation. He lost his goal. And Gita is a counseling of Arjuna done by Krishna. And when Krishna gave him the realization, what is your role? Okay, here your role is a wonderful intimate partner, not a person. Okay, erection to ho jayega, ejaculation ho jayega. Aap intimacy ke partner ho, iski realization rakho. That is important. And Arjuna was in despondency. He gave up. I told you to give up everything. आणि मग शस्त्र खाली ठेवले. So the same thing happens with the person. The erection drops down. Shastra niche rakh diya. So one has to be goal oriented. Yeah, last 5 minutes. What should be the goals in sexual interaction? So we should tell the patient, this is the most important slide, togetherness and sexual companionship. आजकल कोई पुणे रहता है हस्बैंड और वाइफ गुड़गांव में रहती है या हैदराबाद में, तो होगा कैसा टाइम? एंड क्वालिटी टाइम वगैरह ठीक है, मगर क्वांटिटी ओनली ब्रीड्स क्वालिटी. ओके, सो there are different ways to tell them, but how they should increase the togetherness. Experiencing soothing mutual touch. Our primate human bodies, due to evolutionary changes, are made in such a way that we are having face-to-face and front interaction, and all other animals do not have skin. Now this I am telling you as an evolutionary dermatologist. We have lost our body hair because we got our sebaceous and basically sweat glands, and sweat glands were there. So we had a trade-off for thermoregulation. Okay, and since the hair went out, the skin became more erotic. So tell the patients, and that's why the touch, ultimately what is sex? Sex is the highest level, the deepest level, the most intimate level of touch. The word intimacy comes from the word intima, endothelial intima. इंटिमा म्हणजे सगळ्यात डीप, सगळ्यात क्लोज, सगळ्यात जवळ, आणि म्हणून एंडोथेलियमला इंटिमा म्हटले, अपार्ट फ्रॉम थिंग्स लाईक आर्जेनिक ॲसिड अँड नायट्रस ऑक्साईड. सो टच, सो we have to tell that humans should make the sex more sexy or sexier. मनाचा स्पर्श आणि स्पर्शातलं मन ओळखायला शिकवा. Deepest, closest, okay. Enjoying mutual body, psychological nudity, openness, so as to be your natural self. Being one in spiritual, philosophical and all these senses. Go with the flow. Don't think, okay, ovulation होईल, कधी होईल, होईल ना, बरोबर की नाही. नातं एन्जॉय करा. Engulfing other. Be an amoeba and engulf your loving partner in love eddies. Transacting, interacting, communicating, TIC, sexually. To convey the feeling, experience, expression of belongingness of each other with a notion that all of mine as a body, an entity is yours, and all of yours as a body, an entity is mine. So sex, what is sex ultimately? It is a celebration of relationship and using intelligence and aesthetics for its enhanced high. Okay, celebratus means repeatedly assemble and participate to honor, glorify, praise solemnly and demonstrate the joy. And again I tell you, basically we have to use something called as an existentialism. The existentially, the life or the cosmos is, it's going on. हम आते हैं जाते हैं. Okay, nothing spiritual, it's practical. What spirituality is there? Spiritual is just a name. Okay, so that is what is important. That we are powerless. We get power incidentally. Uncertainty we should embrace. Death is around us. It's just the time. Death is around everybody of us. So don't fear death. If the person stops fearing death, he will stop fearing everything. Fear of uncertainty. Then as I told you, okay, that fear of deficiency, teach them to have abundancy feeling. As I told you, अरे भाई तेरा amputation तो नहीं हो गया ना पेनिस का, पहले स्लाइड में जो मैंने आपको पहले टॉक में बोला, या congenital malformation पेनिस का तो नहीं है ना, तो ठीक है जितना है, okay, and of course those CBT techniques, REBT. And so that is karmanyevadhikarasya ma phaleshu kadachana. So the translation is action without expectation of fruit of action. And action should be goal-oriented action. And fruit of action is result. Okay, so these are the fruit of action. So instead of having the fruit of course the therapy should go on, but the thing is we should be on the intimacy. And now the last 2 slides. So tell them to have a Gujarati thali approach, enthusiasm, okay? And that is very important. And orientation or the play schema. So Gujarati thali में ठीक है ना भाई, all or none क्यों करने का है? हाँ, आमरस नहीं है ejaculation का, या जल्दी से आता है तो बाकी का खा लो ना यार, चंकिंग करो सेक्स में, बराबर कि नहीं? या पूरी जैसा बड़ा पेनिस नहीं है, बाकी का एंजॉय करो. या वजाइनल लुब्रिकेशन कड़ी की तरह नहीं है, बाकी का एंजॉय करो ना. कड़ी नहीं, आमरस नहीं, पूरी नहीं, इसलिए बाकी की थाली भी नहीं, ये क्यों? And places where performance anxiety can occur. So here, okay, instead of marks oriented, ask the student to be knowledge oriented. And instead of interview, okay, connection is more important other than I getting the promotion. Promotion ho jayega. In the boardroom, how I can be a good team member and synergism. That should be the goal rather than opposition. Okay. Money I have told you. Instead of money, enjoy whatever you are doing. Same with the business plan and with the cricket pitch. See, after 90 runs, okay, after 90 runs, because of that 100 result orientation, the person gets stress anxiety and he does mistakes. Concentration focus जाता, he is clean bowled, slip में catch देता है, desperately run out हो जाता है, ये कुछ न कुछ होता है. But once he crosses the 100, again चौके छक्के शुरू हो जाते हैं. And yeah, this was Mr. Kamri. And that on the stage, don't think of whether, I always have this thinking. आपको टॉपिक लगेगा अच्छा, नहीं लगेगा, पसंद करेंगे, नहीं करेंगे, अच्छा बोलेंगे, नहीं बोलेंगे, ये रिजल्ट है. I enjoy my audience, I respect my audience, and I enjoy my talk because I am having goal orientation, and that is the crux of it. Okay, so with that, and the last thing I will go with Sachin Tendulkar. Read all his interviews. Okay, he has always said that I have gone there to enjoy the game, enjoy. He never had said as regards record, because had it been that Tendulkar or Virat Kohli would have thought of records and numbers, they would have got victim of performance anxiety and they wouldn't have made any records. They are totally goal oriented, their goal and focus, and cricket is their passion, their उनके जहन में है. तो फिर एक बार जहन में हो गया, आई एंजॉय पब्लिक स्पीकिंग, जहन में है, तो फिर क्या रिजल्ट आता रहेगा. करेक्शन इंप्रूवमेंट टेक्निक्स तो होते ही रहेंगे, एंड एक्सपीरियंस. ओके, सो दैट्स इट.
Thank you, sir. It was a pleasure listening to you. We can take 1 or 2 questions. Okay. Now I request Dr. Suraj Ingwale sir to come on the dais and felicitate Dr. Prasanna sir. Dr. Suraj Ingwale sir is a head of the department cardiology in VishwaRaj Hospital. I request Dr. Ingole sir to illustrate Kakade sir. Please, sir. Thank you, Kakade sir. We request Dr. Suraj Ingole to felicitate Makaran sir. Thank you, sir. Thank you, sir. We'll move on to the next topic by Dr. Sushma Kunji ma'am. Topic will be, oh, it's paining, stop. For this lecture, I would like to invite Dr. Amar Shinde sir, Dr. Shivaji Bharati sir to chair for this session. Please, sir. Dr. Amar Shinde sir is a consultant psychiatrist. He is attached to the hospital. He is the director of Jagruti Hospital, Pune. Dr. Shivaji Bhati sir, he is an obstetrician gynecologist. He is the director of Riddhi Siddhi Medical Foundation, Chintamani Hospital. He is the director of Bharati's Life Care Hospital, Hadapsar. Thank you, sir. I would request our chairperson to introduce our speaker.
Thank you. It's pleasure to introduce Dr. Sushma Kunjir. She is MBBS, MD, MR, COG, consultant gynecologist and obstetrics. She has done MBBS and MD obstetric gynec from GMC Goa and having gold medal in OBGY in 2012. She is also member of Royal College of Obstetrics and Gynecology since 2019, London. Fellow of Reproductive Medicine, Nadkarni Group of Hospitals at Vapi, Gujarat. Fellow of Laparoscopy, KL School, Germany and Galaxy Care Hospital, Pune. Trained in ultrasound in obstetrics and gynecology from Chikitsa Hospital, Mumbai. She is ex-junior consultant of Goa Medical College, ex-junior consultant at Korean Nursing Home, Chennai, ex-junior consultant at Dinanath Mangeshkar Hospital, and also currently consultant at VishwaRaj Hospital, Loni Karbhav. So I welcome her, and I think she will deliver us a very good talk on recent Yes. Thank you, ma'am.
Thank you, sir, for the kind words. Oh, it's painful. Stop. Sex should be a pleasurable experience, isn't it? But pain during intercourse is very common. Nearly 3 out of 4 women have pain during intercourse at some time during their lives. For some women, the pain is only a temporary problem, while others, it is a long-term issue. So today I'm going to discuss here female sexual pain under the headings definition, epidemiology, risk factors, etiology, clinical features, diagnostic, evaluation, red flags, and treatment. So what is female sexual pain? It is actually a vulvovaginal, which is superficial or deep pelvic pain that is either provoked by or exacerbated during a sexual contact. In 2015, the 4th International Consultation on Sexual Medicine classified female sexual pain as female genital pelvic pain dysfunction. It has a negative impact on women's health, self-esteem, relationships, quality of life, and work productivity. Genital pelvic pain dysfunction must have persistent or recurring challenges with at least one of the following criteria. First, pain with vaginal penetration. Second, marked vulvovaginal or pelvic pain during genital contact. Third, marked fear or anxiety about vulvovaginal or pelvic pain in anticipation, during, or as a result of genital contact. Fourth, marked hypertonicity of pelvic floor muscles with or without genital contact. Coming to epidemiology, in US, the prevalence of FSP is around 10 to 20%, while WHO said global prevalence of painful intercourse ranges from 8 to 21%. What about India? This is a article which I found in 2018. A study was done by AIIMS in North India, where they studied 560 women for a period of 6 months. 82% had female sexual dysfunction. 82% is a large number, and most of the Indian population never talk about it, and none take treatment, out of which 56% of females had actual sexual pain. What are the risk factors of female sexual pain? They can be classified as biological, psychological, and socio-cultural. Biological being pelvic floor muscle hypertonus, pelvic inflammatory disease, poor physical health, previous abortions, vaginal delivery, female genital mutilation. Psychological being anxiety, depression, stress, history of sexual abuse. Socio-cultural, relationship dissatisfaction, being too religious or lack of privacy. So coming to etiology, etiology can be either non-identified causes, which comes under idiopathic, or identifiable causes, which can be classified as anatomical, hormonal, traumatic, inflammatory, neurological, neoplastic, and psychosocial. So the most common anatomical cause being myofascial pelvic pain syndrome, which I am going to come shortly. Next is infectious causes, candidiasis, sexually transmitted infections, and pelvic inflammatory disease. And others. Hormonal causes in premenopausal age group can be intake of oral contraceptive pills, progesterone-only pills, endometriosis, postpartum dyspareunia, and hyperprolactinemia. In postmenopausal, it is genitourinary syndrome of menopause because of vaginal atrophy, traumatic obstetric perineal injury, pelvic perineal surgeries, and female genital mutilation. Inflammatory, which are mostly autoimmune, are vulvar dermatosis, which is more common. Neurological causes are post-herpetic neuralgia, pudendal and other peripheral neuropathies, fibromyalgia. Neoplastic being malignancies, and psychosocial being relationship stresses like argument, being workaholic, abuse can be mental, physical, or sexual, anxiety, depression, and vaginismus. So what is the unidentified cause? It is classified as localized vulvar pain syndrome. So pain is localized to the vulvar vestibule with or without the clitoris, absence of any identifiable cause, duration of at least 3 months, and pain elicited just with pressure point testing. The hypothesis for this is, in view of any infection or trauma which initiates local inflammatory response, and in susceptible women, the inflammatory response causes proliferation of nerve fibers which are more sensitive to pain, and this leads to central sensitization of pain. Next, coming to most common anatomical cause, which is myofascial pelvic pain syndrome, which is a chronic pelvic pain syndrome that is defined by short, tight, tender pelvic floor muscles that can include palpable nodules or trigger points that cause referred pain. Palpation of trigger points is the hallmark of myofascial pelvic pain syndrome and is diagnosed upon any two of the following: a taut bend, a hyper-irritable spot, referred pain, and accompanied by high tone of pelvic floor. This can be associated with other syndromes like fibromyalgia, interstitial cystitis, now known as bladder pain syndrome, and irritable bowel syndrome. Pathogenesis is that because of previous trauma or repetitive traumas can cause high intensity stimulation of motor end plate of pelvic floor muscle, resulting in hypotonus and formation of trigger points. Pain can be anywhere from pelvis, vagina, buttocks, thighs, hips. It can be overactive bladder also can be there, along with constipation, dyspareunia, and dyschezia. Symptoms can be continuous or episodic, acute or chronic. The pain is often worsened with specific positions and increase with stress. What about vulvar dermatosis? We see this commonly in our OPD. Okay, the commonest being lichen sclerosis, lichen planus, and lichen simplex. In this, there is these are all autoimmune phenomena where in lichen sclerosis there is loss of anatomy and narrowing of the vaginal introitus, which makes sex painful. While in lichen planus, the erosive variety comes with erosion of the labias plus the vagina, which can make sex painful. Genital urinary syndrome of menopause, which occurs because of less estrogen in this age group, leading to vaginal atrophy. It is also seen after surgical removal of ovaries, premature ovarian insufficiency, and temporarily during postpartum period or during lactation and due to hypothalamic amenorrhea. Coming to female genital mutilation, I'm lucky not to see such cases in OPD. So they are type 1, type 2 and type 3. Type 1 where the clitoris is cut, type 2 excision of the labia majora, and type 3 is closure of the labia minora to seal the vagina. This is a very common practice, mostly in African countries. Coming to diagnostic evaluation, history is the main thing which needs to be taken properly, because getting history becomes difficult in Indian scenario because they don't open up to sex and sex related issues. So history can be taken in a sensitive manner. Pelvic pain assessment form and female sexual function index I'll be showing you. Then comes physical examination. Swabs, culture, tissue biopsy, imaging are used to rule out other causes. Now, what are the pearls for open communication when you take a history? You should be in partnership with the patient, have empathy. You should apologize for unmet expectations, respect their sufferings, legitimize the concerns, and support the patient. This is very important. So CDC has given us a guide to taking a sexual history. I know most of the gynecologists, they don't usually, they miss, patients don't speak out. So in this, there's a dialogue where there are many questions which you can ask the patient. You need to take permission before you ask a sexual history. Like, may I ask you a few questions about your sexual health and sexual practices? At this point, in the visit, I generally ask some questions regarding your sexual life. Will that do? Is it okay? I ask these questions to my other patients also, irrespective of their age, gender, and marital status, because this helps me in my diagnosis. So this, whatever I talk today in my clinic will be kept confidential. This is how you have to gain the confidence so that the patient opens up towards sexual history. Coming to pain during sex. So you need to ask, when does the pain occur? Is it before the contact, during, or after the contact? If it is before the contact, it can be anxiety or it can be vulvar pain syndrome. If it is just at the start of just at the genital contact, superficial, then it can be either because of infections, vaginitis, or provoked vestibulodynia. If it is deep inside pelvis, it can be PID or endometriosis. Where is the pain located? You need to show the pic and ask the patient where exactly is the pain located. Another important question is, was the onset of pain associated with specific events like after childbirth, any surgeries, trauma, or sexual abuse? What is the characteristic and pattern of pain? Is there any tingling, burning, sharp pain? Is it cyclical, non-cyclical? Cyclical, usually with endometriosis. What is the duration? What is the severity, which is measured by visual analog score or Marinoff dyspareunia rating score, which is 0 to 3. 0 means no pain and 3 is intense pain which will interrupt intercourse. What are the aggravating and relieving factors? Sexual history should also include about the first sex, subsequent sex. Does she avoid sex because of the pain? Is it the same with other partners also? And also whether she is having anal sex, sex under influence of alcohol, drug, etc. Relationship questions are very important, like how is your relationship with your partner? Is he supportive? Is there adequate sexual knowledge, technique? And one more important question, are you safe in the relationship? This is, if you suspect domestic violence, this is the one question which you need to ask. I'm just showing a pain assessment form. So this is pelvic pain, International Pelvic Pain Society has given us a history sheet where there are lots of questions. This is visual analog score marking. This is a map where you tender points are marked. Surgical history, other histories also need to be asked: menstrual, medication, obstetric history, family history, GIT history, health habits, urinary symptoms, and even abuse and coping mechanism needs to be asked. So coming to pelvic examination, most of the patients are anxious, uncomfortable. They will not allow pelvic examination, but it is our job to convince them. Okay, pelvic examination can exacerbate previous trauma. Then we need to know the previous pelvic examination experiences. Education is the most important. You need to educate them, teach her the anatomy with picture or a mirror during examination. Verbal consent is important. Agree to stop if she requests. Ask the woman if she would like to bring a support person or an electronic device to listen to music. Examination can be completed over several visits. Okay, inspection, sensory examination, single digit palpation. If that is possible, then comes bimanual and speculum examination. So in inspection, you need to see for complete lower back, abdomen, asymmetry in gait needs to be noticed, and rule out infections, trauma, or any congenital problems. Vulvodynia assessment can be done by cotton swab examination of the vulva at different points as shown in the figure. This is also vestibule cotton tip test. Vaginal single digit examination is the most reliable method for evaluating pelvic muscle tenderness and trigger points in myofascial pelvic pain syndrome. The patient is asked to squeeze and contract using single digit to assess the muscle strength. Effort is made to identify scars and previous surgery scars. Bimanual and per speculum examination will tell me pelvic masses, discharges, scarring, etc. What about lab test and imaging? Ultrasound and all are done to rule out other causes like pelvic mass, lab test for STI, urine analysis, biopsy. What are the red flags? The most important, domestic violence, where you need to refer the patient. Female genital mutilation, vulvar dermatosis if one is not experienced to treat, and suspicion of malignancy. Treatment. Aim of treatment is to reduce sexual and genital pain and to restore and improve sexual function. So what are the general measures? Patient education. It is a multidisciplinary approach. Perineal hygiene has already been discussed. Lifestyle modifications, healthy diet, avoid alcohol, smoking, drugs, psychosexual counseling, and treatment of comorbidities. Treatment of identifiable cause like STIs, vaginitis, and endometriosis needs to be done. Commonly local anesthetic agent like lidocaine is used. Vaginal lubricants can be given to such patients, and vaginal moisturizers. Treatment of genital urinary syndrome of menopause involves estradiol cream, which is given in the dose of 2 to 4 gram, applied daily for 1 or 2 weeks, and then 1 gram applied for 1 to 3 times per week for maintenance therapy. Lichen sclerosis. Here the superpotent steroid ointment is given for 3 months in a tapering doses. Further maintenance also is required in such cases. In case of failure, we can use tacrolimus 1% cream. And some resistant cases, you need to rule out squamous cell carcinoma, which can be less than 5% associated in these cases. Same with erosive lichen planus, you give a super potent steroid ointment for 3 months in tapering dose. Next, coming to genital mutilation, the type 3 needs minor surgery where you do defibulation and you correct it before if they are experiencing dyspareunia or before childbirth. Vulvar pain and myofascial pelvic pain syndrome. Here also it is a multidisciplinary approach. You need behavioral modifications and topical lubricants, vaginal moisturizers can be used. Pelvic floor physical therapy is done to increase awareness of pelvic muscle, improving relaxation techniques, normalizing the tone, and providing stretching stimuli at the introitus. The approach is often multimodal and encompasses techniques such as EMG, electrical stimulation, manual tissue manipulation, stretching exercises, and use of dilators. Psychosexual counseling involves cognitive behavior therapy, sex therapy, and couple-based therapy. Medications which are available, there are topical, oral or injections, topical, lignocaine and hormone therapy, medical, antidepressants can be given, neuropathic pain medication in severe cases, Trigger point injections are also available if the patient do not respond to the initial management, which involves injection of bupivacaine and triamcinolone. Sacral neuromodulation in refractory cases. There is also onabotulinum toxin A, which appears to be helpful, but it is temporary. The relief is only for 3 to 12 months. There are also gabapentin creams, amitriptyline-based creams, and mast cell stabilizer creams available. The last thing which can be done is vestibulectomy in cases of vulvar pain, which is effective in some, but later on it can cause scarring and again dyspareunia. So the take-home message being, like mental health, sexual health carries a lot of stigma. Mental health is slowly losing the stigma, and sexual health needs to follow that trend. We can look at these things as health conditions and normalize having this conversation as a part of our regular healthcare. Sensitization of patients as well as gynecologists is necessary to treat this problem. Learning and acquiring knowledge about the subject will improve our approach to manage such cases. Thank you.
Thank you, ma'am, for enlightening us on this topic of female sexual health. I think as a psychiatrist, we are having lots of sexology patients, but I think Dr. Pense will also agree that we are finding less female coming for the sexual help. They are not asking ki I am having anorgasmia or any other problem or pains. Okay, what are the problems? So patients are coming very less. So I think we need to educate the.
They think pain is normal in sex, so they compromise over it. Because I always try to ask about sexual health in my history, and I come to know lots of problems which they encounter in their sexual life.
Yes, one question from me. For menopausal age group, are you using intrauterine devices, hormonal devices here?
No, I just use estradiol cream.
Because we have one patient, she came from UK, she is having that device.
They have it outside, but I don't think so in India it is available. We use estradiol cream only.
Any other
and
question?
Also, if she has other symptoms.
Answer the question. I am also a gynecologist. Now, when we are talking about intrauterine devices, it is doesn't show any results because a lot of papers are there, people are using it, but it doesn't affect in menopausal lady. In perimenopausal lady, yes, in somewhat it do affect, but in menopausal it doesn't has any effect.
Thank you very much, sir. Any question?
Thank you, ma'am, for your able talk. I would like to request Dr. Anirudh Garud, sir, to come on the dais and felicitate Dr. Sushma Kunjir, ma'am. Anirudh Garud, sir, is head of the department pathology in VishwaRaj Hospital. But extra Dr. Anirudh Garud, sir, to felicitate Dr. Amar Shinde, sir. Thank you, sir. I will request Dr. Anirudh Garud to felicitate Dr. Shivaji Bharti, sir. Thank you, sir. And to move on to the next lecture by Dr. Apurva Datta, The topic is female sexual arousal disorders. For this lecture, I would like to request Dr. Himanshu Pense sir to come on the dais. Dr. Himanshu Pense sir to please come on the dais to chair this session. Dr. Himanshu Pense sir is a senior consultant psychiatrist. He is practicing since last 14 years. He is a joint secretary at Asst Medical Association and visiting consultant in the Regional Mental Hospital, Erwada. I would request our chairperson to introduce our speaker, Dr. Apurva Datta sir.
Hello. Yeah. First of all, I want to thank VishwaRaj Hospital, Dr. Tabrez and Dr. Khandale for organizing such a wonderful conference, a 2 days full conference on sexology. I think it is a need of a time, and it is an honor to be here on the dais of a wonderful institute and a well-crafted conference. Now let me introduce the faculty for the next lecture. Dr. Apurva Kumar Datta, who is MBBS MS Gold Medalist, FIOG, FMAS, RCOG Associate. And I think he's from Jharkhand, and he was the chairman of last year's Foxy conference.
Yeah, I am also the chairperson elect for the Sexual Medicine Committee Foxy.
Yeah, congratulations,
yeah.
sir. Thank you, sir. He is also medical director, Sri Durga Clinic and Fertility Center, Dhanbad, National Coordinator for Sexual Medicine Committee, National Coordinator for Foxy CME.
Thank you so much, sir. I think...
Over to you, sir.
Yeah. Being the second last lecture of a conference, itself is a boring. People are actually very much flooded with all the topics since morning. But I would like to arouse you from the dysfunction of not having the arousal. I'm trying to do that. So, my dear friend, we are celebrating the 75 years of independence, the Azadi Ka Amrit Mahotsav. Let's take a place today so that we free our women the suffering from the sexual dysfunction. So, what is female sexual dysfunction? Female sexual dysfunction included the low sexual desire or reduced libido, the diminished arousal, orgasm difficulties, and pain with the sexual activities. The prevalence, yes, it is very high. Indian data, not available. But believe me, because previously the chairperson has stated that they are not getting the female sexual problem. The reason being, the female sexual problem, they are actually prefer to go to their friendly OB-GYNs. And actually, we gynecologists are getting these type of patients. That was my basic agenda for my tenure, which is start in January, to give a basic information to each and every 40,000 gynecologists all over the India to have the basic knowledge of about the female sexual dysfunction, so that our women is benefited and they will not suffer silently with this dysfunction. So that is, now many a time when I give a talk on this female sexual dysfunction in any obs and gynae, lecture, they are saying, why Apur, why you are choosing this type of topics? Now, I always used to tell them, previously it was the maternal mortality, now it's coming to the respectful mortality. Previously it was the abortion care, now it is the respectful abortion care. So my dear friend, the sexual dysfunction is not only about to remove the dysfunction, but it is about the improving the quality of life. Believe me, I have made a lot of, avoid divorces in the family due to this sexual dysfunction. So this is as important as maternal mortality, this is as important as infertility, this is as important as any other branches which we gynecologists or which doctors we are practicing. So this is my thing. Now when we are talking about the DMS criteria, previously there is a sexual arousal disorder, then sexual desire disorder, these are separate. Now they have clubbed, and actually the female sexual disorder is divided into three. First, sexual interest and arousal disorder in one. Second, the orgasm disorder, which and third is the genitopelvic pain penetration disorder. Now, what is the female, interest arousal disorder? It is characterized by absence of or a decrease in the sexual interest, initiation of the sexual activity, pleasure, thoughts, and fantasies, absence of responsive desire, and or lack of subjective arousal or of physical genital response to the sexual stimulation, either non-genital, genital, or both. Now, what does this mean? This means when a patient is coming with you, how will you diagnose that whether she is a case of the arousal interest disorder? So there is a set criteria, and the criteria is that if the 3 is present out of these 6, we consider it as a arousal and interest disorder. What are the 6 points? The first, there is either absent or decrease in the sexual interest or erotic thoughts and fantasies. And the other 4 are either absent or decrease in the initiation of the sexual activity and responsiveness to the partner attempt to initiate it, excitement and pleasure during the sexual activity, arousal in response to the sexual cues like written, verbal, visual, and sensation during the sexual activity, whether genital or non-genital. So the point is, if the 3 out of this is present, then we consider it as a sexual arousal interest disorder. But many a time, last month I have a patient, on the first night, they are unable, because the female is unable to perform, and she said, I don't have that interest to have a sex today. So the next day, the couple visited to me, and, Algat Gagri Chalkat Jai. She has, Google it and say, this may be some problem in my wife. So it is not that if there is only once it happens, we consider it as an arousal interest disorder. This should be experienced at least 75 to 100% of the time, and a minimum period of 6 months, and actually it's caused a distress in the relationship. If this is present, then we call it as a dysfunction. Now, what are the etiologies? Etiology, psychological factor like anxiety, depression, distractibility, low self-estimation, low communication. For example, a young lady not willing to marry, she is very career goal oriented and forcefully married. Then these type of patients are coming with these symptoms. Now, unrewinding sexual relationship, physical factor. Many times, the females are the passive partner. So they are thought of that they are the only sex toys. So they are not rewarded. So there is some problem of the arousal interest disorder. The physical factor like fatigue, disability, genitourinary symptoms, especially in premenopausal and menopausal symptoms. Certain drugs like SSRI, the anti-epileptic, beta blocker, excessive alcohol, chronic disease like diabetes, very common nowadays. Hormones like fluctuation, reduction in the testosterone level, hyperprolactinemia, hyperthyroidism or hypothyroidism, inadequate sexual stimulation and wrong setting, and treating the other sexual dysfunction. Like, for example, if the partner having the sexual dysfunction of like a premature ejaculation or the erectile dysfunction, there may be a secondary arousal interest disorder in the female. Now, how will you classify? Classify is either lifelong, that is, she is noticed this as soon as she is sexually active, or acquired. That means previously it was normal, but now it is, she have difficulty in arousal and interest. Now, other classification is the generalized or situational. Generalized, this involves the symptoms in any situation, any stimulation, and any person. Situational, in a particular specific scenario. For example, suppose that a combined family, not very well-to-do family, small houses, they didn't have that personal space. So these type of patients are coming with the arousal disorder, and simply just asking them to have their own personal space is actually treating their problems. So we all know that we have certain chemicals chemicals locha in our mind in each and every. So we have a neuromodulators. Some neuromodulators are excitatory, some neuromodulators are inhibitory. Certain excitatory pathways like dopamine, norepinephrine, melanocorticones, oxytocin, estrogen, and testosterone. These are the excitatory pathway. When there's increase, it cause the excitement is cause the interest. There's the inhibitory pathways like serotonin, opioids, endocannabinoids, prolactins, and progesterones. When these actually increases, it cause the arousal and interest disorder. So how to evaluate this? Now, the recognize the underlying condition contribute to reduce the desire and arousal. The major relationship and physical issues should be asked. So history is very important. Now the problem here is, we gynecologists especially, we have to, our OPDs, 50, 60, 70, 80s OPDs are there. And now we have to do cesarean, bhaiya labor room mein wo chilla rahi hai. We have to do hysterectomies, we have to do IVF, we have to do IUI, we have to attend the webinars, we have to attend the conferences. So we are actually not giving much time to the history taking. This comes to problem. So we have to ask them, we have to give them personal space and ask them about their issues. How the onset is, what is the duration, what is the behavioral adaptation, what is the level of stress, etc. So close evaluation of the patient's medical history, the comorbidities, nowadays very common, even young age diabetes are very common, and these are actually many times when there is no symptoms of diabetes and the patient is coming with arousal interest disorder, we just simply do a thyroid profile or do prolactin profile or do diabetes. It's turned out to be, it is actually the secondary due to increase in those comorbidity which cause the arousal interest disorders. So we have to asked about the comorbidities. And yes, I already stated there is certain drugs. So we asked our cardiologist friend, we asked our urologist friend to change their prescription to those who are not causing the arousal interest disorder. Now, evaluation, we have to take the complete gynecological history, any STDs, any history of sexual abuse, sorry, urinary or bowel complaint, and the prior surgery. Why urinary and bowel complaint? Because in case of deep endometriosis, nowadays very common, it causes the pain during having the intercourse. And actually it is due to the endometriosis which cause the pain, and due to the pain, it causes the interest and arousal disorder. So these all are vicious cycle and interrelated. So we have to very vigilant about asking the history. Now, psychiatric disorders, in particular depression, anxiety is very important. Oral contraceptive pills. Now, this is again very important because many a time patients are coming and they are taking the OCPs for like 10 years in a shot. So what it happened, it caused somewhat vaginal dryness and reduces the secretion of the cervical glands. So it caused, the dryness of the vagina. So when there is a dryness of the vagina, it causes the pain during the sexual intercourse, and it is leading to the secondary arousal interest disorder. So how to examine? According to our history, we have to give a specific test. I already stated the thyroid, the prolactin, these are things. Now, being a gynecologist, I already stated what mera dukhra aap logo ko maine sunaya, what I have to do the cesarean, I have to do the hysterectomy. What actually I am doing, I have a set a pattern of the questions. So when my patient is waiting outside, my attendant is giving them their form, which actually have to write them yes, no, or what's the problem. So before the patient is coming, when the paper is with me about their history, I got a idea what is their problem. So this actually made my job very easy and actually reduces a lot of time. So this is again a screener is there. So this is sexual desire screener, and it has a 5 question, yes, no, and according to the questions, we have to either it is a generalized, it is acquired, or there is a no sexual disorder, or possibly there is. So this is very important, and I think all those who are dealing with the female sexual dysfunction, they should have this screener in their OPD so that to evaluate and to diagnose this case. Now, what are the investigations? We already stated the testosterone level, estradiol level, progesterone, LH, FSH, prolactin, TSH. These are the laboratory tests which should be done. Now, what the treatment? Now, it is always a multidisciplinary approach. Sexologist, pain specialist, counselor, psychotherapy, physical therapists are involved in that. Education is very, very important. Counseling is very, very important. I think in my practice, it's a 90% cases where there is some problem. You know, I have a patient of unconsumable marriage. What is the, if there is some quarrel between the groom's father and bride mother. So due to that conflict, they have their mind. So go to the history. It's very, very important, and mere counseling is very important, and give 2 to 3 minutes extra and your job will be done. So education is very important. Cognitive behavioral therapy. Now what is cognitive behavioral therapy? I will just take 30 seconds. The cognitive means there is some belief or some thinking of a patient, and that's turned into their behavior. For example, in perimenopausal lady, a lady is coming with a 45 years old, and the husband is saying she is not interested. When I am asking about the wife about why you are not getting into sex, बोले भाई मैं तो दादी बन गई हूँ, I have the grandchild, now thinking of about sex, chichi, it should not be there. So this type of, we have to counsel them that sex doesn't has an expiry date, and you can have a sex even last day of your life. So these counseling are having very important, and it's improved the therapy. Sunset focus, we all know it's entirely separate topics, but we all know it is the non-genital touch with or without clothes. Secondly, genital touch. Third, application of the lubricant. Fourth is the mutual touching. And fifth is the consensual sexual intercourse. So these are the 5 points. The hormonal therapy, yes, I am using testosterone a lot. A lot of IVF doctors are using it, and it has a benefits, especially when the testosterone level is low. But many times I have seen even the testosterone level is low, and patient is using that, they are getting benefited. Now DHEA. These are the 3 drugs which I am using in my practice. First is the testosterone. Second is the DHEA. DHEA, what is that? It is the off-label use. It is the dihydroepiandrosterone. It is used. Now, it is basically used for increasing the AMH level in case of infertility treatment. So the recommended dose is 100 milligram. But India, it is found either 75 milligram and 25 milligram. Believe me, I am using 75 milligram. When the weight is less than 60 for the 3 months, it's really improved a lot of their cognitive and the sexual behavior. So this is very important. And if you want, then you can mix 75 plus 25, that's come to the 100 milligram. Now, bupropion, yes, it is again, what is this? This is the non-epinephrine dopamine reuptake inhibitor. As I already stated, that is dopamine is the excitatory pathway. So anything which increases the dopamine in the body, it acts in a interest and arousal disorder. So this is the thing. The third is the sildenafil citrate, 25 milligram. We all know the pink pill. I am using it. It increases the vascular blood flow in the vagina, and thus improving the sexual arousal and interest. And I am using it for 3 months, and it has result. The main problem is 2 things with the sildenafil. First is the blue vision. Again, very important. When the patient is taking it for a long time, whenever they go outside, they have the blue vision. Second is the headache. So I always ask them take it in the evening time. So it benefited. Now the devices, Ajay sir has beautifully demonstrated in the morning his own device that how to stimulate in case of arousal interest disorder. And flibanserin, fortunately flibanserin is the only medicine which is approved by FDA for the perimenopausal patients. It is available in India definitely, but not freely available. I am not using it. The main side effect of that, it causes the hypotension, especially the postural hypotension. So we have to refer the patient if there is a contributing comorbidities are there, if there is a lifelong sexual disorder, anatomical deformity, you have to send it to our gynecologists, so correct the anatomical deformities. The physical and psychological trauma, we have to send to the psychiatrist to have the counseling, and if there is a treatment failure. So what is the take-home message? The take-home message is the sexual health is important for the quality of life. Female sexual dysfunction is very common. Sexual functioning can be affected by illness, surgery, medication. Assess medico, psycho, social, and relationship factor to detect the cause and treat accordingly. Simple history taking, asked about the desire, arousal, orgasm, pain, and also asked about the male sexual dysfunction is very important. Treat the cause, educate about the anatomy and physiology of the genital function, remove the myths and misconception, and treat not the patient but the couple. Thank you so much.
Thank you, Apurva. Dr. Apurva, the lecture was really arousing, and I'm sure looking at your energy and enthusiasm, the audience has also aroused.
Thank you so much, sir.
Any questions?
Now we have to arouse them, then only they will ask.
No, I have two questions.
Yes, sir,
Yeah.
sure.
Considering first scenario where a female comes from a very orthodox, conservative and religious family, where she hasn't developed confidence, or she's hesitant to initiate or show interest into sex, or she hasn't developed the thought process of having sexual fantasies. So can we categorize such female or such client as a sexual arousal disorder?
Sir, first of all, I'm really, because I'm from a very small place, okay? And even the gaon ki gori are much more smarter than the shahar ki chodi. Believe me, है ना? Even they are coming with the sex problem with us. Even I have one patient from the village, and they are coming and they are saying, I am a sexually active. I am not going to marry with my sexual partner, and now I want to tighten my vagina. So this is actually what we are thinking is not like that. But suppose that if these type of patients are coming in any ways, now the counseling, I always stated that they are not aware of their even own anatomy. So this is very important to educate them. So education is very important, and when these type of patients are coming, and I already stated that it should be for minimum for the 6th period when their sexually activity started. So if it is a 6, if it is fit in criteria, then we should ask them, we should consider it as an arousal interest disorder. But many times when there is some confusion, nowadays the couples are very smart, the husband is really very smart, and they educate. If not, they are coming with us and we educate them and the problem is solved. So that is the thing.
Why I asked this question is because I had 2 clients who had specifically mentioned they were from they were going through for years together since their childhood through some sort of religious practices.
Absolutely.
And they specifically pointed out that because I am inclined more towards the spirituality and religiosity, I really don't get that thoughts or that interest into sexual activity.
So I'm just saying, yes, if it is fit in the criteria, you can gradate it. But in this type of cases, the counseling part is very, very important. Second, I always used to ask my patient, you can have Sunny Leone photo in your bedroom, but don't put Hanumanji bedroom photo in your bedroom. Put Hanumanji photo where it should be, that is in the puja ghar. So your room should be like that. So it is very important to have this arousal. Okay, भाई भगवान का पूजा करना आप सुबह करो, भाई दिन भर अगर या तो आप करो या तो आप छोड़ के सन्यासी बन जाओ, है ना, योगी बाबा जैसा. Or if you are there, then you should have to that. So this is the thing, sir.
And the second scenario, suppose a partner, male partner, he's so sexually overactive, and he's demanding sex, every now and then. Can it cause a negative impact or the stressful impact on the female partner, and that can lead to a arousal and interest disorder?
Absolutely. I have many of such patients which are actually have when the patients, the females are coming and they are saying that husband is demanding more sex. Even दोपहर में भी आते हैं तो they wants to have the sex. In the night में भी आते हैं, they want to have. I have to look after the kids. I have to look after my in-laws. I have to look after the household and what to do. Now we all know, sir, you are a psychiatrist. We have a aversion syndrome. So probably in that case, the husband should be treated. So sexual intercourse, you can't gradate it as having sex twice in a week is absolutely normal, and twice in a day absolutely normal if it doesn't distress the relationship of the couple. So if there is a distress in the couple, that means there is a problem in the sexual dysfunction. So I think in that cases, first we have to ask many times, what happened, which my patient are there is a 5 or 6 kids they have. So there is a, lax vagina, and there is a dry vagina is there. So see, avoid that sexual part. So this might be caused, so we have to take the detailed history. Is it is actually the husband which is demanding more sex, or it is the wife which is actually not interested to have sex? Then only we are able to treat that. So,
thank you, sir.
Thank you, sir. Thank you, sir. Yes, sir. Absolutely, sir. Absolutely, absolutely. Absolutely, sir. Absolutely. And one more thing which I am usually, the tech couples, husband, wife, both are working. So many times they are so much exhausted. So I always advise them to, have the sexual intercourse in the early morning. There is a natural erosion. Arousal is there. So in the night when they are very much, thaka hua hai, they are tired, they are not able to perform, I always ask them to have the early morning sexual intercourse, and many times patients are applying that and they are got benefited with that. Yeah, that's absolutely, sir. Thank you, sir. Thank you so much.
थैंक यू सर. अगर आयोजकों की अनुमति हो तो सिर्फ आधा मिनट लेना चाहूँगा. Sir, I have written few lines. I'm going to dedicate it to you and
you
for
so
your
much,
wonderful lecture.
Thank
you
you so
for your
much, sir.
wonderful lecture. And of course, ये एक दर्द है मेल पार्टनर का, जिसके पार्टनर को, फीमेल पार्टनर को सेक्सुअल इंटरेस्ट एंड अराउजल डिसऑर्डर है. एक्चुअली में गदरे सर ने जैसे कहा था, वो परफॉर्मेंस एंग्जाइटी की वजह से मैं स्पेक्स भूल आया हूँ. तो अगर कुछ शब्द पढ़ना गलती से पढ़ा मैंने, तो मुझे मैं कोशिश कर रहा हूँ मेरी आँखों को अराउज करने का और ढंग से पढ़ने का. तो ये कुछ ऐसा है. मैं श्रृंगार रस से सराबोर, मैं श्रृंगार रस से सराबोर, वो प्रणय से सिहोर. मेरी चाहत उसमें डूब जाना, उसकी आदत बस किनारे रहना. मुझे आलिंगन की प्यास, उसे सिर्फ कर्तव्य का एहसास. मुझे चुंबन की आस, उसकी मायूसी भरी सांस. मैं सावन का भंवर, मैं सावन का भंवर, वो रेगिस्तान की लहर, वो रेगिस्तान की लहर.
वाओ सर.
Thank you.
सर सारा कॉन्फ्रेंस एक तरफ एंड आपका सर ये बात एक तरफ.
A disclaimer: there is no offense intended towards a female partner.
सर एक कहावत था, पुरुष कल भी आभारी था, आज भी आभारी है, कल भी आभारी रहेगी. महिलाएं कल भी भारी थी, आज भी भारी है, कल भी भारी रहेगी, और 40 के बाद ऐसे ही भारी हो जाती है. With all the respect to all the females.
Thank you, Abu sir. Now I request Dr. Sangram Gadge sir to come on the dais and felicitate Dr. Apurva sir. Sangram Gadge is a cardiac anesthetist at Asst Hospital. He is also a full-time ICU consultant. Thank you, Apurva sir. I request Dr. Sangram to felicitate Dr. Himanshu sir. Thank you, sir. Thank you, sir. We'll move on to the last lecture of this session, conference, by Dr. Sanjay Dhangar, sir. Topic will be role of lifestyle medicine in sexual medicine. I would like to request Dr. Sandeep Kharat, sir, and Dr. Nitin Lokare, sir, to please come on the dais to chair this session. Sandeep Kharat sir, he is a consultant orthopedician practicing in Urodi Kanchan. He is associated with the Gandhar Hospital. He has a special interest in joint replacement and trauma care. Nitin Logre sir, he is a senior consulting physician in HOD-Critical sir. He is the director of Mahesh Hospital. I would like to request our chairperson to introduce our speaker, Sanjay Dhangar sir.
Hello, good evening all. Welcome to the last lecture, I think. I congratulate VishwaRaj Hospital for arranging a nice conference today. So, lifestyle is a very important part. If you improve the lifestyle, there will be no medicine. So, lifestyle is very important, and this is also important in patients with sexual disorders. So, Dr. Sanjay Prakash Dhangar, he is MBBS DNB Urology and Chief Urologist as Andrologist Pune. Dr. Sanjay Prakash Dhangar graduated from Mahatma Gandhi Institute of Medical Sciences, Swargam, Wardha. He did his super specialization in urology, Ruby Hall Clinic 15. He is a member of editorial board of many urology and reproductive medicine journals. He has associated membership of 40 surgical urology scientific professional societies and organizations. He has received many honors like FACS, FMAS, FAIS, and many more. And over to you, sir.
Thank you, sir, for your kind introduction. I am not going to discuss much of the all discussed topic till now. I am just so lifestyle medicine is nothing. It's how to change your current living lifestyle to change your life. Most of the things related to lifestyle medicine, previous speakers they have discussed. So I'll just stay everything related to the sexual function. So for the optimal sexual function, everybody needs to aware about how his or her body works, how they eat, how they behave, how are they active, what are they doing at their working place, and the way their body and mind respond, and many more things. So everything is related to how your mind works and how your body behaves, or it is vice versa. The unfortunate truth in the current situation is that many of us, in fact many among the doctors, they don't know much pay attention to their body. Everybody is busy in their work, busy in their numbers. As Gadre sir said, numbers, numbers and numbers, all result oriented. Everybody is running. So sometimes it's like when you get a signal on a highway, you reminded, yeah, I was on 120 speed. I would have been a bit slow. Same is the situation when a 30-year-old young man comes to me with an erectile dysfunction. Everything is normal. everything is fine, no comorbidities. But all of a sudden, he came, doctor, I'm about to marry in a year, and now I'm having this problem. I don't have any wrong habit. I don't smoke. I don't go to parties. Still, I have all these things. So again, I discussed in all the previous all topics. Everybody's stressed upon the history. Here again, the history is he was working on a computer, sitting for 8 hours, sometimes late nights, eating, sleeping, office work, no activity, in fact, no physical activity, and no healthy food. There was a study that came from Europe and America that if a younger man develops erectile dysfunction, it could be a sign of a future heart attack or a cardiovascular event or a cerebrovascular event in a near future in next 5 years. So whenever I have such patients, apart from my routine investigation, I try to send that patient to a cardiologist for further evaluation, or in fact basic evaluation is done by me only, and then I send the patient to cardiologist. Being a surgeon, I am speaking on medicine, sexual medicine, lifestyle medicine. Years back, even I had few problems that suggested that surgery is not the final answer for many things in the medical field. In fact, if you change the way you are living your life, you can get your answer. Sometimes you may get your nirvana if you focus on yourself. So coming to sexual medicine, these are the basic things in the sexual life that we will get if we have a healthy habits and good lifestyle, and or we changes the way we live. Increased libido, improved sexual life, good erections, no female sexual problems, no arousal problems, a healthy heart, healthy overall, everything. Now, so what to change and what may happen with all wrong lifestyle habits? This is first, weight management. So obesity in itself is a disease. When I was in second MBBS, I saw a book with one of my PGs that was completely on obesity only. I was surprised this could be such a big topic. But now, at this stage of my life, females 7 to 20% chances of having coital pain, arousal problems, lubrication, sexual dissatisfaction, and many more. Therefore, weight management especially needs attention. But yes, this is not a singular approach. You need a multidisciplinary approach. You need to involve a physician, dietitian, a physiotherapist, or a trainer, and something like meditation, yoga, and many things like in the previous discussion, it was told about psychotherapies, especially the cognitive therapies. So weight loss will lead to irrelevance to the sexual function, biopsycho and social improvement. Again, if a person is diabetic, there will be increased insulin sensitivity, increased plasma testosterone levels, good erectile function, and improved desire. In males, as we measure this IIEF scores, International Index of Erectile Function, so this function also improves. Next is the exercise, regular exercise. Most of us, till now, if we ask in the audience, 50% of the people will not be doing exercise. Completely busy in their OPDs, hospitals. I don't have time, coming late. I cannot find at least 20 minutes, 10 minutes for the exercise. Everybody is holding a bottle in his hand and saying, this bottle is not leaving me. So this is the situation presently with the practitioners as well as the patients who are coming with the sexual problems. Sometimes we have to let them see this problem, that the bottle is in their hand, not they are in the bottle's hand. So with exercise, there is increase in the level of sexual hormones as well as the endorphins in the brain. If you have a good heart, rest of the things will be happy. Your body image will improve. Individuals will feel better. There is no limit to exercise, but yes, those who want to do limited exercise, they have a limitation of 150 minutes per week or 30 minutes per day at least for 5 days in a week. Similarly, the physical activity should be a combination of aerobic, high intensity and cardio exercise. It should not be like you are doing only aerobic and aerobic or only a cardio exercise. These should be intermittent, or you can make them alternate. Aerobic exercises, HIIT, cardio exercise. You can do 90 minutes per week. Next, again, smoking. Here I will tell you few things. One is the nicotine in the tobacco. It's a potent vasoconstrictor. Vasoconstrictor means it will constrict each and every artery. Mostly people think of the heart only. But in man, if it comes to their sexual activity, if it comes anything over their penis, it's like there is a bombing over their head that yes, now what will happen? How will I perform? So tobacco, nicotine constricts the penile arteries also. Apart from that, the sensations are also decreased. Another thing, it is anti-androgenic as well as anti-estrogenic. So both male and female are affected. It's not like that male smokes, so male will be affected. Both males and female partners are affected. Males have problem with the erection and premature ejaculation, and females have the problem with the lubrication. Because of the dryness, there is dyspareunia. So if you quit smoking, there will be improvement in the libido, and automatically the sex life will be improved. Stress. Again, we are working round the clock, especially doctors, 12 hours, no time to sleep, no time for the family. Even we don't recognize that this is a silent killer who is killing all of us from inside. It is growing slowly as we start our practice after our final degrees. Slowly we stop giving time to our family. We start focus on the patients, money and the number of working hours. And then, like me, today I have 3 cases. No, 3 are not enough. I have to do 4. Then again, next day 5. So this will go on and go on. There is no end to that. So what happened with the stress? It raises the cortisol and adrenaline levels. Again, same. Adrenaline, vasoconstrictor. Cortisol, suppressing the sexual hormones. So what will happen at the end? All problems related to the sexual cycle. So how can you manage it? There are few ways. One is you can go with your friends. Sometimes going at some place far from your office, far from your hospital, sometimes out of the city, or you can have your own me time. If you don't find anybody, just enjoy yourself. Take your own time, enjoy, relax yourself, and then go back to your work. Probably you may get relaxed. And still, if something is there, you can have your good friend, or if you are alone, just start chucha chucha. People will come to you and will focus on you. Is there anything wrong? Then you can discuss your problem and you can get relieved. Then comes the sleep hygiene. This is one new term that we are using in lifestyle medicine. Sleep hygiene is not how many hours we are sleeping. It's all the way you sleep, the time you sleep, the environment of sleep. Everybody is busy, and whenever they are going to bed, the phone is in the hands. Last message, boss का message आया रहेगा. Boss ने क्या बोला है? Oh, hospital से I've got a message from a GP. Oh, there is a patient. If you set your limits, my limit is 10 o'clock. After that, I don't recognize what instrument is this, what device is this. Then you may recognize that you have a peaceful sleep. What I do is, I make my phone on silent. Internet is off. It is at least 6 feet from my bed. And another thing is, for last 8 years, I have not attended any single call at night from 10 to 5 o'clock. I'm completely away from my mobile. This is the part of the sleep hygiene. Then comes, you should not take alcohol at that time. You should not be under influence of any drug. No late night parties. Sometimes is a fine, but there should not be daily parties. And then comes the bedroom temperature, the bedroom environment. All should be pleasant. And you can have 6 to 8 hours of sleep. Alcohol. There is a myth that alcohol is a powerful sexual facilitator. In fact, it is not. In low dose, it causes euphoria, and people, they become more open or more receptive for sexual talks or sexual activity. But in higher doses, it has an opposite effect. It attenuates the sexual cycle. And again, it is a CNS depressor. So it's better to avoid. But yes, there was some study from the US and UK that wine in mild dose or in another form is beneficial, especially the red wine. But I will not suggest here that if you have to transfer from one alcohol to other, then you should switch on to the red wine. Not advisable, but yes, if somebody is having that, it is beneficial because of the flavonoids that are present in the red wine. Otherwise, it's not a good thing to have alcohol at all. Again, this is for tea and coffee. So caffeine in any form is not good. At least if you are taking it, limit the use and don't take it too much, cup by cup, if you find something like that. If you find a good friend, 1 tea, 2 tea and 3 tea, and then there is no limit. So don't do that. Then comes healthful eating. Healthful eating is you are eating all good things with a good taste. The only thing you should know how to make it. So a diet which is colorful, rich in antioxidants. This is like you can have all variety of fruits as per the current season, and then you can have vegetables and legumes. Different vegetables come in different colors. So week wise or day wise, you can choose the color and decide. In this way, everything will go inside your body. And special advice for those who are going with the dairy products, it's a big no, because dairy products, they have a lot of things that are not that should be avoided. One among them is an insulin dependent, insulin like factor that reduces the insulin sensitivity, and for a diabetic person, this is not advisable. So try to limit all the dairy products as much as low possible. And for reducing weight, you can go to the low carb diet, Mediterranean diet, or any other diet, but under guidance of a dietitian. Apart from that, if you are going for weight loss, don't just go by healthful eating only. Simultaneously, you have to start your stretching and muscle building exercises so that your muscle proteins are not loosened. Then comes, there are few foods that are acidic. There is a long list, but one example is pumpkin. Everybody must be knowing. Pumpkin is a food that is acidic. So in any body, that will create an acidic environment. So for that, those who are diabetic have to avoid acidic food, because diabetic body is already an acidic body. And otherwise, any individual not diabetic can have few acidic foods. Similarly, same is the case with alkaline water. You can have alkaline water. Just last 2 slides. This is socializing. So if you socialize yourself, you will get some knowledge about your body, some knowledge about your diet, some knowledge finally about the sexual function, and people may guide you to a sexologist or a person who is practicing sexual medicine, who can help you in all the sexual problems. This is like, थक गया हूँ यार, अब मैं क्या करूँ, मेरी कुछ समझ में नहीं आ रहा है. And then finally somebody comes, you find there, it's time to wake up, just get up. I have someone, I can tell you the name of person who will help you. So then you become ready. Yes, I am ready to do some changes in my body so that my body, mind and the sexual function improves. Finally, when you start doing, you say, I am depositing confidence in my saving account, not the money. And if you have confidence, definitely all functions of your body will improve. Not just money, everything will improve. This is just on a lighter note. How to burn your calories. There are many ways. So this happens at the end. Thank you very much. I am open for any health related queries.
Thank you, Dr. Sanjay Dhangar, for your nice lecture. So lifestyle is a very important part. If you improve your lifestyle, there will not be any medicine. As a physician, I tell the patient 25% of the treatment is by myself. 75% is by you have to follow diet, exercise, and some sort of a yoga and pranayama. So if you don't follow these three, 75%, there will not be any cure. Likewise in sexual dysfunction also, there will not be any cure if you don't improve your lifestyle. So any questions, audience?
Thank you very much.
Thank you.
Thank you, sir. I would like to request Dr. Suraj Ingole, sir, to come on the dais and felicitate Dr. Sanjay Dhangar, sir. But this VishwaRaj Hospital has been organizing this VRH GYAAN program since last 3 to 4 years, and every 2 to 3 months we have conferences with different topics: obstetrics, ortho, critical care, and now this time we had come with this new topic, central advantage in sexual medicines. Obviously, this event cannot be performed without any leader. Dr. Sanjay Dhangar sir is a organizing chairperson for this CME. Without his support and guidance, we will not able to complete this CME. He has been continuously behind us for since last 15 days to 1 month to organize all this event, to organize for each and every speaker, for their even transportation to stay, and that's why this conference able to do very smoothly. Once again, big applaud for Dr. Sanjay Dhangar sir. Would I request Dr. Suraj Ingole sir to felicitate Dr. Nitin Lokare sir. Please, sir. I request Dr. Suraj Ingole sir to felicitate Dr. Kharaj sir. Thank you, Kharaj sir. Thank you. At last, we are all thankful to the organizing secretary, Dr. Tabrez Pathan sir. He's a assistant to general manager operations in VishwaRaj Hospital. He's a organizing secretary. Without his continuous efforts, we will not able to accomplish today. I would like to request Dr. Suraj Ingole sir to please felicitate Dr. Tabrez Pathan sir. I would like to thank all the eminent speakers, faculty members, chairperson who are able to come over here for this CME from their busy schedules. Would like to thank to all the delegates. They are patiently listening for this conference. We are going to provide the certificates through email. Let me take the opportunity to thank all the managing team of VishwaRaj Hospital, Dr. Aditi Karad ma'am, Executive Director of the hospital, Dr. Santosh Pawar sir, Medical Director, Dr. Sachin Katkade sir, Assistant Medical Superintendent, Marketing Team, Dr. Doshi sir, Kiran Kulkarni, Amol Kharat, GM Medical Operations, Dr. Sudhir Uttam sir, IT team, media and photography. This concludes our 2 days CME conference. On behalf of hospital, I would like to promise that we'll next time come for the CME with new topics. Obviously, this is not going to be the end of today. This is going to be a new beginning for us. Thank you. I would like to thank Kamlesh Bagul. He's been behind this session continuously. Okay, without his continuous efforts, the session of these presentations would not be completed. Thank you, thank you, thank you.